Let's go over the warm-up review. First question, where are nicotinic acetylcholine receptors found in the body? So they're found at the neuromuscular junction, and then don't forget the autonomic ganglion as well. That's the first step in getting both the sympathetic and the parasympathetic nervous system, those nicotinic receptors in the autonomic ganglia. And also the adrenal medulla, which you can think of as just an overdeveloped, specialized sympathetic ganglion. Next, which drug category has each of the following endings? So operidol are neuroleptics, phenyl are the methylxanthines like theophylline, pterol are beta-2 agonists, triptyline are the tricyclic antidepressants, and zosyn are alpha-1 blockers. And the last question, what are the systolic heart murmurs? So you have mitral regurgitation, tricuspid regurgitation, aortic stenosis, pulmonic stenosis, mitral valve prolapse, VSD and possibly an ASD, hypertrophic cardiomyopathy, and then PDA produces a continuous machine-like murmur, so it's both systolic and diastolic. Now we're ready for the lecture.
Welcome to our Step 1 video on reproductive anatomy. Let's start with the male reproductive anatomy. We can review these structures by going through the pathway that sperm takes during emissions and ejaculation. Sperm are produced in the testes, which are found in the scrotum. Specifically, the sperm are produced in the seminiferous tubules of the testes. The testes are also where testosterone is produced. After the sperm are formed, they pass through the epididymis, which is the structure sitting on top of the testes. Next, the sperm travel through the ductus deferens, which is also called the vas deferens. This is what gets cut during a vasectomy. The ductus deferens passes through the inguinal canal as a part of the spermatic cord. It then enters the pelvis. It joins with the duct of the seminal vesicle to form the ejaculatory duct. Secretions from the seminal vesicle empty into the ejaculatory duct and mix with the sperm to make semen. The ejaculatory duct ends in this prostatic urethra, the portion of the urethra that's surrounded by the prostate gland. The prostate gland also contributes to the fluid in the semen. And then finally, the sperm will move through the urethra to exit the penis out of the urethral meatus. I'll just mention that bulbourethral glands, or Cowper's glands, sit here to produce mucus that enters the urethra for lubrication. So again, the pathway for sperm. It starts in the seminiferous tubules of the testes, then goes through the epididymis. Next, they travel through the ductus deferens, or vas deferens, into the ejaculatory duct, which empties into the prostatic urethra, and then the sperm travel through and out the urethra in the penis. Next are the layers of the penis. So, for the layers of the penis, starting from the outside and working our way in, you have the outer dermis, and then the superficial fascia, or Dartos fascia. This is continuous with Colles fascia of the perineum and the Scarpa fascia of the abdominal wall. Next is the deep fascia, or Buck's fascia, which is a continuation of the deep perineal fascia. And it's important to note that Buck's fascia separates the corpus spongiosum from the corpus cavernosa. You'll see that it forms a roughly looking figure 8 with these structures. And then there are 3 cylindrical masses of erectile tissue that are encased and separated by the tunica albuginea. The 2 corpora cavernosa, which are dorsolateral, and the corpus spongiosum ventrally. And then, deep within the corpus spongiosum is the urethra. Let's move on to female reproductive anatomy. So, you have the vagina and the cervix, and then moving up is the corpus, or body, of the uterus, the larger, rounder part. Bilaterally, you have ovaries, where oogenesis takes place, and where the female sex hormones estrogen and progesterone are produced. And then, in close approximation, are the fallopian tubes. After ovulation, the fimbriae will sweep the released egg into the fallopian tube, and then the egg will move down the tube and into the uterus. If fertilization occurs, it usually happens in the fallopian tube. There are a bunch of ligaments that help support these structures. Let's go through these. The cardinal ligament connects the cervix to the pelvic sidewall, so you can remember C for cervix and C for cardinal ligaments. This contains the uterine vessels. The infundibulopelvic ligament is also called the suspensory ligament of the ovary. It connects the ovary to the pelvic sidewall, and it contains the ovarian vessels. Don't confuse that with the ovarian ligament. The ovarian ligament connects the ovary to the uterus. It's derived from the gubernaculum, as is the round ligament of the uterus. The gubernaculum in males attaches to the testes and helps the testes to descend through the inguinal canal and into the scrotum. In females, the round ligament of the uterus comes off the side walls of the uterus, travels through the inguinal canal, and ends up in the labia majora. And then finally, we have the broad ligament. This is a double fold of peritoneum that covers the uterus, the fallopian tubes, and the ovaries, and it connects them to the walls of the pelvis. It also contains the ovarian ligament, the round ligament, and the infundibulopelvic ligament. So you can think of the broad ligament as being a large, broad ligament that basically covers everything. So again, the cardinal ligaments connect the cervix to the pelvic walls and contain the uterine vessels. The infundibulopelvic ligament, or suspensory ligaments of the ovary, connects the ovary to the pelvic wall and contains the ovarian vessels. The ovarian ligament connects the ovaries to the uterus. The round ligament of the uterus goes from the uterus through the inguinal canal to the labia majorum. And the broad ligament covers everything that connects the uterus, fallopian tubes, and ovaries to the pelvic wall. Let's talk a little bit about innervation of the pelvis. If you can remember only one nerve, remember the pudendal nerve. The pudendal nerve comes off of the sacral plexus, specifically S2, S3, and S4. The pudendal nerve supplies sensation to the perineum and the genitals, including the penis and the clitoris. It also supplies motor to the perineal muscles. This includes the muscles at the base of the penis that aid with erection, and the external anal sphincter, and the external urethral sphincter. The pudendal nerve can sometimes be damaged during surgery or childbirth, or sometimes you'll see damage to the pudendal nerve in professional cyclists. So what kinds of problems would you expect? Well, you can have genital numbness and pain, fecal incontinence, and urinary incontinence. It can also lead to erectile dysfunction in males. One way we can take advantage of the pudendal nerve is a pudendal nerve block. Remember that the pudendal nerve provides sensation to the perineum, so you can block that, and sometimes we do that during childbirth for anesthesia. You basically feel for the ischial spine, and then you use that landmark to inject a local anesthetic into the pudendal nerve. The pelvic region is also innervated by the autonomic nervous system, and this plays a role in the male sexual response, which we'll talk about next. So, sympathetic input and parasympathetic input both contribute to the inferior hypogastric plexus, which is also called the pelvic plexus. And then from there, you have a bunch of subplexuses that go on to innervate their target organs. One of these is the prostatic plexus, and this gives rise to the cavernous nerves. The cavernous nerves carry the parasympathetic fibers to the penis and are responsible for erection. And as you can see here, the cavernous nerves sit basically upon the top of the prostate gland. And this becomes important when you're performing a prostatectomy for prostate cancer. The cavernous nerves can get injured during that surgery, and that can result in erectile dysfunction. So again, injury to the cavernous nerves during prostate surgery can result in erectile dysfunction, because these nerves carry parasympathetic fibers. So now we go through the male sexual response. This is definitely high yield. And what we're talking about here is erection, emissions, and ejaculation. So let's go through each of these. I'm sure you all know what an erection is. Erection is mediated by the parasympathetic nervous system, and specifically, remember that cavernous nerves. How this works is the parasympathetic nerves release nitric oxide, which is a vasodilator. And the vascular smooth muscle cells of the penis, this nitric oxide activates guanylyl cyclase, which generates cyclic GMP. And then, through a couple of different steps, this cyclic GMP causes a decrease in calcium levels, and this leads to smooth muscle relaxation and vasodilation. So then, blood flow in the penis increases, and the corpora cavernosa fills up with blood, and the penis becomes erect. As a side note, this is where the drugs that treat erectile dysfunction work. Cyclic GMP is hydrolyzed by the enzyme phosphodiesterase 5. The PDE5 inhibitors, like sildenafil and tadalafil, inhibit the breakdown of cyclic GMP, so they facilitate vasodilation and erection. So erection is mediated by parasympathetic autonomic nervous system, but there's also a little contribution from the somatic nerve, the pudendal nerve. Remember, the pudendal nerve innervates the muscles at the base of the penis. This causes them to contract, and this helps to maintain that erection. And then you have emissions and ejaculation. Emission is when the sperm moves into the urethra and mixes with secretions from the seminal vesicles and the prostate gland to form semen. And then ejaculation is when the semen is actually expelled from the penis. Both emissions and ejaculations are mediated mainly by sympathetic nervous system. You get peristaltic contractions of the ductus deferens in the glands, and this will help move sperm and secretion into the urethra, which, remember, this is emission. And then the contraction will force the semen out of the meatus, and that's ejaculation. The pudendal nerve also helps here. Contraction of those muscles at the base of the penis will help with this expulsion. So the pudendal nerve does help a little, but what's important to know is the autonomic control. So remember, erection is mediated by the parasympathetic nervous system, and emissions and ejaculation are controlled by the sympathetic nervous system. The classic mnemonic for this is point and shoot. So point is the erection, and that starts with P, like parasympathetic. And shoot is the emission and ejaculation, and that starts with S, like sympathetic. Next, let's talk about the arteries of the pelvis. I don't expect you guys to memorize much of this anatomy right now. With any anatomy for step 1, you probably need to spend extra time with a video or an anatomy book. There's really no quick, easy way to memorize anatomy. But let's get going. First, we'll tackle the female pelvis. From the common iliac artery, the first branch to the left on this image is the external iliac artery. And the other branch off the common iliac artery here, this is the internal iliac artery. And from there, we have many branches, like the iliolumbar, the superior gluteal, and the lateral sacral arteries, for starters. Then, further down, we'll see the umbilical, and off of that, the superior vesical artery. Also, off the internal iliac, we have the obturator, the uterine, and the inferior vesicle, the vaginal, the middle rectal, and the inferior gluteal. Finally, the internal pudendal arteries. At the very bottom, we see the vaginal branch of the uterine artery. Next, let's go over the male pelvis. Again, we start at the top of the common iliac artery. The external iliac is off to the left of the image, and then we see the internal iliac with its many branches. Similar to the female pelvis, there is the iliolumbar, the superior gluteal, and the lateral sacral arteries at the top. From here, it gets a little bit different. Off the umbilical artery, we have the artery of the ductus deferens and the superior vesical artery. Next is a similar appearing obturator artery. And then there are the inferior vesicle and the middle rectal arteries. The inferior gluteal artery is similar, and then the internal pudendal artery will give rise to the inferior rectal artery and also the dorsal penile artery. All right, let's switch gears and talk about venous drainage of the gonads, so the testes and the ovaries. On each side, the ovary and the testes drain to the papiform venous plexus and into their respective gonadal vein. So the right ovary and the right testes drain into the right gonadal vein, and that goes directly into the inferior vena cava. But the left ovary and the left testes drain into the left gonadal vein, but that goes to the left renal vein, and then that goes to the inferior vena cava. So there's an extra step on the left. The left gonadal vein is longer, and because it has to make that extra 90-degree turn, where it can sometimes get compressed, there's an increased risk for pressure in the left gonadal vein, and that's why some varicocele are common on the left side. A varicocele is basically an enlargement in the papiniform plexus because of poor venous return. This is often described as feeling like a bag of worms in the scrotum. It gets worse with the valsalva, but it improves when kneeling flat. Lymphatic vein drainage is also important because this tells you where cancers or infections are likely to spread to first. So the ovaries and the testes, these drain into the para-aortic lymph nodes. The upper 2/3 of the vagina, the uterus, including the cervix, and the prostate, they drain to the external and internal iliac lymph nodes. The internal iliac nodes are also known as the hypogastric nodes, and they include a cluster known as the obturator nodes. The distal third of the vagina, as well as the vulva and the scrotum, these are your more superficial structures, so they drain to your superficial inguinal nodes. I want to finish by talking about two things that are sort of related to anatomy in this area: groin hernias and urinary incontinence. There are 3 types of groin hernias: indirect inguinal, direct inguinal, and femoral. Inguinal hernias are more common and they tend to occur in males. Indirect inguinal hernias are the most common type. Most of these are congenital due to failure of the process vaginalis to close. Basically, the processus vaginalis is an outpouching of the peritoneum. It descends into the scrotum and it covers the testes to become the tunica vaginalis. The rest of it is supposed to obliterate, but if it doesn't, it leaves a communication from the peritoneal cavity into the scrotum. And this communication can fill with fluid, becoming a hydrocele, or it can fill with abdominal contents, and this would be an indirect inguinal hernia. Indirect inguinal hernias protrude through a deep inguinal ring lateral to the inferior epigastric vessels, and then they pass through the inguinal canal and exit the superficial inguinal ring to enter the scrotum. Direct inguinal hernias result as a weakening of the abdominal wall, what's known as a Hasselbeck's triangle. This weakening can be due to things like increased abdominal pressure from constipation or chronic cough or heavy lifting. So direct hernias are generally acquired rather than congenital. Direct inguinal hernias go through the abdominal wall and Hasselbeck's triangle, medial to the inferior epigastric vessels. They exit out of the superficial inguinal ring. So what structures form Hasselbeck's triangle? It's formed by the inguinal ligament, the inferior epigastric vessels, and the lateral border of the rectus abdominis muscles. The third type of groin hernia is a femoral hernia. Remember, going from lateral to medial, you have the femoral nerve, artery, vein, and then the lymphatics in the femoral canal. That's navel, N-A-V-L. Well, femoral hernias protrude through the femoral ring into the femoral canal. Femoral hernias make up less than 10% of groin hernias, but when they do occur, they're more likely to be in a woman, and they're also more likely to cause complications. What complications do we worry about with hernias? Well, mostly we worry about incarceration and strangulation. Incarceration is where the contents from that hernia, usually bowel, get trapped and you can't reduce it. So an irreducible hernia, that's incarceration. When this happens, venous and lymphatic blood flow can get obstructed, so you can get edema, and eventually the arterial blood supply can be compromised. You can get ischemia, necrosis of the bowel, and that is strangulation. So a strangulated hernia is when you have necrosis of the herniated contents. Let's review hernias one last time. An indirect inguinal hernia enters the deep inguinal ring lateral to the inferior epigastric vessels and travels through the inguinal canal and then exits the superficial inguinal ring. Now, direct inguinal hernias go through Hasselbeck's triangle, medial to the inferior epigastric vessel, and then out the superficial inguinal ring. And then femoral hernias, they go through the femoral ring into the femoral canal. And remember that femoral hernias are more common in women. Okay, so now let's move on to urinary incontinence. The three main types of urinary incontinence are stress, urge, and overflow. Stress incontinence is the most common type, and it occurs due to weakening of the pelvic floor, usually after childbirth, so women who have given a vaginal childbirth. So these patients will leak urine when the abdominal pressure is increased, such as with coughing or sneezing. As far as treatments, you would recommend lifestyle modifications first, such as timed voiding, pelvic muscle exercises. The most famous pelvic floor exercises are the Kegel exercises. If those aren't effective, you can try a pessary, which is a device that sits in the vagina and helps to add support. And then surgery is an option for stress incontinence. Urge incontinence is due to overactivity of the detrusor muscle. So these patients will feel a sudden urge to go, and then they have to go right then and there. And a lot of times they won't make it to the bathroom. Again, you want to try lifestyle modifications first, but there are medications that can help, specifically antimuscarinics like oxybutynin and darafenicin. The last one is overflow incontinence. This occurs when someone is unable to void normally because of bladder obstruction or neuropathy. Since they can't void normally, the bladder gets overly distended, and then patients have continuous leakage or dribbling of urine. The treatment for this is to treat the underlying cause. Intermittent catheterization is possible if you can't find the underlying cause. That's the end of this lecture. Let's do the end of session quiz. Let's go through the answers. A professional cyclist develops decreased sensation in the genitalia and the perineal pain and numbness. Which nerve is most likely injured? That's the pudendal nerve. A 67-year-old man with prostate cancer develops erectile dysfunction after undergoing a radical prostatectomy. What nerves were most likely injured? That would be the cavernous nerves. Remember, they carry parasympathetic input, and that parasympathetic nervous system controls erection. Next question. Describe the autonomic control of erection, emissions, and ejaculation. So again, erection is mediated by parasympathetic nervous system, and emissions and ejaculation are mediated by the sympathetic nervous system. What do the following ligaments located in the fallopian tubes do? First, we have the cardinal ligament. This ligament connects the cervix to the pelvic sidewall. It also contains the uterine vessels. Remember, C for cervix and C for cardinal ligament. Infundibulopelvic ligament. This ligament connects the ovary to the pelvic sidewall, and it contains the ovarian vessels. Round ligament. The round ligament comes off the side of the uterus, travels through the inguinal canal, and then ends in the labia majorum. The broad ligament. The broad ligament is a double fold of peritoneum that covers the uterus, the fallopian tubes, and the ovaries. Remember, we said it connects these ligaments to the walls of the pelvis. The broad ligament also contains the ovarian, round, and infundibulopelvic ligaments. So remember, the broad ligament is a large ligament that pretty much covers everything. And what structures make up Hasselbeck's triangle? So it would be the inferior epigastric vessels, the lateral border of the rectus abdominis, and the inguinal ligament. Where are the pudendal nerves located? What is its function? And what is the landmark used when injecting local anesthetic into the pudendal nerve? The pudendal nerve comes off the sacral plexus, specifically at S2, S3, and S4. Remember, we said the function of the pudendal nerve is to supply sensation to the perineum and the genitals, including the penis and the clitoris. It also supplies motor function for the perineal muscles. The landmark used to inject a local anesthetic into the pudendal nerve is the ischial spine. Last question. Which type of urinary incontinence matches each of the following descriptions? Treated with antimuscarinics, like oxybutynin. That's urge incontinence. Occurs with coughing and sneezing. That would be stress incontinence. And presents as continuous leakage of urine. That's overflow incontinence. Let's go through the rapid fire facts. The main artery of the pelvis, that's the internal iliac artery. The main nerve of the pelvis, that's the pudendal nerve. And a bag of worms in the scrotum, that's the varicocele due to dilation of the pampiniform plexus. Okay, that's it for this video. We'll see you next time.
Let's do the Reproduction 2 warm-up. First question, what are the common side effects of beta blockers? So they can cause bradycardia, possibly cause some AV block. They depress myocardial contractility, so they might trigger some CHF. The non-selective beta blockers can cause bronchoconstriction, and beta blockers can mask the sympathetic symptoms of hypoglycemia. Next, describe how the murmur of mitral regurgitation is different from the murmur of aortic regurgitation. So the murmur of mitral regurgitation is holosystolic. It's heard throughout systole. It's heard loudest at the apex. It's heard best in the left lateral decubitus position, so you have the patient lying on the left side. And it's going to be enhanced by maneuvers like squatting and also by expiration. Then aortic regurgitation is a diastolic murmur, which is heard in the first part of diastole. It's usually heard best along the left sternal border, and this doesn't really have anything to do with the murmur, but remember that aortic regurgitation is also associated with a widening of the pulse pressure. And the last question, in which order of elimination, zero order or first order, would you see a linear decrease in the plasma concentration of a substance when plotted against time? Well, that's zero order, because in zero order kinetics, the rate of elimination of the substance is independent of the level of the substance. All right, now we're ready for the lecture.
Hello everyone, and welcome to our video on genital embryology. In the last video, we talked about reproductive anatomy. Now let's talk embryology. The embryology of the genitals is about a 4-star topic. You'll more than likely have a question on this. First, let's talk about the development of the kidney. We have 3 important structures: a pronephros, which degenerates early, and a mesonephros, which acts as the embryonic kidney for the first trimester, then degenerates, and a metanephros, which eventually becomes the adult kidney. But that mesonephros, that middle one, that eventually degenerates, it has a fully canalized duct system called the mesonephric duct. And right alongside that, you develop a paramesonephric duct. With me so far? The mesonephric duct, which is also called a Wolffian duct, is going to degenerate sometime after the first trimester. It's going away unless something induces it to stick around. And the something that would induce it to stick around and develop is testosterone. We'll talk about where that comes from in a minute. But for now, just remember that the mesonephric duct can become male genitalia under the right circumstances. So remember, mesonephric duct or Wolffian duct plus testosterone equals male. The paramesonephric duct is also called the Mullerian duct, and this will go on to become the female genital tract unless something inhibits it from doing so. The default developmental program is for the mesonephric duct to recede and the paramesonephric duct to develop into female structures. So remember, paramesonephric duct, also known as Mullerian duct, plus nothing equals female. Now, if you have a hard time remembering which is the mesonephric and which is the paramesonephric, think about this. The difference between the word man and woman is the prefix wo. The difference between the word male and the word female is the prefix phi. And the difference between the word mesonephric and paramesonephric is the prefix para. So the female always gets the prefix woman, female, paramesonephric. Pretty easy. And remember, the female pathway is the default. You have to induce the mesonephric ducts to make man parts. You don't have to do anything to induce woman parts. In fact, you have to inhibit the paramesonephric ducts from developing into a uterus. Let's talk some more about female development. The paramesonephric ducts develop into the fallopian tubes, the uterus, and the upper portion of the vagina. Let me repeat that. The paramesonephric ducts develop into the fallopian tubes, the uterus, and the upper portion of the vagina. What about the lower portion of the vagina? The urogenital sinus gives rise to the sinovaginal bulbs, which will eventually develop into the lower portion of the vagina. So again, the urogenital sinus develops into the sinovaginal bulbs, which proceed to develop the lower portion of the vagina. So what if you have a problem with the development of your paramesonephric ducts? Can you still have a vagina? Well, you might end up with something called vaginal agenesis or atresia, which is also called Mullerian aplasia. This is a congenital absence of the vagina. And as the name implies, it results from an agenesis or hypoplasia of the Mullerian duct system. There can also be agenesis or atresia of the lower vagina as well. This occurs from abnormal development of the sinovaginal bulbs and vaginal plate. Let's look at some other things that can go wrong with the paramesonephric ducts for just a second. The ducts are supposed to come together and fuse to form a single uterus with a single uterine cavity. But things don't always go according to plan. If the 2 paramesonephric ducts don't fuse correctly, you can get something called a bicornuate uterus, which can lead to infertility and recurrent miscarriages because there's simply inadequate room to grow. So if the female program is the default, what does it take to make a male instead? Who's calling the shots? Who's the decider? Well, it turns out that the decider is a gene called SRY, which is found on the Y chromosome, which makes perfect sense since only males have a Y chromosome. The SRY gene codes for something called testis-determining factor, which induces the undifferentiated embryonic gonads to become testes and to develop 2 specific cell types and 3 specific hormones. The Sertoli cells make a hormone called Müllerian inhibitory factor, which, as you might guess, inhibits the Müllerian ducts, or the paramesonephric ducts, from becoming a uterus, fallopian tubes, and the rest. If Müllerian inhibitory factor is around, the paramesonephric ducts are going to degenerate. The second cell type, the Leydig cells, produce the second hormone, testosterone, and testosterone is what stimulates the mesonephric or Wolffian ducts to become all of the internal male genital structures, the seminal vesicles, the epididymis, the vas deferens, all those things that sperm travel through except for the prostate. That develops with the external genitalia for whatever reason. So that's 2 cell types and 2 hormones. For the third hormone, think back to endocrinology and the adrenal steroid synthesis. There's an enzyme called 5-alpha reductase that converts testosterone into dihydrotestosterone, or DHT, which is a super potent form of testosterone. And that DHT is responsible for inducing the urogenital sinus and the genital tubercle to become the male external genital structures. What did that urogenital sinus become in the female? Remember that it became the lower portion of the vagina. So DHT is very important because without it, there could be ambiguous external genitalia. Okay, let's see if we can piece everything together in a Dr. C recap. First, let's look at males. Paramesonephric duct is inhibited by Müllerian inhibitory factor. Mesonephric duct is stimulated by testosterone to produce internal male structures, including the seminal vesicles, epididymis, vas deferens, but not the prostate. 5-alpha reductase converts testosterone to DHT. DHT stimulates the urogenital sinus and the genital tubercle to develop into external genital structures. Next, let's review females. Paramesonephric duct develops into fallopian tubes, the uterus, and the upper portion of the vagina, since Müllerian inhibitory factor is not present. The mesonephric duct degenerates because of lack of testosterone, and the urogenital sinus develops into the lower portion of the vagina because of lack of DHT. There are 2 developmental penile anomalies to discuss, which are hypospadias and epispadias. Both of these refer to the positioning of the urethral meatus on the penis. Hypospadias is where the meatus opens up on the ventral aspect of the penis, which is much more common and is more of a cosmetic problem. It can be surgically corrected by a pediatric urologist using a little flap of foreskin. Surgery may not be necessary with mild hypospadias, but surgical correction with severe hypospadias is common. Epispadias is where the meatus opens up on the dorsal side of the penis. This is more severe because it's commonly associated with something called exstrophy of the bladder. Let's look at that in the study guide. Exstrophy of the bladder is a congenital gap in the anterior bladder wall and the abdominal wall in front of it, so that the interior of the bladder is open to the outside world, and that needs to be repaired as well. So let's talk about external genitalia. The male external genitalia have specific homologous counterparts in the female and vice versa. These male-female genital homologs are another high-yield topic, about 3 stars, possibly 4 stars. The glans penis in the male is homologous to the glans clitoris. The corpus spongiosum and the corpus cavernosum, which cause erections, are homologous to the vestibular bulbs. The bulbal urethral glands, or Cowper glands in male, are homologous to the greater vestibular glands, or Bartholin glands in females. And as a side note, the Bartholin glands can become infected, leading to the development of an abscess called a Bartholin gland cyst. To treat this, you have to open it and drain it. The prostate gland is homologous to the urethral and paraurethral glands, the Skene glands. The ventral shaft of the penis is homologous to the labia minora, and the scrotum is homologous to the labia majora. The very last topic I want to cover deals with how the testes and ovaries descend. There are two structures to be familiar with, the gubernaculum and the processus vaginalis. In males, the gubernaculum is what anchors the testes within the scrotum, and the processus vaginalis forms the tunica vaginalis, which is one of the coverings of the testicle. In females, the gubernaculum becomes the ovarian ligament and the round ligament of the uterus, which anchors the uterus to the labia majora. The processus vaginalis is obliterated in females. All right, that's it for the lecture. Let's have a go at the end of session quiz. First question, what structures develop from the mesonephric duct system? All of the internal male genital structures except the prostate. This will include seminal vesicles, epididymis, ejaculatory duct, and vas deferens. Next, what is the male homologue to each of the following female structures? Vestibular bulbs. The male homologues are the corpus spongiosum and the corpus cavernosum. Labia minora. The homologue is the ventral shaft of the penis. Bartholin glands are homologous to the bulbourethral glands. Urethral and paraurethral glands are homologous to the prostate. Next, what gene product comes from the SRY gene that underlies male genital development? The SRY genes codes for testis determining factor. Next, what structure anchors the testes to the scrotum? That's the gubernaculum. That's the end of our video. I hope you learned something. See you next time.
Let's go over the warm-up review. First question, what medications have anticholinergic side effects? So the typical neuroleptics can cause anticholinergic side effects, especially the low-potency neuroleptic drugs like thyroidazine and chlorpromazine. First-generation antihistamines like diphenhydramine and hydroxyzine all have anticholinergic side effects. Tricyclic antidepressants such as amitriptyline will do it. And then amantadine, the anti-influenza drug, can also have an atropine-like side effect. So those are the main ones. Next, which drug categories have the following endings? So ane is going to be the inhaled anesthetics, things like halothane. Azine are the phenothiazines. Barbital are the barbiturates. Psilin are the penicillins, that's pretty easy. And then ipramine are tricyclic antidepressants. And the last question, a 21-year-old man presents with 5 days of fever, chills, and an enlarged painful knee. What organism is most likely responsible for the symptoms? So the most common organism overall is Staph aureus, but when they give you a young person with septic arthritis, you should strongly suspect Neisseria gonorrhea, especially on your exams. Now it's time for the lecture.
Are you a dinosaur who's lost his pep? Do you remember the good old days when you could chomp a stegosaurus in half in one bite and then make all the lady dinosaurs look in your direction? Well, look at you now. You can barely gnaw your way through a baby mammoth, and those stubby little arms are just wasting away. And as far as the ladies are concerned, you might as well be extinct. But don't give up. We can help. Top researchers have developed a testosterone replacement system that caters specifically for dinosaurs. It's called Jurassitone. After a few weeks, you can be that fearsome beast you used to be in high school. Don't wait for the Ice Age. Order Jurassitone now. And remember, no one has to be a low T-Rex. Man, that was a really bad joke. We're usually further along in the course before we start bringing that stuff out. Maybe a bad sign. Okay, so in this video, we're going to learn about androgens and the testes. Now, in the first part of the video, we're going to talk about how we make sperm. So in order to do that, we have to talk about the seminiferous tubules. So the seminiferous tubules are located in the testes, and this is where meiosis and where the creation of spermatozoa is taking place. Now, in the middle of your seminiferous tubules, you'll see more mature spermatids. On the outside, you see their Sertoli cells, those are the support cells, and then the less mature spermatogonia. So let's go through a few of these cell types. So first we have those good old-fashioned spermatogonia, and these are the undifferentiated differentiated germ cells. So these cells will divide and then produce two primary spermatocytes. And you'll find these cells, again, lining the seminiferous tubules. Next are the Sertoli cells. So these are very important cells, but they are non-germ cells. So what are their function? Well, I like to think of these as support cells, sometimes even referred to as nurse or even mother cells. Now, they support the developing sperm cells by providing nourishment to the spermatozoa. Now, they are activated by follicle-stimulating hormone, so FSH. Now, Sertoli cells secrete a bunch of stuff. Now, you might recall from embryology that Sertoli cells secrete anti-Mullerian hormone, also referred to as a Mullerian inhibitory factor, which is going to inhibit the development of the internal female sex organs. They also secrete inhibin. Now, inhibin inhibits FSH. It's actually just a feedback mechanism. They also, and probably most importantly for this topic, they secrete androgen-binding protein, ABP, which maintains the level of testosterone in the seminiferous tubules. It kind of traps all that testosterone in the area. So this is very important because this helps mature our spermatocytes. Now, Sertoli cells maintain the blood-testis barrier. They do this by forming tight junctions between adjacent Sertoli cells. So all these Sertoli cells are getting really close together. They form these tight junctions so that blood can't get through. Now, everyone's heard of the blood-brain barrier. Why do we have a blood-testis barrier? Well, this protects the gametes from any autoimmune attacks. Also, the Sertoli cells are temperature sensitive, so you get decreased sperm production and decreased inhibin with increasing temperature. Now, when would you see this clinically? Well, you'd see this increased temperature in a varicocele or cryptorchidism. And remember that the Sertoli cells line, again, the seminiferous tubules. Next, we have our Leydig cells. Leydig cells, their primary function is just to secrete testosterone. Very, very important. Now, testosterone, again, very important. You have to have testosterone bathing all of these spermatogonia in order for further development to occur. How do we keep the testosterone in the seminiferous tubules? Well, we just, again, mentioned it before. Those Sertoli cells are secreting that androgen-binding protein. The Leydig cells, as we mentioned before, are located in the interstitium. So it's not lining the seminiferous tubules like the other cells that we just talked about. Now, visually, when we look at all these cells, Sertoli cells, very large cells, and they're supporting the spermatogonium, the primary spermatocytes, the secondary spermatocytes, and then even the early spermatids. Now, if you look at the image again of the seminiferous tubules, you'll see in the center those late spermatids, and they're maturing as they move towards the lumen. So you'll notice that the older spermatids are the ones that are closer to the middle. Now, in between the tubules, you might potentially see the interstitium, and this is where the Leydig cells are going to reside. All right, so now we're continuing our discussion on spermatogenesis, and we're talking about how we're maturing those sperm. Now, we just mentioned that this is taking place in the seminiferous tubules. Now, the process does not begin until a male reaches puberty, and then full development of a sperm takes about 2 to 3 months. So the beginning cell is the spermatogonia, which will yield primary spermatocytes by mitosis. And then the spermatocytes will undergo meiosis to produce spermatids. Now, important things to remember are meiosis 1 and meiosis 2. With meiosis 1, you go from a diploid to a haploid cell. Then for testing purposes, you need to know that if you have failure of meiosis 1, then you accumulate primary spermatocytes. So remember, if you lose the ability to go through meiosis 1, you accumulate primary spermatocytes. So remember that part. Now with meiosis 2, you're going from a haploid sister chromatid to a sperm cell. Now if you have failure in this, you will have an accumulation of the secondary spermatocytes. So remember, meiosis 1 is primary, meiosis 2 is secondary. Pretty easy with the numbers there. So now let's go through a little bit more on regulation of spermatogenesis. So first we have the hypothalamus. And at the hypothalamus, we're going to secrete GnRH. That's gonadotropin releasing hormone. Now this will then affect the anterior pituitary, which will then secrete FSH, follicle stimulating hormone, and LH, luteinizing hormone. So the FSH will stimulate the Sertoli cells that we just talked about, and those Sertoli cells are going to do what? They're going to produce that ABP, that androgen-binding protein, and inhibin. Now, what do these things do? Remember that ABP maintains the testosterone in the seminiferous tubules to help mature the spermatogonium. Inhibin will further inhibit FSH secretion as a negative feedback. Now, the LH will stimulate testosterone release from the Leydig cells. Remember, the Leydig cells are located in the interstitium. And that testosterone has to be in the area for further maturation of the spermatogonia. So LH is going to help promote that. So remember, FSH affecting Sertoli cells, producing that sperm production. LH is going to affect the Leydig cells, going to produce that testosterone, and that testosterone supports the sperm production. All right, so we've seen how the hypothalamus and the anterior pituitary act to stimulate the Leydig cells to produce testosterone and how this is very important to spermatogenesis. Now let's go a bit deeper with this and some of our other androgens and go into a lot more detail here. So again, let's start back at that hypothalamus. GnRH, gonadotropin releasing hormone, we just talked about this. It's secreted in a pulsatile fashion. That's a very important point. With normal functioning of the hypothalamus, we see GnRH secreted in a pulsatile fashion. So the hypothalamus will not secrete GnRH continuously. A continuous release of GnRH will actually inhibit the anterior pituitary. Now clinically, we can actually use this to our advantage. We have synthetic GnRH, and we will sometimes give it continuously to try to shut down the release of FSH and LH from the anterior pituitary. So for example, in prostate cancer, sometimes we want to shut off testosterone altogether, and therefore we're going to give a synthetic GnRH continuously. We can also give a GnRH in a pulsatile fashion to actually stimulate normal anterior pituitary function, hopefully get those gonadotropins going. So next let's talk about in more detail our androgens. Now the most clinically significant androgens are testosterone and dihydrotestosterone. Now the function of testosterone includes a lot of things. Differentiation of the epididymis, vas deferens, and the seminal vesicles. So the internal genitalia, but not the prostate. Testosterone promotes growth in general, helps the development of the penis and other secondary sex characteristics, sperm production as we just talked about, muscle development, RBC, red blood cell development. Now it will result in the deepening of the voice, and testosterone is also important for libido, not just for males but for females as well. Now clinically, it's used to treat hypogonadism. It's also there to promote secondary sexual characteristics if they're not developing appropriately. But there's also some negative effects as well. It can cause masculinization in females, which most women don't want. Patients can also get premature closing of the epiphyseal plates. So it's very important that we don't get too much testosterone too early in life as a child. Therefore, we're going to end up being very short. Now, excess testosterone will also act as a negative feedback on the anterior pituitary, inhibiting LH release. So this will lead to testicular atrophy. So bodybuilders who take a lot of testosterone will have very small atrophied testicles. And because of that atrophy, there's also going to be a decrease in sperm production and maturation. Therefore, patients on exogenous testosterone will often be less fertile, which seems actually a little counterintuitive. But you have to have the testosterone in the right place, in the seminiferous tubules, for those sperm to mature. So now let's talk about dihydrotestosterone, also referred to as DHT. So testosterone is converted to dihydrotestosterone by a very important enzyme, 5-alpha reductase. Again, very important, we'll come back to that one. So what does DHT do? Well, it's actually a more potent hormone than testosterone. And DHT is responsible early on in life with good things, development of the penis, the scrotum, the prostate. Recall that it's working on the urogenital sinus during development as well. Now later on, it's not so helpful. It's stimulating a pathologic prostate growth, BPH, male pattern baldness, and sebaceous gland activity. And we'll talk about how we're going to treat those in just a minute. Now, another important aspect of androgens is that they can be converted into estrogens. Aromatase is an enzyme that can convert testosterone to estradiol. It can also convert androstenedione, which is a weaker androgen and a precursor of testosterone, into something called estrone. Now, aromatase is produced by Sertoli cells, and you can actually find aromatase in many other tissues as well, including the brain, blood vessels, skin, bone, and especially in adipose tissue. So this becomes clinically important because obese patients can become testosterone deficient because their testosterone gets converted into estrogens in all that excess adipose tissue. So now let's move on to the anti-androgens, so things that are working against androgens. So remember, testosterone is converted to DHT by 5-alpha reductase. We mentioned that just a second ago. There is a medicine, or a couple of medicines, one called finasteride, the other one called dutasteride. These are the 5-alpha reductase inhibitors. They decrease the conversion of testosterone to dihydrotestosterone. Now this is very useful for patients who have benign prostatic hyperplasia, BPH. Remember how we said that late in life that DHT is going to cause prostatic enlargement. So we can use this to help counteract that. Finasteride can also be used to treat male pattern baldness as well. DHT causes what's called the androgenic miniaturization of hair follicles. So by blocking DHT, we can prevent this type of hair loss. Moving on to other drugs that are anti-androgens, flutamide. Flutamide is a different type of medication. It is a non-steroidal competitive inhibitor of androgens at the testosterone receptor. So it's working at the receptor level. Its only clinical use is in the treatment of prostate cancer. Ketoconazole, we use that as an antifungal all the time. It actually inhibits steroid synthesis. It's inhibiting desmolase, so it's going to decrease testosterone levels. Spironolactone inhibits steroid binding. Ketoconazole and spironolactone are used in the treatment of polycystic ovarian syndrome to prevent hirsutism, so that excess hair growth that you're going to see in females. Both have side effects, again, gynecomastia and amenorrhea. Next, let's move on to some pathology. The first one we're going to talk about is androgen insensitivity syndrome. You might also hear this referred to as testicular feminization syndrome. So this is only clinically significant in male patients. In female patients, you may not even be able to diagnose this very easily. So most of the time when you see this, these are patients who are going to be 46XY genetically. Chromosomally, they're males. Now, gonadally, they're normal males also. They have testes. So what's going on here? Well, the defect is at the androgen receptor. Testosterone is present everywhere, but since that receptor is bad, you don't get any of the effects of that testosterone. Therefore, this results in a mostly normal appearing female, though genetically they're still male. So these patients have female external genitalia with a rudimentary vagina. So why is it that you have a rudimentary vagina? That doesn't make sense. Well, because the actions of testosterone and DHT are ineffective, the portion of the vagina is still going to be able to develop. Now, since we still have anti-Mullerian hormone around, you're not developing the paramesonephric duct. So you don't have the upper portion of the vagina, but you do have the lower portion. Uterus and fallopian tubes are going to be absent as well. Now, patients will have decreased or no sexual hair because testosterone is actually responsible for most of the pubic hair. Now, testes are often found in the labia majora. So if you have a patient coming in, appears to be a normal female in general, with 2 lumps in the labia majora, red flag for androgen insensitivity syndrome. Those lumps in the labia majora for step 1 are probably almost always going to be the testes, indicating this particular problem. Now, we surgically remove these to prevent any malignancy in the future. These patients will have increased testosterone levels because the body is trying to stimulate these androgen receptors, but they're just not reacting. There's going to be increased estrogen and increased luteinizing hormone overall. So next is 5-alpha reductase deficiency. So this is an inability of the male to convert testosterone to dihydrotestosterone, the DHT. And DHT is the more potent form of testosterone. So these patients have ambiguous genitalia until puberty. And then at puberty, there's a large but kind of normal increase in testosterone levels. And even though they can't convert it to DHT, they have enough testosterone around at puberty that masculinization occurs and there's increased growth of the external genitalia. Now, the testosterone and estrogen levels overall are going to be normal. So remember we said with androgen insensitivity, those levels are going to be raised. Here they are normal. LH is normal, maybe slightly increased, and internal genitalia are normal as well. So gonadally, they're going to be normal. So next, let's move on to pseudohermaphroditism. So pseudohermaphrodites, there's a disagreement between the phenotype and the gonadal sex. They do not have both types of gonads. They are pseudohermaphrodites. So they have one particular type of gonad, and again, the name of the pseudohermaphrodite is based on what gonad is present and what chromosomes they have. So the female pseudohermaphrodite are going to be XX. They have ovaries, but the external genitalia it's what's disagreeing here. They're either going to be virilized or ambiguous. So this is due to excessive or inappropriate exposure to androgenic steroids during early gestation. Now, congenital adrenal hyperplasia is another scenario where you could have a female pseudohermaphrodite. Congenital adrenal hyperplasia is caused by that 21 beta hydroxylase deficiency or the 11 beta hydroxylase deficiency. Okay, so that's a female. The male pseudohermaphrodite is XY with testicular tissue, but the external genitalia are going to be female or ambiguous. Now, the most common form is that androgen insensitivity syndrome or testicular feminization, which we just talked about. So that's an example of that. Now, what if we just have regular hermaphroditism? Well, the patient's karyotype has both XX and XY chromosome pairs, and this patient can have both ovarian and testicular tissue present. You get ambiguous genitalia as well. Now, one possible explanation is called the parthenogenic genetic division of a haploid ovum into two haploid ova. The two ova get fertilized by two sperm, one carrying the X, one carrying the Y, and then the two kind of fertilized, fuse back into each other, and that's how they have both types of genital. Now, another cause is the crossing over the SRY gene from the Y chromosome to the X chromosome during meiosis. So this doesn't happen very often. That's why we don't see a lot of true hermaphrodites in the world. All right, so next we're going to go through a couple scenarios here. So we're diagnosing disorders of sex hormones. So what if you suspect a disorder of sex hormones? What should you do? So if you have ambiguous genitalia or abnormal sexual development, you might check at the very least a testosterone level and a luteinizing hormone. This is going to tell us quite a bit. And those can help you identify a few very specific conditions. So let's say you check a testosterone and LH. And the testosterone is high and the luteinizing hormone is high. Well, one thing that can cause this is a defective androgen receptor. So it's not responding to testosterone. So the luteinizing hormone and the testosterone are both going to be increasing to try to generate the response to that receptor. So that would be a defective androgen receptor. What if you have a patient with a testosterone secreting tumor? What would you see in that scenario? Well, obviously your testosterone level is going to be very high, and that high testosterone is going to cause a negative feedback inhibition on luteinizing hormone. So it's going to cause the luteinizing hormone to be very low. What about primary hypogonadism? So with primary hypogonadism, you have low testosterone levels. They're just not producing. And so that low testosterone is not going to inhibit or have any negative feedback on that luteinizing hormone. So you're going to have very high luteinizing hormone trying to reverse that hypogonadism. So then another scenario is hypogonadotropic hypogonadism. So your gonadotropic hormones, the luteinizing hormone is very low in this case. And because your luteinizing hormone is low, then your testosterone is also low. So one example of a disorder that can have this hypogonadotropic hypogonadism is Kallmann syndrome. Patients will have low levels of GnRH, which will then lead to low levels of LH and FSH, and go on down the road. You get the same thing with low testosterone. It's also associated with a defect of the olfactory bulb that results in anosmia, which means you can't smell. So Kallmann syndrome is a defect of an X-linked Kall chain, K-A-L, and the disorder is suspected in any female that has primary amenorrhea and or delayed puberty that also has a defect in the sense of smell. So remember that one. They love to put that one on tests. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those questions first, and then we'll go through them together. First question, how does the dosing schedule of a GnRH agonist affect gonadotropin release? So if a GnRH agonist is given continuously, then gonadotropin release is decreased, it's inhibited. If a GnRH agonist is given in a pulsatile fashion, then this will promote normal gonadotropin release. Next, what is the difference between androgen insensitivity and 5-alpha reductase deficiency? So remember, the androgen insensitivity is testicular feminization, same thing, where there is a defect in the testosterone receptor, so it does not respond to stimulation. So these people are genetically male, but they look a lot like females, with a vulva instead of a penis, and the lower portion of the vagina is present, but no uterus or ovaries. The gonads are actually testes and are often located in the labia majora, and you'll see elevated levels of testosterone, LH, and estrogen. And then for the 5-alpha reductase deficiency, testosterone cannot be converted to DHT. So the early defect is ambiguous genitalia. Then when the patient reaches puberty, the penis develops and you have normal testosterone levels, normal estrogen, normal LH. Next, what is the role of Sertoli cells and Leydig cells in male spermatogenesis? So remember, those Leydig cells are stimulated by LH, they're just producing testosterone. The Sertoli cells are stimulated by FSH, and they secrete androgen binding protein, which maintains a high concentration of testosterone in the seminiferous tubules, and those Sertoli cells provide support and nutrition for those spermatocytes as well. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question, which elbow injury is common in tennis players and then also in golfers? So in tennis players, you're going to see lateral epicondylitis, and golfers tend to get medial epicondylitis. Next, what reactions take place in phase 1 versus phase 2 metabolism, and in general, what are the products of these reactions. So phase 1 metabolism reactions include oxidation, reduction, and hydrolysis. Phase 2 metabolism reactions include acetylation, sulfation, and glucuronidation. And then in general, phase 1 metabolism produces metabolites that are slightly more polar and slightly more water soluble. Phase 2 produces metabolites that are very polar and therefore much more easily renally excreted. These are usually inactive metabolites. And the last question, which enzymes are required to convert phenylalanine to dopamine? So first of all, you need phenylalanine hydroxylase to convert phenylalanine to tyrosine. Then you need tyrosine hydroxylase to convert tyrosine to dopa. Then you need dopa decarboxylase to convert dopa to dopamine. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on testicular pathology. I really like this lecture because I don't have to write an intro. From the beginning of time, the testicle has been the easiest subject matter for comedy. I think Shakespeare wrote that. Why are testicles funny? It's a mystery. All I have to say is balls, 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 and a bunch of you watching right now are smiling and some of you are even laughing out loud. It's just that easy. So sit back and enjoy my lecture on nuts and balls. See, I did it again. All right, so today we're going to cover the major pathologies of the testicles. First, we're going to talk about epididymitis. So this is inflammation of the epididymis. This is painful. Most of the time, diagnosis is just by palpation. During the testicular exam, the epididymis may be mildly swollen and it's almost always going to be tender. Now, another sign is that some of the pain may be relieved by elevation of the testicles. Although it might be a bit awkward, elevate them a little bit and then see if the pain improves. Now, the two most common organisms that cause epididymitis are Chlamydia trachomatis and Neisseria gonorrhea. Men who engage in anal intercourse are at an increased risk of E. coli. Now, the treatment is similar to urethritis, so you want to think about gonorrhea and chlamydia and that they can be treated with ceftriaxone IM doses plus doxycycline or an azithromycin one-time dose. Now, if the patient has a history of anal intercourse, you want to think about enteric bacteria. Fluoroquinolones are going to be used in this situation. Let's move on to testicular torsion. So testicular torsion is twisting of the spermatocord, which can eventually lead to ischemia. So this is a potential emergency. It is very painful. Now the diagnosis here, the classic finding is going to be that high riding testes on the affected side with the long axis of the testis oriented transversely instead of longitudinally. Now, testicular swelling may also be present. The cremasteric reflex is usually absent in testicular torsion, and ultimately, you need to get an ultrasound to look for blood flow into that testicle. Now, for treatment, rarely you can manually untwist the testes. The action is almost like opening a book. You're rotating in an outward fashion. Surgical detorsion is necessary in most cases, and then once you get a testicular torsion, you're more likely to get one again. So oftentimes they will do a bilateral orchiopexy, where they actually suture the testes to the scrotum so it doesn't happen again. Now, if you don't treat these things within about 6 hours, you can have permanent ischemia and permanent damage to the testes. Next, let's move on to cryptorchidism. So this is failure of the testes to descend into the scrotum. Now, usually it is unilateral, but it can be bilateral as well. The descent is usually complete in the first year of life. And there's an increased risk of malignant tumor in the undescended testicle, and it's usually a germ cell tumor. It's also interesting that there's an increased risk, though smaller, of testicular cancer in the contralateral, so that normal descended testicle as well. And we're not entirely sure why this occurs. Also, undescended testes may suffer from lack of spermatogenesis because of higher body temperature. One of the reasons we have testicles on the outside of our body is to provide a lower temperature for spermatogenesis. Prematurity also increases the risk of cryptorchidism. Now, early orchiopexy is the treatment. So you're going to bring the undescended testicle down into the scrotum and then suture it there to make sure that it remains in place. And this will reduce the risk of the germ cell tumors, but not completely. But just as important, if a germ cell tumor does develop in that testicle, you'll be able to detect it because it will be palpable. So early orchiopexy is usually all that's indicated in that case. Now, in the more rare scenario where there's a post-pubertal treatment of cryptorchidism, it's a more complex issue. But depending on the patient, it's going to be either orchiopexy or possibly orchiectomy, just taking out that undescended testicle. Now, what about the case of androgen insensitivity syndrome? So remember that this disorder is where the patient has male testes, but because of the androgen receptor not working, the patient develops female external genitals. Well, the testes don't have a scrotum to descend to, but they do tend to locate in the labia majora. Basically, you have 2 lumps in the labia majora, and again, that is an indication for orchiectomy. And in the case of bilateral non-palpable testes in a phenotypic male, it may be the case that the phenotypic male doesn't even have testes. So you need to make sure that you're ruling out congenital adrenal hyperplasia, a scenario in which the infant was exposed to excessive androgens. Here the patient has ovaries, but has developed male external genitalia. Now let's move on to testicular germ cell tumors. So this can be a bit dense, but stay with me and we'll get through it. Now, 95% of all testicular tumors are going to be these germ cell tumors. They can present as a mixed germ cell tumor as well. Now, the first one is a seminoma. So it is the most common testicular tumor. About 50% of all these germ cell tumors are seminomas. It mostly affects males between the ages of 15 and 35, and it is malignant, and patients will present with a painless, homogeneous testicular enlargement. Now, on histology, you're going to see large cells and lobules with watery cytoplasm and what's called a fried egg appearance. So remember that. This is similar in appearance to the coilocytes of HPV and the oligodendroglioma. So remember, the watery or clear cytoplasm, the fried egg appearance. Now, they are radiosensitive and have a late metastasis. So they have good prognosis because by the time you diagnose these tumors, most of the time they haven't gone through any metastasis. Now, the female equivalent of this is the ovarian dysgerminoma. So they are going to be similar cancers. Now we're going to move on to the embryonal carcinoma. So this is uncommon, but malignant. So it has a worse prognosis than the seminoma. Patients will again present with a palpable mass in the scrotum, and these tumors tend to be more painful as well. Now, under the microscope, these appear more glandular with papillary morphology. This can differentiate it to other tumors. Now, the AFP alpha fetoprotein level is usually normal, but if it is elevated, then you're probably dealing with a mixed germ cell tumor. HCG might be elevated as well. Next, we're going to move on to the yolk sac tumor, which is also called the endodermal sinus tumor. So this is the most common testicular cancer in children up to 3 years of age. Now, the appearance is yellowish and mucinous, and this is analogous to an ovarian yolk sac tumor. So yolk yellow, remember that yellowish mucinous look there. You get these Schiller-Duval bodies that resemble primitive glomeruli as well. So you see a pattern where there is a mesodermal core with a central capillary, which are lined by flattened layers of both visceral and parietal cells. Yolk sac tumors will have an elevated AFP most of the time. Choriocarcinoma. So choriocarcinoma is malignant and can cause increases in HCG, so remember that. This is a tumor with disordered syncytiotrophoblasts and cytotrophoblasts. Since you have all these syncytiotrophoblasts, that's why you see an elevation in that HCG. These tumors will metastasize hematogenously as well. And then finally, we have the teratoma. Mature teratomas in males are most often malignant. The most important thing you need to remember about teratomas is that they have multiple tissue types. So you definitely hear about hair and teeth and all sorts of nasty, gross stuff coming out of a teratoma. And these will be having elevations in HCG and alpha fetoprotein. These will be elevated probably about 50% of cases. Next, let's move on to the testicular non-germ cell tumors. So this is only just about 5% of testicular tumors in general. Again, these are also nicer because they are mostly benign. Leydig cell tumors are the most common of the non-germ cell tumors. They contain Rinke cells. So these are lipofuscin pigment and rod-shaped kind of crystal-like structures. We're really not sure if they serve any function, but you might see that on a question. These tumors are usually androgen producing, though they can produce estrogens as well. So a patient can get both virilizing or potentially feminizing symptoms. These tumors can occur in any age, but are more common in adults. Endocrine symptoms include decreased libido, erectile dysfunction, infertility. In children, we can see precocious puberty in boys, and that makes sense because you're getting too much testosterone too early. You can also see this kind of golden brown color when you look at these tumors grossly. Sertoli cell tumors, they're going to secrete excess estrogen in most cases. Patients may have a gynecomastia. 90% of these are benign. Strangely, these tumors can be associated with Peutz-Jeghers syndrome and Carney syndrome. And then testicular lymphoma. That's going to be the most common testicular cancers in older men. But this is not a primary testicular tumor. It's just a metastasis to the testes. Okay, we need to boil down the differences between all these tumors. It's time for another Lewis Notes. All right, so today we're looking at our testicular tumors, and we've got our matching game again here. We really just boiled it down to some of the biggest buzzwords for each one of these. I think if you know these, you'll be in pretty good shape. So let's get started here. We'll start out with the Schiller-Duval bodies. Where are we going to send those? Remember, our Schiller-Duval bodies are going to come over here to our yolk sac tumor. And then we have increased alpha-fetoprotein. That could go on a couple ones. Remember, in teratomas, you have about 50% elevated in alpha-fetoprotein. But for this one, I'm really going and looking at yolk sac tumors again. So yolk sac tumors are going to have an elevated LFP. What about elevated HCG? Remember, a couple of these can do it, but the big one I want you to remember is choriocarcinoma. I won't give away the answer to one of these other ones, but I'll tell you why in here in a second. Fried egg appearance. Remember, that's going to have those real watery-looking ones. That's going to be seminoma. Normal AFP, but elevated HCG. That's going to put this one over here at embryonal. Remember, that's the bad one that has poor prognosis. Most common overall is going to be our seminomus. Remember that one. Syncytiotrophoblasts. So this is the one I didn't want to spoil for you earlier, because remember, you have all these syncytiotrophoblasts and cytotrophoblasts. That's why that HCG is so high. So that's why I really want you to put in your mind choriocarcinoma and increase HCG. Very painful tumor goes along again with our poor prognosis embryonal tumors. Teeth and hair, that's the easiest one on here. You guys know that's going to be a teratoma. Most common up to age 3. So this is one that you really need to remember that maybe you don't very easily. That's going to be our yolk sac tumor again. Testosterone secreting. That one's pretty easy because remember, this is going to be our Leydig cell tumor. Remember, Leydig cells secrete testosterone. Most common in older men. Older men are going to get this lymphoma. Remember, it's not really a primary tumor, but that's going to go there. Then estrogen secreting, very easy, Sertoli cells again. And you're going to get, both with the Leydig and the Sertoli cells, you might see some gynecomastia in your men. All right, so that's going to be it for all these tumors. I hope you know this stuff, and you ought to do okay. Next, let's talk about tunica vaginalis lesions. So these are lesions in the serous covering of the testis that can present as testicular masses. Now, what's important is that they can be transilluminated in many cases. So you take a flashlight, you put it up to the scrotum, which isn't awkward. You can see something in there kind of floating around to some extent. You can see through that area right there. But it's going to be very different with a testicular tumor with something solid. You won't see anything kind of floating around when it's just a big solid mass, but you can see something when it's just fluid or blood in there. Now, the first one is a hydrocele. This has increased fluid secondary to incomplete fusion of the processus vaginalis. So this is very, very common in newborns. So when you go through your newborn rotation, you see little boys with very tight fluid-filled scrotums. So this is not a big deal. We don't get excited about this at all. These are going to resolve on their own, usually relatively quickly, but they can stick around for maybe even up to a year. We still don't do any treatment in that first year because it's benign. It doesn't cause any problems at all. Next, we have the spermatocele. This is due to a dilated epididymal duct. So there's not too many other details that you need to know about this one. Pretty low yield, but just know the name of that one. Next, we have a varicocele. Don't get a hydrocele confused with a varicocele. Varicocele is a dilated vein or veins in the pampiniform plexus that can cause infertility. And really kind of more of an association with infertility, not necessarily a cause. We're not 100% sure about that one. Now, this is a good test question that you might get. A bag of worms feeling in the area, and you can kind of feel these dilated veins. It kind of feels like a bag of worms. So varicocele, think of bag of worms in that situation. All right, guys, that brings us to the end of the lecture part. It's time for the end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, a 23-year-old patient presents with one testicle. For what is this patient at risk? So we presume he has an undescended testicle, which puts him at risk for testicular cancer, specifically germ cell tumors. Next question, what testicular tumor is described by the following statement? So first we have composed of cytotrophoblasts and syncytiotrophoblasts. So this is choriocarcinoma. May present initially with gynecomastia. Think of the Leydig cell tumor and also the Sertoli cell tumors. Elevated AFP, that's going to be yolk sac tumor, and also 50% of teratomas. Next, we have elevated HCG. Think of choriocarcinoma, also embryonal carcinoma and teratoma. Most common testicular tumor, that's going to be the seminoma. Most common testicular tumor in infants and children up to the age of 3 years, that's going to be the yolk sac tumor. Most common testicular tumor in men over the age of 60, think of testicular lymphoma. Histologic appearance similar to koilocytes with cytoplasmic clearing, that's the seminoma. Histologically may have an alveolar or tubular appearance, sometimes with papillary convolutions, that's going to be the embryonal carcinoma. Composed of multiple tissue types, teratoma. Histologic endodermal sinus structures, so the Schiller-Duval bodies, that's going to be the yolk sac tumor. 25% have cytoplasmic rod-shaped crystalloids of Rinke, that's going to be the Leydig cell tumors. Androgen producing and associated with precocious puberty, think of the Leydig cell tumors, maybe a Sertoli cell tumor as well. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go through the answers to the warm-up. First question, what's the function of the protein that's absent in Duchenne muscular dystrophy? Well, the name of the protein is dystrophin, and the function of dystrophin is to connect muscle fibers to one another. Next, what's the most likely presentation of methanol toxicity? So methanol is metabolized to formaldehyde, which causes metabolic acidosis, and then potentially also some retinal damage and blindness. Last question, which skin disorder matches each of the following statements? So pruritic purple polygonal papules are the P's of lichen planus. Pruritic vesicles associated with celiac disease is called dermatitis herpetiformis. A thickened scar, especially around the face or chest, is a keloid. Parakeratotic scaling is a buzzword for psoriasis. Keratin-filled cysts are seen in seborrheic keratosis. Skin rash plus proximal muscle weakness would make you think about dermatomyositis, which might also be associated with a malignancy. Honey crusting lesions around the nose and lips suggest impetigo. And then hyperkeratosis and koilocytosis are the verrucae of HPV. These are warts. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on penis and prostate pathology. Once again, no intro necessary. Many can't say erection without a smirk. And once again, I believe it was Shakespeare who said, "Shut up already about all these penis jokes. I'm just trying to eat this hot dog in peace." Okay, so in this lecture, we'll cover sexual dysfunction, penile pathology, and then we'll tackle the prostate as well. So, moving on to sexual dysfunction. So when we say sexual dysfunction, this can mean several different things. I think most people tend to equate sexual dysfunction with erectile dysfunction, but that's just a part of sexual dysfunction. So this can include decreased libido. It includes sexual arousal disorders like erectile dysfunction, orgasmic disorders. Patients might have pain with sexual activity, and we call this dyspareunia. So now let's talk about some of the causes of sexual dysfunction. Many, if not most of these, will lead to erectile dysfunction, especially in men. Now, number one, drugs. Drugs can cause sexual dysfunction. Antihypertensives, they're pretty well known for sexual dysfunction, but more recent data actually suggests specifically the beta blockers do not cause significant erectile dysfunction. Neuroleptic drugs, so drugs used to treat things like schizophrenia, can cause sexual dysfunction. SSRIs are well known for causing sexual dysfunction, especially a decrease in libido. Alcohol. So alcohol will, of course, decrease your inhibition for sexual activity, but it will also increase your sexual dysfunction. It's one of the great ironies of alcohol use. Diseases like atherosclerosis, depression, diabetes, all again can cause some level of sexual dysfunction. Hyperprolactinemia can cause sexual dysfunction. That increased prolactin level can decrease libido. And of course, low testosterone can decrease libido as well. And then there are psychological effects, like performance anxiety can certainly lead to anxiety about having sex, and then that dysfunction happens. All right, so now let's more specifically talk about erectile dysfunction. So this is a very common disorder. Men are often embarrassed to bring this topic up, but I'm finding actually more and more are becoming more comfortable talking about this. So what should we know? Well, this is not quote unquote a normal part of the aging process, but it is very common. About 50% of men between the ages of 40 and 70 years will have some degree of ED. So there's three primary mechanisms by which erectile dysfunction occurs. So first we have a failure to initiate. So that could be a psychogenic problem, so that performance anxiety we talked about before, endocrinologic, you can have neurogenic as well, so think about diabetes and other nerve problems leading to this. You get a failure to fill, which is a big one, so arteriogenic, so atherosclerosis causing this. And then you have failure to store, so you can't store adequate blood volume within the lacunar network. So you can have problems with just one or all three of these things. Diabetic, atherosclerotic, and drug-related causes account for about at least 80% of the cases of ED in older men. And then also think of this, 35 to 75%, I know that's pretty wide, of men with diabetes will have ED. So if you have a diabetic male, you should probably ask them about erectile dysfunction. So let's talk about some drugs. Phosphodiesterase inhibitors. So the drugs include things like sildenafil, vardenafil, and tadalafil. So these are all erectile dysfunction medications. Now for their mechanism, they inhibit cyclic GMP phosphodiesterase. And this is going to cause an increase in cyclic GMP. So what do we get as a result of that? Well, we get smooth muscle relaxation in the corpus cavernosum, increasing blood flow and penile erection. So these are very popular drugs. For clinical uses, we have erectile dysfunction. It does do a couple of other things. It does also have a beneficial effect on Raynaud disease, so it can help with some vasodilation where you'll have less vasoconstriction. This can also be used with primary pulmonary hypertension. And then more recently, daily tadalafil has been FDA approved to treat the symptoms of BPH, benign prostatic hyperplasia. Side effects of these drugs, well, they include things like headache. You can also get flushing and dyspepsia. So most of this is due to that vasodilation effect. You can also get, interestingly enough, impaired blue-green color vision. So one way to remember this is that Viagra, and that's the brand name for sildenafil, was called the little blue pill in its marketing campaign. Also, there is the risk of life-threatening hypotension in patients taking nitrates. So if anyone has a prescription for nitrates, nitroglycerin, do not give them a phosphodiesterase inhibitor. So now let's move on. We're going to talk briefly about several penile pathologies, quite a few here. The first one is Bowen disease. So this is a kind of gray, solitary, crusty plaque, usually on the shaft of the penis or on the scrotum. It can be on other parts of the body as well. And this is not just a male disease. This can occur in females as well, so that you get this on the female genitalia. The peak incidence is in the 5th decade of life and can progress to invasive squamous cell carcinoma in less than 10% of cases, but it is an increased risk. Erythroplasia of Corrette. So this is a red velvety plaque, usually involving the gland. So this is actually a form of Bowen disease, but instead of having kind of those gray crusty plaques that we talked about, you get these kind of red velvety looking plaques. And then we have a similar one, Bowenoid papulosis. So Bowenoid papulosis, these are kind of multiple papular lesions that affect a younger age group than the other subtypes we just talked about. And this usually does not become invasive. Next is squamous cell carcinoma of the penis, which causes about 95% of penile cancers. Squamous cell carcinoma is more common in Asia, in Africa, and South America than here in the United States, commonly associated with HPV and lack of circumcision. Peyronie disease. So in Peyronie disease, you're going to see an actual angulation to the penis. So it can be painful with erections and can lead to difficulties with sexual activity. And this is due to inflammation and fibrous tissue formation of the tunica albuginea. Priapism. So priapism is a persistent penile erection. It can be quite painful for some patients, and this can be potentially serious because it can lead to ischemia and clotting of the blood that is retained in the penis. And it's associated with sickle cell disease and spinal cord injuries. Condyloma acuminata. So this is the common genital wart. So these are benign, but are considered a sexually transmitted infection. They are due to HPV types 6 and 11, 6 being the more common one. Now the treatment options include chemical or physical destruction, immunologic therapy, or even surgical excision. Next we have balanitis. So this is an inflammation of the glans penis. 40% are due to Candida albicans, but this can also be caused by local trauma, bacteria, viruses, sexually transmitted infections as well. It's more common in patients who have not been circumcised. It's also more common in diabetic patients as well. When I see an obese patient with balanitis, I definitely want to screen that patient for diabetes. So next, I want to briefly mention urethral injuries. First, the big rule here, if you see blood at the urethral meatus, do not place a catheter. You can cause more damage to the urethra in that case. If you see blood, generally you're going to call a urologist. Now let's talk about other damage. So damage to the urethra usually falls into a posterior injury or an anterior injury. Posterior injuries can occur with big pelvic fractures. And with a severe enough injury, a patient can have urine that leaks into the retropubic space. Now what about an anterior injury? So an anterior injury can occur with a straddle type injury. So think about falling on the crossbar of a bicycle. And this can cause urine to leak beneath the deep fascia of buck. Now if the fascia is also torn, then that urine can then leak into the superficial perineal space. All right, so next let's talk about prostatitis. So what are the symptoms? Well, prostatitis will cause dysuria, so painful urination, frequency, urgency, low back pain. Kind of sounds like cystitis here. There is an acute and a chronic form. Now the acute form can be divided up by age by some people because there is an association between age and then the bacterial cause of that prostatitis. So if you're younger than 35 years of age, you're going to have a greater chance of finding gonorrhea or chlamydia. Greater than 35 years of age, less likely to find those. You're going to find more of the things like UTI type bugs, so E. coli, Klebsiella, Serratia, Enterobacter, and Proteus. Now, chronic prostatitis can be difficult to treat. Also, prostatitis can be abacterial, and that can be very frustrating. So you actually don't have a bacterial infection that you can culture, and you can get this kind of chronic smoldering prostatitis that is very uncomfortable. Treatment for this is kind of like treating a UTI in older patients. So you can treat with fluoroquinolone, so something like levofloxacin. You could also use trimethoprim sulfamethoxazole. You have to give this for a while though, a good 4-week treatment to help treat this. Sometimes you might even have to retreat prostatitis as well. It can be actually very difficult to cure. Let's move on to benign prostatic hyperplasia, very common disease. As the name implies, this is a benign enlargement of the prostate. Now this is common in men greater than 50 years of age, so you get hyperplasia, not hypertrophy of the prostate gland. So what's the difference? Well, hyperplasia is producing more cells. Hypertrophy is the enlargement of those cells. So what causes BPH? And the short answer is androgens. So remember that DHT, dihydrotestosterone, plays the biggest role in prostate growth later in life. However, it is actually quite interesting that giving exogenous testosterone does not increase the size of the prostate significantly. BPH is characterized by a nodular enlargement of the periurethral area, so that's kind of the lateral and middle lobes, which will compress the urethra into a vertical slit. Now you can have BPH and not feel any significant enlargement because when you're actually doing a rectal exam, you're pressing on the posterior lobes. Now the periurethral lobes may be enlarged. You may not be feeling those areas as much, but if the gland is globally enlarged, then you're still going to be able to feel a significant difference there. Now, under the microscope, a BPH nodule will have glandular and stromal hyperplasia. So you can see all of the glandular-looking crypts, and then surrounding all of these grouped glands is an excess of fibrous connective tissue. And you can actually see this grossly as well. The prostate will have a kind of lumpy nodular feel and appearance. All right, a few more details about BPH. So it's present in 80% of men over the age of 80 years. Diagnosis is based on the following symptoms: sensation of incomplete voiding, increased urinary frequency, and usually it's less than every 2 hours, straining to void, intermittent or weak urine stream, urgency, nocturia, so at least 2 to 3 times a night they're waking up having to go to the bathroom. Palpable prostate size may not actually correlate with degree of obstruction or symptom severity. Now let's talk about some of the medical intervention. First, we have the non-selective alpha-1 blockers, doxazosine, prazosin, terazosin. Now don't get confused with the term non-selective here. These meds do not affect the alpha-2 receptors. There are different types of alpha-1 receptors, and these non-selective alpha-1 blockers affect them all. Now we'll talk about a drug in a second that affects only certain alpha-1 receptors, and that's why we call that one a selective drug. So these act to decrease prostate smooth muscle tone, therefore you get a fast improvement in urine flow. Some of the side effects though: dizziness, postural hypotension, and fatigue. Now to reduce some of those side effects, sometimes we dose this at night and then titrate the dose upward slowly over time over the span of weeks. Now another drug, tamsulosin, is what we call a selective alpha 1A/D blocker, and you have fewer side effects than the previous that we just described, the non-selective. So it has no or little antihypertensive effects. So why is this one more selective? Well, tamsulosin primarily affects, as we mentioned before, the alpha 1A and the alpha 1D receptors. So the alpha 1A is the receptor found mostly in the prostate. Now, why don't we see that big drop in blood pressure with this drug? Well, the alpha 1B is the type of receptor found in blood vessels. So tamsulosin doesn't affect those receptors much at all. So you get the relaxation of the smooth muscle in the prostate with no relaxation of the smooth muscle in the blood vessels. And then another group of drugs, the 5-alpha reductase inhibitors. So think of finasteride and dutasteride. So these slowly reduce dihydrotestosterone levels. So remember that DHT causes your prostate growth later in life. And this leads to a 20% decrease in prostate volume over 3 to 6 months once you start the medication. Side effects will include decreased libido, ejaculatory dysfunction, and even impotence. And then we have the phosphodiesterase inhibitors. Now, as we mentioned before, tadalafil can be used for erectile dysfunction, but it can also be used to decrease the symptoms associated with BPH as well. And then you can actually do some surgical interventions. Patients can have a prostatectomy, but this can lead to permanent erectile dysfunction. Also realize that BPH is not a pre-malignant lesion. BPH is not a precursor or a pre-prostate cancer. It is just causing an obstruction of the urine getting out. Also realize you can get increase in free prostate-specific antigen, that PSA, with just this BPH syndrome. And that leads us to prostatic adenocarcinoma. So prostate cancer is a slow-growing cancer, and like BPH, it's common in men over the age of 50. Patients will have many of the same symptoms that we just talked about that are associated with BPH, that urinary frequency, the nocturia, that weak stream. Prostate cancer develops in the posterior lobe of the prostate gland. And this is great because it can be diagnosed with a rectal exam because it's where you're actually putting your finger when you're touching that area to perform the rectal exam. Now, the cancer may present as a hard nodule, but that isn't a reliable diagnosis. So you will need a prostate biopsy to help confirm it. Remember that BPH was enlargement of the middle and lateral aspects of the prostate. Now, 95% of the prostate cancers are adenocarcinomas originating from the glands and ducts in the prostate. Now, instead of seeing nice clusters of glands with cells with clear cytoplasm, you see this obliteration of any orderly glands, very dense cancer cells with very little cytoplasm. And as I just said, about 75% of the tumors are going to appear in the peripheral zones. Now, the prostate-specific antigen, or PSA, is used as a screening test, though there is controversy regarding this test and the rectal exam as well. The U.S. Preventative Service Task Force in 2012 recommended against screening for prostate cancer because of high false positive rates in these test cases, and the fact that many cases of prostate cancer don't lead to any symptoms at all. Many elderly men who die of natural causes or some other disease will actually have prostate cancer, but they never knew they had it in the first place. But more recently, in 2017, U.S. PSTF have backed off their original statement. They say that the decision to screen should be made on an individual basis, and doctors should discuss it with their patients. So they're no help at all at this point. So there is a lot of controversy regarding the most appropriate screening for prostate cancer. Now, when patients do get advanced disease or metastasis, prostate cancer likes to spread to bone. So patients may have lower back pain and can have elevated alkaline phosphatase. Now, for treatment, we mentioned flutamide in another video, and that med inhibits testosterone at the receptor level. Prostate cancer can sometimes feed off testosterone, therefore removing testosterone can be a helpful treatment. Oftentimes, resection of the prostate can be very, very helpful. All right, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer that on your own, and then we'll go through them together. All right, first question here. What is the mechanism of action of sildenafil? So sildenafil is one of those phosphodiesterase inhibitors. So it's going to inhibit cyclic GMP phosphodiesterase, which causes an increase in cyclic GMP, and that leads to relaxation of the smooth muscle, and specifically smooth muscle of the corpus cavernosum, thereby leading to increased blood flow and erection. Next, what are the side effects of sildenafil? Well, the side effects are generally going to be usually due to that vasodilation, which can lead to flushing, headache, dyspepsia, impaired blue-green color vision is the one weird one. And then the big one would also be potentially life-threatening hypotension in patients that are also taking nitrates. Next. What organism is commonly implicated in balanitis? So remember, somewhere around 40% is going to be Candida albicans. Next, how does flutamide differ from finasteride in relation to mechanism of action and clinical use? So this is a good one. Flutamide, remember, inhibits testosterone receptors, and we use it to treat prostate cancer. Finasteride is a 5-alpha reductase inhibitor that prevents the conversion of testosterone to DHT, and it's used for BPH and male pattern baldness as well. Next, what are the diagnostic symptoms of BPH? So these are the signs of obstruction or urinary aggravation like nocturia, hesitancy, difficulty starting and stopping urination, frequency, maybe even dysuria. Later, a more progressive urinary retention could lead to bladder distension or even maybe urinary tract infections. All right, and we do have a couple rapid fire facts here. So first we have the most common cancer in men. It's going to be prostate cancer. Most common cause of urinary obstruction in men, that's going to be BPH. Most common treatment of erectile dysfunction, that's going to be those phosphodiesterase inhibitors. An example would be sildenafil. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. It's time for another warm-up review. Let's get going. What are some examples of substances eliminated at a constant rate, or zero-order elimination? So remember the mnemonic PEA, and a P is round like zero. So PEA stands for phenytoin, ethanol, and aspirin. Next, which enzymes are used to metabolize alcohol? So alcohol dehydrogenase metabolizes ethanol to acetaldehyde. And then acetaldehyde dehydrogenase metabolizes acetaldehyde to acetate. Next, which cranial nerve nuclei are located medially in the pons? So you can remember that the nuclei for cranial nerves 5, 6, 7, 8 are located in the pons. And then remember that the nuclei are located medially in the brainstem. Those are going to be the ones that are divided evenly into 12, which will be cranial nerve 3, 4, 6, and 12. So the only cranial nerve nucleus in the medial pons is cranial nerve 6. All right, that's it for the review. Let's get to that video.
Hey everyone, my name is Dr. Emil Tajzoy, and I'm an OB-GYN in Dallas, Texas. It's nice to be with you all today, and good luck studying. So in this video, we're going to review the female reproductive cycle. The reproductive cycle is about reproduction, from producing a mature egg and releasing that egg so it can be fertilized, and also to make sure that the uterus is able to support a pregnancy if fertilization occurs. So let's begin at the beginning with oogenesis. Oogenesis is a process by which the ovaries produce a mature egg, and it begins even before birth, during fetal development. We start with a diploid cell called an oogonium, which has 23 pairs of chromosomes, or 46 chromosomes total. The oogonium begins meiosis during fetal development, and once it begins that first meiosis, it's called a primary oocyte. The primary oocyte enters meiosis, but then stops at prophase 1 and goes dormant. So the primary oocyte is arrested in prophase 1, and that's where it stays for years and years until puberty. Then right before ovulation, the primary oocyte resumes meiosis. It finishes meiosis 1, and then cell division occurs, producing a secondary oocyte, which is haploid, plus a polar body. Then the secondary oocyte starts a second round of meiosis, but then it is arrested in metaphase 2. This secondary oocyte is the cell that is released at ovulation, and if fertilization occurs, it completes meiosis 2, resulting in a mature haploid ovum and another polar body. So, primary oocytes are arrested in prophase 1 until right before ovulation, and secondary oocytes are arrested in metaphase 2 until fertilization. Next, let's review how the hypothalamus and the pituitary and the ovaries interact in order to regulate the reproductive cycle. First of all, the hypothalamus releases gonadotropin-releasing hormone, GnRH, and it releases GnRH in a pulsatile fashion. That pulsatile release of gonadotropin-releasing hormone tells the anterior pituitary to release the gonadotropins, which are FSH and LH. FSH stands for follicle-stimulating hormone, and LH stands for luteinizing hormone. FSH and LH then bind to the receptors in the ovaries, which leads to follicle maturation and ovulation. And the ovaries produce estrogen, progesterone, and inhibin, which provide negative feedback at the hypothalamus and anterior pituitary. Now let's look at the ovulation a little more closely. Each primary oocyte is found inside a primordial follicle. This primordial follicle contains the primary oocyte surrounded by a layer of supportive cells, such as the granulosa cells and the theca cells. These are the cells that actually produce estrogen and progesterone, as we'll see in a moment. Every month, when the FSH starts flowing from the pituitary, several primordial follicles begin to grow and mature, which is depicted as you follow the follicle counterclockwise. FSH is follicle-stimulating hormone, so it stimulates the follicles. And eventually, one follicle becomes dominant, and that becomes the Graafian follicle. It will release its oocyte, while all the other follicles will degenerate so that only one is released each cycle. Once that oocyte is released, what's left of the Graafian follicle becomes the corpus luteum, which secretes a lot of progesterone and also smaller amounts of estrogen and inhibin A. If pregnancy occurs, the syncytial trophoblast produces HCG, which maintains the corpus luteum so that it can keep producing progesterone until the placenta develops to the point where it can produce its own progesterone. That was covered in the Foundations video when embryology was discussed. If pregnancy does not occur, there's no HCG, so the corpus luteum degenerates and progesterone levels start to fall. Let's talk a little bit more about estrogen and progesterone. There are three main types of estrogen. Estradiol is the most potent of the estrogens. It's produced in the ovaries, and it's the most important estrogen in women. It's what keeps your skin young. You can remember it as the one that's to die for, estradiol. Estrone is found in both men and women. It's produced mainly by conversion of androgens that were produced by the adrenal cortex. This conversion is catalyzed by the enzyme aromatase, which is found in adipose tissue. Estrone, think Stallone. It's also found in men. And then finally, estriol is produced by the placenta during pregnancy. And this is the weakest estrogen. Remember this by thinking estriol is like a tree. The roots are complex and weave around just like the vessels of the placenta. And it's the weakest because it supports babies via the placenta, and babies are vulnerable and weak. So estradiol is the most potent, then estrone, then estriol. Now, I mentioned that FSH and LH stimulate the ovaries to produce estrogen, specifically estradiol, and the granulosa cells and theca cells, which were those support cells that surround the primary oocyte. But neither cell can produce estradiol by itself. It takes both types of cell. This is called the two-cell theory of estradiol production. LH acts on the theca cells to facilitate the entry of cholesterol, which is converted through a series of steps to androstenedione. This requires the enzyme desmolase. Then androstenedione diffuses into nearby granulosa cells where the enzyme aromatase converts it to estrone, which is then converted to estradiol. And FSH is involved in stimulating the granulosa cells. So it takes two different enzymes found in two different cell types to produce estradiol in the ovaries. And when you think about the functions of estradiol and estrogens in general, I want you to think growth. Estrogen causes growth of the female reproductive organs like the ovaries and fallopian tubes, the uterus, the vagina, and the external genitalia. It also stimulates development of the breasts and the ductal system of the breasts, and proliferation of the endometrium. In fact, women with excess unopposed estrogen states, such as what happens in polycystic ovarian syndrome, can lead to continued proliferation of the endometrium, which eventually leads to dysplastic changes in the endometrium and ultimately leading to uterine cancer. Estrogen also inhibits osteoclasts in the bone, so in a way it stimulates bone growth. And this is why the risk of osteoporosis increases after menopause. Estrogen levels drop and you lose that beneficial estrogen effect. Estrogen also increases HDL levels and decreases LDL levels. Pretty good. And what are the functions of progesterone? As the name implies, progesterone is progestational. It's important for getting the body ready for the pregnancy and supporting pregnancy. Progesterone inhibits endometrial proliferation. Like I mentioned earlier, when women encounter states of excessive endometrial proliferation due to unopposed estrogen, what is the treatment to reverse those early dysplastic changes on the endometrium? It's progesterone-derived hormones, which is the mechanism by which the IUD, or intrauterine device called the Mirena, works. Progesterone also promotes secretory changes that prepare the endometrium for implantation. Progesterone promotes secretory changes in the breast so that the breasts are prepared for milk production. Progesterone causes the cervical mucus to become thick and viscous to block additional sperm from entering the cervix after fertilization has already taken place. This also helps to prevent infection. This is also one of the mechanisms by which the Mirena IUD prevents pregnancy. Progesterone inhibits uterine contractions, which is beneficial during pregnancy to prevent a miscarriage. And progesterone relaxes smooth muscle in general. Now, we're ready to tackle the menstrual cycle. I'm sure you've encountered this chart once or twice before. It can be pretty daunting, so let's take it slowly. So across the top, you see what's happening in the ovary, from the follicle to the degenerative corpus luteum. Below that are the levels of various hormones. And the background shows the relative thickness of the endometrium as it gets thicker and prepares for a possible pregnancy, and then sloughs off during menstruation. Across the bottom is a timeline. The average cycle length is 28 days. And you'll notice that the menstrual cycle is divided into two phases: the follicular phase, or proliferative, and the luteal phase, or secretory phase. And the event that separates these two phases is ovulation. The follicular phase is where you have the growth of the follicle in the ovary, which is driven by FSH, follicle stimulating hormone, and FSH is stimulating the follicle to produce estrogen, which causes the endometrium to proliferate and become thicker. This is why the follicular phase is also called the proliferative phase, because the endometrium is proliferating and getting thicker so that it's all ready to go in case fertilization and implantation take place. Eventually, the rising estrogen levels triggers a surge in the levels of LH and, to a lesser extent, FSH. About 1 day after the LH surge, around day 14, the follicle ruptures and it releases its egg, and that, of course, is ovulation. So the LH surge triggers ovulation. And we've already discussed how the empty follicle becomes the corpus luteum, which secretes progesterone and some estrogen. That's why this is called the luteal phase. So the luteal phase is LH and progesterone dominant, while the follicular phase was FSH and estrogen dominant. And unlike the follicular phase, the length of the luteal phase is pretty consistent, right around 14 days. And note that as the progesterone level rises initially, it causes a tiny half-degree spike in body temperature, which occurs about 1 day after ovulation. The rising progesterone levels provide negative feedback at the hypothalamus and the pituitary, so FSH and LH levels decrease. The low LH levels eventually cause the corpus luteum to degenerate, leading to a rapid fall off of the estrogen and progesterone. And when that happens, there's nothing to maintain all that thick endometrium, so it sloughs off, and that's menstruation. We've also included a list of the main steps of the female reproductive cycle in your study guide. First, there's an increase in FSH, which stimulates follicle maturation. The follicles produce estrogen, so estrogen will increase, and initially estrogen inhibits LH and FSH. But at some point, there's a switch from negative feedback to positive feedback, which causes the LH surge, and that triggers ovulation. Then the corpus luteum forms and starts producing progesterone, as well as some estrogen. And the progesterone and estrogen feed back and inhibit FSH and LH production, so those levels drop. As LH and FSH levels decrease, the corpus luteum degenerates, so it'll stop producing progesterone and estrogen, and those levels will fall, which leads to menstruation. And with low levels of estrogen and progesterone, there's decreased negative feedback on FSH production, so FSH will increase, and that brings you back to step 1. So the cycle can begin again, circle of life, or whatever. We started out this video by saying that the purpose of the reproductive cycle is pregnancy. So let's talk about how this has to happen in order for pregnancy to occur. Again, we covered most of this in Foundations 1, but let's review it one more time. The first step is ovulation. The egg is released from the ovary. The fimbriae of the fallopian tubes sweep the egg into the tube, which is lined by cilia that move the egg towards the uterus. Fertilization has to occur within about a day of ovulation, and fertilization usually occurs in the ampulla of the fallopian tube. Then, 3 to 4 days after ovulation, the embryo enters the uterine cavity, and then implantation occurs on the 6th day after fertilization. Then, the syncytiotrophoblaст cells start secreting human chorionic gonadotropin, HCG. And what did we say was the main function of HCG? To support the corpus luteum and to keep it from degenerating so that the corpus luteum can continue to produce progesterone until the placenta takes over around week 6. And that way, HCG acts a lot like LH. In fact, HCG and LH share an alpha subunit along with FSH and TSH. The beta subunit is specific to HCG, so that's what we test for with our pregnancy tests. You can detect HCG in the blood about 1 week after fertilization, and you can detect it in the urine about 2 weeks after fertilization. HCG levels will remain high during pregnancy, and estrogen and progesterone levels will be high as well. Do you remember what type of estrogen the placenta produces? Estriol, which is the least potent estrogen. Let's finish up with a quick review of lactation. Milk is produced in the alveoli, and a cluster of alveoli makes up a lobule, and these lobules drain into the ducts, which empty out at the nipple. Milk production is stimulated by the hormone prolactin, which is produced by the anterior pituitary. You may also see this called milk secretion, because the milk is produced by glandular tissue and then secreted from the cells into the alveoli. And then the milk will sit there, and the hormone oxytocin causes it to move into the ducts. This process is called milk letdown or milk ejection. Oxytocin comes from the posterior pituitary. So prolactin is needed for milk production and secretion, and oxytocin is needed for milk ejection or letdown. And both prolactin and oxytocin are released in response to the baby suckling. Estrogen and progesterone also play roles in lactation. During pregnancy, remember that the placenta is producing high levels of estrogen and progesterone, and those hormones inhibit milk production. But after delivery of the placenta, the levels of estrogen and progesterone drop. You lose that inhibition, and that allows prolactin to stimulate milk production and secretion. Now it's time for the end of session quiz. First question. During what stage of meiosis is the primary oocyte arrested? The primary oocyte is arrested in prophase 1 of meiosis 1. And it stays there until just before ovulation, which is when it becomes a secondary oocyte and enters meiosis 2, and then is arrested in metaphase of meiosis 2 until fertilization. Next, which hormone, estrogen or progesterone, is responsible for each of the following actions? Production of thick cervical mucus that inhibits entry of the sperm into the uterus. That's progesterone. Induces LH surge. That's estrogen. Relaxes uterine smooth muscle. Is progesterone. Stimulates endometrial proliferation. That's estrogen. So excess estrogen is a risk factor for endometrial cancer, which we talked about. Inhibits endometrial proliferation. Is progesterone. So progesterone protects against endometrial cancer. Next, HCG has an alpha subunit identical to which other hormones? The hormones that share the same alpha subunit are HCG, LH, FSH, and TSH. Last question. What hormonal changes facilitate lactation? There's a drop in estrogen and progesterone after delivery, so you lose the inhibition of milk production. There's an increase in prolactin, which is responsible for milk secretion, as well as an increase in oxytocin, which stimulates milk ejection. That's it for now. I'll see you next time.
It's time for another warm-up review. Let's get going. What artery and nerve are most at risk of being damaged in a patient with an anterior shoulder dislocation? So the main nerve you worry about is the axillary nerve, and what runs with the axillary nerve is going to be the posterior circumflex artery. Now additionally, what other structures might be injured in an anterior shoulder dislocation? So you got to think about the supraspinatus tendon, you got to think about the anterior glenohumeral ligament, and then the glenoid labrum as well. That's considered a Bankart lesion. And then if the posterior lateral humeral head is injured, that's going to be what's called a Hill-Sachs lesion. Next, a 75-year-old man presents with acute knee pain and swelling. An X-ray reveals absence of erosion of the joint space, but there are calcium deposits in the menisci. What is the most likely diagnosis? Aspiration of the joint would be expected to show what finding? So this is what we call pseudogout, and on aspiration of the joint you would see the calcium pyrophosphate crystals, and then on X-ray you might see that chondrocalcinosis with calcification of the menisci. Next, what are some of the inducers of cytochrome P450? So remember, our mnemonic is Guinness, Coronas, and PBRs, and it induces chronic alcoholism. So the G is for griseofulvin, the C is for carbamazepine, P is for phenytoin, B is for barbiturates, R is for rifampin, and then the S in the PBRs, you got to remember the S, is for St. John's wort, and then the last one, chronic alcoholism, speaks for itself. All right, that's it for the review. Let's get to that video.
Hey everybody. In this video, we'll be talking about menstruation and menopause, and some of the medications we use to manipulate them, like contraceptives. We reviewed the basic physiology of the menstrual cycle in the video on the female reproductive cycle. So let's talk about the more clinical aspects of menstruation. We use the term menarche to describe the first menstrual period, the onset of menstruation. The average age of menarche in the US is just under 12.5 years. We cover puberty and the Tanner stages in another video, but I'll just remind you that the sequence of pubertal maturation in girls is thelarche, or breast development, first, then pubarche, or pubic hair development, and then menarche, the first menstrual cycle. In the first few years after menarche, many girls have anovulatory cycles, resulting in irregular periods and irregular bleeding. This is due to the immaturity of the hypothalamic pituitary adrenal axis, which causes inconsistent release of the hormones of the menstrual cycle. The HPA axis will automatically mature and become regular in about 6 years. So if you have a young patient, 13 or 14 years old, and she's complaining of irregular periods, think about anovulation due to this phenomenon. You still need to do a pregnancy test, but consider the possibility of anovulatory cycles. The treatment for anovulatory bleeding is usually oral contraceptive pills to regulate the cycle. There are lots of different terms we use to describe various types of irregular and abnormal menstrual periods. They're being gradually phased out, but you should probably still be familiar with them. Menorrhagia means heavy or prolonged periods. Metrorrhagia means frequent, irregular periods. So menometrorrhagia means heavy, frequent, irregular periods. Oligomenorrhea is when someone has a cycle length greater than 35 days, resulting in infrequent periods. And the opposite of that is polymenorrhea, which is frequent periods because the cycle length is less than 21 days. Dysmenorrhea means painful periods. Secondary dysmenorrhea is when there is an identifiable cause for the pain, like endometriosis or uterine fibroids. Then the primary dysmenorrhea is painful periods without an identifiable cause. These are basically menstrual cramps. And the first-line pharmacotherapy for primary dysmenorrhea is NSAIDs and/or hormonal contraceptives. So let's talk about hormonal contraceptives. Hormonal birth control contains a progestin plus or minus an estrogen. These work by providing negative feedback at the hypothalamus and the pituitary, which inhibit the release of FSH and LH, and therefore prevents ovulation from occurring. So let's talk about the use of estrogens and progesterones as pharmacotherapy, starting with estrogens. Estrogens are used for hormone replacement therapy and in hormonal birth control, which can be used both for contraception as well as for menstrual irregularities, PCOS, lots of things, not just to prevent pregnancy. But estrogens have some potentially serious side effects, which are worth remembering. Estrogens stimulate endometrial proliferation, so they can lead to endometrial hyperplasia, which can progress to endometrial cancer like we previously mentioned. Estrogens can also promote the growth of other estrogen-responsive cancers such as breast cancer. And estrogens increase the risk of venous thromboembolism like a DVT or a PE. You should also know that estrogens are metabolized by the cytochrome P450 system in the liver, and this may lead to some drug-drug interactions, especially with drugs that induce cytochrome P450. You may remember our mnemonic: Guinness, Coronas, and PBRs induce chronic alcoholism. That stands for griseofulvin, carbamazepine, phenytoin, barbiturates, rifampin, St. John's wort, and chronic alcoholism. So in patients taking any of these medications, the P450 enzymes may be ramped up and the estrogens may be metabolized more rapidly, so the birth control pills may not be as effective. Let's move on to progestins. Progestins are found in hormonal birth control, either alone or together with estrogen. Progestins can also be used to treat abnormal uterine bleeding or to oppose estrogen in women receiving estrogen replacement. Progestins oppose the proliferative effect that estrogen has on the endometrium. So in a woman who still has her uterus, if you're starting estrogen for any reason, you always give a progestin as well. And the main adverse effect that we'll worry about with progestin is irregular bleeding. There's more to contraception than just birth control pills, so let's look at the table in your study guide and review the different types of contraception. First, we have the barrier methods, which include condoms, the diaphragm, and the sponge, as well as a few others. In the real world, these are not as effective as the hormonal methods because of user error, but male condoms do offer the best protection against sexually transmitted infections, including HIV. Next, there are the combined hormonal contraceptives, which contain both estrogen and progestin. These include oral contraceptive pills, OCPs, the transdermal patch, and the vaginal ring. Most of the adverse effects from these combined hormonal contraceptives are due to the estrogen component. So this includes things like venous thromboembolism, hypertension, MI, and stroke. And OCPs are also associated with the development of hepatic adenomas, tumors of the liver. That's worth knowing. There are also some contraceptives that contain progestin only. These include the mini pill, the intramuscular injection of depo-medroxyprogesterone acetate, which is commonly known as Depo-Provera, the implant that's inserted under the skin of the arm called the Nexplanon, which lasts 3 years, and the levonorgestrel IUD, known as the Mirena, which lasts for 5 years, which we have talked about previously. All of these can cause irregular bleeding, but the Depo-Provera has some unique adverse effects. It's the only birth control that has been shown to cause weight gain, although it's usually only a small amount. And it has also been associated with mood changes and, importantly, a decrease in bone mineral density. Definitely know that one. Finally, there's a non-hormonal method that you should be familiar with, the copper IUD. This is a long-lasting method. It lasts for 10 years, but it is also reversible. There is a small risk of uterine perforation when the IUD is being placed, and there is an increased risk of acute pelvic inflammatory disease with IUD use, but that really only occurs in the first 3 weeks after insertion. We started talking about how menarche, when menstruation begins, but now we're going to talk about menopause. Menopause is the permanent cessation of menstruation due to the depletion of the ovarian follicles. You're only born with so many follicles, and when they run out, that's it. The median age of menopause is 51.4 years, and menopause that occurs before the age of 40 is considered pathologic. We call that primary ovarian insufficiency. During menopause, ovarian function ceases and the ovaries stop producing estradiol. So the estrogen levels drop, and this produces a variety of signs and symptoms that we associate with menopause. Our mnemonic for the signs and symptoms of menopause is menopausal symptoms wreak havoc, because a lot of women find these symptoms to be really bothersome and intolerable. The M is for mood changes, especially depression. The S is for sleep disturbances. H is for hot flashes, which are also known as vasomotor symptoms. This is the symptoms that women will complain about the most. A is for atrophy of the vagina, which leads to vaginal dryness, and that leads to dyspareunia, which is pain with intercourse. O is for osteoporosis because bone loss accelerates after menopause. And C is for coronary artery disease. The risk of coronary artery disease increases after menopause. Let's go back and talk a little bit more about the hot flashes, or vasomotor symptoms, since those are so prominent and so bothersome. Hot flashes occur in 75% of menopausal women. Patients will have the sudden onset of heat that starts on the face and chest and then generalizes. It's often accompanied by diaphoresis, sweating, and palpitations, and it can be followed by chills and shivering. Each episode lasts for about 2 to 4 minutes, and women can have multiple episodes per day or at night, which can lead to sleep disturbances. So what can we do about them? The first line therapy is to give estrogen replacement, but SSRIs and SNRIs and gabapentin are other options. And some women prefer alternative medicine, herbal preparations such as soy isoflavones, red clover, black cohosh, and vitamin E. But be aware that some of these can be estrogenic, so you may need to avoid them in patients with breast cancer. So be sure to ask your patients about taking any herbal supplements they may be taking. How do you diagnose menopause? Most of the time you diagnose it clinically after a woman's had 12 months of amenorrhea. You don't need labs to make the diagnosis. She's over 40 and her period stopped, that's menopause, or she's pregnant. But if you were to check the hormone levels, what would you expect to see? Well, the ovaries have stopped producing estradiol and inhibin, so you see a low estradiol and a low inhibin. And without that negative feedback on the hypothalamus and the pituitary, you'd also see high levels of GnRH, FSH, and LH. And just because estradiol is low, that doesn't mean that there's no estrogen around. The adrenal cortex is still producing androgens, and the enzyme aromatase is still converting those androgens to estrone in the adipose tissue. So in a postmenopausal woman, the predominant estrogen present is estrone. For a lot of menopausal women, the mainstay of treatment is to give hormone replacement therapy, or HRT. The symptoms of menopause are primarily due to the drop in estrogen levels. So estrogen is the best treatment for the relief of menopausal symptoms. But there are some caveats to be aware of. As I said before, any woman with a uterus should not receive estrogen alone without progesterone. Unopposed estrogen increases the risk of endometrial cancer. Make sure you know that. Any woman with a uterus who is taking estrogen should also be taking progesterone. Next, hormone replacement therapy should only be used to relieve menopausal symptoms and not for the prevention of chronic diseases like coronary artery disease or osteoporosis. We used to give HRT for those reasons. It hasn't been proven to be beneficial. And generally, the rule of thumb is that we use HRT for the shortest amount of time necessary and at the lowest dose that effectively controls the unwanted symptoms. For instance, hot flashes will stop on their own within 4 to 5 years in most women, even without treatment. So for most women, you shouldn't need to use HRT for longer than 5 years. And finally, the contraindications to HRT are similar to those of OCPs: coronary heart disease, active liver disease, or history of breast cancer, stroke, or venous thromboembolism. Now it's time for the end of session quiz. First question: what is a common cause of irregular bleeding in the first few years after menarche? Anovulatory cycles. And what is the treatment? OCPs, or other hormonal contraception. Next, a 21-year-old college student was started on prophylactic antibiotics following an outbreak of meningococcal meningitis at her sorority house. Despite compliance with her OCPs, she has a positive pregnancy test 4 weeks later. What is the most likely cause? One of the common prophylactic regimens against Neisseria meningitidis is rifampin, which is also an inducer of the P450 system, which metabolizes the estrogen in OCPs. So taking rifampin with OCPs can make the OCPs less effective, which can result in an unintended pregnancy. Next, what hormonal changes are seen during menopause? Low estradiol and low inhibin, which means less negative feedback, leading to a high GnRH, high FSH, and high LH. Last one. Why is progesterone used in combination with estrogen during hormone replacement therapy? Unopposed estrogen increases the risk of endometrial cancer. So in any patient receiving estrogen, if she has a uterus, she needs progesterone as well. That's it for the quiz, but we have one rapid fire fact. Hepatic adenoma is associated with OCP use. That's it for now. See you next time. Good luck.
Let's go over the warm-up. First question, what are the byproducts of MAO and COMT activity on dopamine, norepinephrine, and epinephrine? So dopamine breaks down to HVA, homovanillic acid. Norepinephrine breaks down to VMA, which is vanillomandelic acid. And then epinephrine breaks down to metanephrine. Next, what locations are known for tophi formation in patients with gout? So the external ear is the most common location, and you can also see tophi on the olecranon bursa or the Achilles tendon. And the last question, what's the mechanism of action of the bisphosphonates? So bisphosphonates inhibit osteoclasts, which results in less bone resorption. So osteoblasts are still functioning, so there might be some bone building, but you're definitely going to see less bone resorption. Now let's move on to the lecture.
Hey everybody, welcome back to our Step 1 lecture. Now, before we get started, I just had something I wanted to get off my chest. I know I'm a new lecturer here, but apparently Dr. Lewis thinks he has the best beard at DIT. That's absurd. Everyone can clearly see I have the best beard. I mean, it's not even a contest, is it? In fact, have you guys seen Dr. Lewis's new beard? It reminds me of that Family Guy episode where Peter grows out a beard and ends up having birds living in it. Gross. But I would actually love to know what you think, even though I know it has to be me. So send us a tweet using the hashtag DITBeard and let us know who you think actually has the best beard here at DIT. All right, I feel better. Let's get started. So today we'll focus on the vulva, the vagina, and the cervix. Let's start with a quick review of the anatomy. The vulva is the name for the female external genitalia. This includes the mons pubis, the labia majora, which is where the round ligament of the uterus terminates, the labia minora, which covers the vaginal orifice, and the clitoris and the vestibular glands. The lesser vestibular glands are also known as Skene's glands, and their openings are found around the urethra. Skene's glands are homologous to the male prostate gland. The greater vestibular glands are also called the Bartholin's glands. These are homologous to the bulbal urethral glands in males, and they produce mucus that provides lubrication during intercourse. The duct openings are found at about 5 and 7 o'clock. Sometimes these ducts can get obstructed and inflamed, leading to Bartholin duct cysts, and then a cyst can get infected and become a Bartholin duct abscess. These can become quite large and painful, and just like with any other abscess, the treatment is incision and drainage. On occasion, following incision and drainage, a small catheter is left in the abscess cavity to facilitate prolonged drainage to ensure proper healing. If a Bartholin's abscess recurs in the same location several times, the treatment is marsupialization. Moving on, here you have the vagina, which connects superiorly to the uterus. The body of the uterus is called the corpus, and the skinny, narrow part that opens up to and is contiguous with the vagina is the cervix. The part of the cervix which is exposed at the top of the vagina, and what you would see if you were looking into the vagina during a speculum exam, is the ectocervix. And the inside canal of the cervix as it approaches the uterine corpus is the endocervical canal. The endocervical canal transitions into the endometrial lining, which, as you know, is what grows and recesses each month. Okay, now let's go over the epithelial histology of the female reproductive tract. The vulva is covered by stratified squamous epithelium. The more exposed areas, like the labia majora, are keratinized, whereas the moist areas, like the labia minora, are non-keratinized. The vagina is covered by non-keratinized stratified squamous epithelium, as is the ectocervix, which protrudes into the top of the vagina. The endocervical canal becomes simple columnar epithelium with mucus-secreting cells. This mucus provides an important barrier that prevents infections from ascending up past the cervix and into the body of the uterus. The place where the ectocervix and the endocervix meet is called the squamocolumnar junction. So you transition from the stratified squamous epithelium of the ectocervix to the simple columnar epithelium of the endocervix. Here comes some key information. The squamocolumnar junction lies within a broader area known as the transformation zone. And here you find metaplastic cells that transform from columnar to squamous epithelium, depending on the age and hormonal status of the woman. Because of this, there are immature squamous cells here, and this is important because HPV, human papillomavirus, is able to infect and replicate in these cells really well. So this is where most cervical cancers arise. This is an important point, so let me say that again. The majority of cervical cancers arise at the squamocolumnar junction within the transformation zone. Going back to our epithelial histology, the body of the uterus is lined with simple columnar epithelium. Some of these cells are ciliated and some are secretory, and there are long tubular glands. The fallopian tube contains simple columnar epithelium. Many of these cells are ciliated as well and help to move the egg down the tube. And some of the cells are secretory to provide nutrition to the embryo as it travels down the tube. The resting secretory cells are called PEG cells. And finally, the surface of the ovary is a simple cuboidal epithelium called the germinal epithelium. You'll learn in a later lecture that the majority of ovarian cancers arise from this epithelium. The two items that I would definitely know are the ectocervix and the endocervix, and especially that it's in the transition between the two, and the squamocolumnar junction is where most cervical cancers arise. Now, let's talk about some conditions that affect the vulva, starting with lichen sclerosus. Take a look at your study guide. Lichen sclerosus is an inflammatory condition of the vulva, characterized by thinning of the epidermis. We don't know what exactly causes lichen sclerosus, but it may be due to some kind of immune dysregulation. It tends to occur in prepubertal girls or in postmenopausal women. On exam, you would see these smooth white plaques. It sometimes is described as looking like parchment paper. The lesions are also described as an hourglass shape. This is one trick to remember the bimodal age distribution of lichen sclerosus. Just think of the top half of the hourglass representing kids and the bottom half representing old age, the beginning and end of life. Over time, the scarring can lead to shrinking of the introitus and even fusion of the labia majora and minora. Patients will complain of pain and pruritus, and often dyspareunia, painful intercourse, depending on the extent of the disease. The diagnosis is made by biopsy, and treatment is generally with topical corticosteroids. Lichen sclerosus itself is benign and not pre-malignant, but women who have lichen sclerosus are at an increased risk of developing squamous cell carcinoma of the vulva, so it does need to be monitored. That brings us to our next topic, vulvar cancer, which luckily is relatively rare. The most common type is squamous cell carcinoma, and there are two big risk factors for this. One is having a chronic inflammatory condition of the vulva, like lichen sclerosus, and the other is HPV infection of the vulva. So just like in the cervix, which we'll talk about later in this lecture, HPV infection can lead to vulvar cancer. The oncogenic strain we worry about the most here is 16, although 18 and 31 are also high-risk strains. HPV-related vulvar cancer often coexist with cervical cancer because these cancers have the same risk factors, which we'll cover in a bit. The hallmark finding of HPV infection is called cholocytosis. As the virus replicates in the squamous cells, it produces changes in these cells. If you look at this image, you can see that these cells have enlarged nuclei and perinuclear halos. There's this white perinuclear cytoplasmic clearing. These are cells infected with HPV, and we call them koilocytes. And again, this indicates HPV infection. The other vulvar cancer I want to mention is Paget's disease of the vulva. Like Paget disease of the breast, this is an intraepithelial cancer, meaning that the cancer is in the skin, and in the vulva, this is usually an adenocarcinoma. Patients will present with these red, weepy, well-demarcated skin changes. So it kind of looks like eczema. And like eczema, the main symptom is pruritus. In the majority of patients, the cancer is confined to the skin, but somewhere around 10 to 20% of patients will have an underlying malignancy. I don't think that this is necessarily a high-yield topic, but there seems to be some confusion out there based on what some of the other resources say, so I do want to try and clear some of that up. So again, for both Paget disease of the breast and Paget disease of the vulva, cancer cells are found within the skin. With Paget's disease of the breast, nearly 100% of cases are associated with an underlying breast cancer, meaning that the cancer starts in the breast and then extends to involve the skin. With Paget's disease of the vulva, the majority of cases, 80 to 90%, are thought to arise from the skin and stay confined to the skin. But maybe 10 to 20% will be associated with another neoplasm. So it's not 100% like Paget disease of the breast, but there is a risk of underlying malignancy. Let's move on and talk about vaginal tumors. Primary vaginal cancer is rare, but there are three that you should be familiar with: squamous cell carcinoma, clear cell adenocarcinoma, and sarcoma botryoides. Squamous cell carcinoma of the vagina is associated with infection with the high-risk HPV strains, most frequently 16, 18, and 31. Again, this is similar to cervical cancer, which we'll talk about next. Clear cell adenocarcinoma is a rare tumor of the vagina. It's associated with in utero diethylstilbestrol exposure. DES was a synthetic estrogen that was given to pregnant women in the 40s and 50s to prevent miscarriage. DES use during pregnancy is also associated with Mullerian duct anomalies, specifically a T-shaped uterus and something called vaginal adenosis. What type of epithelium do you normally find on the ectocervix and vagina? We said squamous, right? Well, vaginal adenosis is when you find patches of columnar epithelium on the ectocervix and vagina. So for DES exposure during pregnancy, remember clear cell adenocarcinoma of the vagina, Mullerian duct abnormalities, and vaginal adenosis. Sarcoma botryoides is also known as embryonal rhabdomyosarcoma. This is a rare cancer, and it usually occurs in infants and children, usually under the age of 5. It gets its name from the Greek word meaning bunch of grapes, because these tumors can look like grape-like masses as they grow out of the vagina. So if you see this, think sarcoma botryoides. I want to spend the rest of this lecture talking about cervical dysplasia and cervical cancer. Worldwide, cervical cancer is the 4th leading cause of cancer death in women, but it's not even in the top 10 in the US. And that's because we have great screening for cervical cancer. Screening works because you get cervical dysplasia first, and then that can progress to cervical cancer. But since it takes time, we have a chance to catch it before it becomes cancer. Before we get to screening, let's go over some of the basics. What are the risk factors for cervical dysplasia and cancer? Well, the big one is persistent infection with a high-risk HPV strain. There are something like 15 high-risk strains, but the ones you need to remember for cervical cancer are 16 and 18. These two strains account for 70% of cervical cancer cases. So it makes sense that most of the other risk factors are things that increase your risk of acquiring HPV or affect your ability to clear HPV infection. So, for example, early coitarchy, so early age of first intercourse, and having multiple sexual partners or having a partner with multiple sexual partners. Immunosuppression, for example, HIV infection is a risk factor. Smoking, because it impairs the immune system as well. OCP use is a risk factor because they don't protect against HPV infection, and history of STDs. Okay, so how exactly does HPV infection lead to cancer? Well, the high-risk strains, 16 and 18, produce the oncogenes E6 and E7. The E6 gene product binds to p53, causing it to be degraded, and the E7 gene product binds to and inactivates RB. Remember that RB and p53 are tumor suppressor proteins that help regulate the cell cycle. RB controls the G1S checkpoint by binding to and inactivating the E2F transcription factor, which transcribes genes needed for DNA replication. So RB is always there, putting the brakes on the transition. But the E7 protein binds to RB such that RB can't bind to E2F anymore, so then DNA replication proceeds. p53 normally senses DNA damage and stops the cell cycle so that the DNA can be repaired. And it can do this either at the G1 to S checkpoint or at the G2 to M checkpoint. If the DNA can't be repaired, p53 will tell the cell to undergo apoptosis. The HPV-E6 protein binds to p53 and causes p53 to be degraded. So the end result is that you lose control of the cell cycle, and these cells replicate unchecked and eventually can become cancer. The majority of these cancers are squamous cell carcinoma, but there are some adenocarcinomas as well. I think one of the reasons cervical dysplasia is so confusing is because there are a bunch of different names used to describe the lesions, coming from multiple different classification schemes. So let's clear that up. So this is pertaining to histology, what you see in the tissue. These are the findings you would see from getting a biopsy. The important thing to know is that you divide the epithelium into thirds and then base your diagnosis on how much of the epithelium is affected. So if the abnormal cells are confined to the bottom third of the epithelium, that can be called mild dysplasia, CIN1, or low-grade SIL. CIN stands for cervical intraepithelial neoplasia, and SIL stands for squamous intraepithelial lesion. If 2/3 of the epithelium is affected, this is moderate dysplasia, CIN2, or high-grade squamous intraepithelial lesion. If more than 2/3 of the epithelium is affected, that's severe dysplasia. Carcinoma in situ is if there's full thickness involvement. These both fall under CIN3 and again, high-grade squamous intraepithelial lesion. And then there's invasive carcinoma is when there's invasion through the basement membrane. Clinically, it's most useful to use the Bethesda system with L-sil and H-sil. And that's because most L-sils will regress, so those can just be monitored unless a patient has long-standing persistent L-sil, whereas H-sil is precancerous and needs to be excised right away. So how do we screen for cervical dysplasia and cancer? I don't think for step 1 you need to know the specific guidelines, but you do need to understand the basic concepts. The main screening modality we use is the Pap test. Basically, you twirl a little brush or wand around the cervical os to scrape cells off the cervix, specifically targeting the transformation zone, and then the pathologist looks at the cells under the microscope. You're looking for koilocytes, those cells that indicate HPV infection, and you're looking for other abnormalities like darkening of the nuclei or an increased nucleus to cytoplasm ratio. So take a look at this image. This cell over here is an example of a normal squamous cell. You can see that it has a small nucleus with lots of cytoplasm around it. But then take a look at these cells. They have big nuclei and scant cytoplasm. These are actually CIN3 cells, so pretty severely dysplastic. In women over the age of 30, we can add HPV DNA testing in addition to doing the Pap test, and that allows you to space out the screening interval. In fact, the FDA recently approved the HPV DNA test to be used alone as a primary screening tool, so we may see some changes to screening guidelines in the near future. It also remains to be seen how the HPV vaccine may or may not change screening guidelines. There are 3 HPV vaccines available. These are effective in preventing HPV infection and cervical dysplasia. All of them protect against the strains 16 and 18, the high-risk oncogenic strains. And then 2 of the vaccines also cover additional strains, including type 6 and 11, which cause 90% of genital warts. So do know that there are HPV vaccines available and that they prevent cervical cancer. These vaccines are available to males and females from the ages of 9 to 26. So if you can vaccinate children before they become sexually active, you would dramatically reduce their risk of carrying high-risk HPV and therefore the risk of cervical cancer. This can save many lives. Keep it in mind. But say someone doesn't undergo regular screening and they develop cervical cancer. How will they present? The most common symptom is abnormal vaginal bleeding, irregular bleeding, or especially postcoital bleeding. Patients will often describe they will spot for a day or so after intercourse, similar to the beginning of a period. Once the cancer gets really invasive, the bleeding will tend to get heavier. Cancerous lesions on the surface of the cervix can contain friable tissue and superficial blood vessels that are disturbed with intercourse, and that's what causes the postcoital bleeding. Patients can have a non-specific vaginal discharge, pelvic or low back pain. This is due to the cancer invading the surrounding tissue, including the perimetrium and vaginal sidewalls. If the cancer has spread further, you may have bladder and bowel symptoms. An invasion of the ureters can cause ureteral obstruction, which can lead to pyelonephritis, uremia, and renal failure. Something unique about cervical cancer is that it's staged clinically rather than surgically, like most other cancers. And then the treatment will depend on the stage of the disease, but generally will consist of surgery plus or minus chemoradiation. Okay, that's it for the lecture. Now it's time for the end of session quiz. Let's go over the answers. First question. What type of epithelium covers each of the following structures? Ectocervix is non-keratinized stratified squamous. Endocervix is mucus-secreting simple columnar. And the fallopian tube is ciliated simple columnar. Next, what conditions are associated with diethylstilbestrol use during pregnancy? Clear cell adenocarcinoma of the vagina. Mullerian duct anomalies. Vaginal adenosis. Next, what are the risk factors for cervical cancer? HPV infection, and remember the high-risk strains 16 and 18. Early coitarchy, multiple sexual partners or having a partner with multiple sexual partners, immunosuppression, smoking, OCP use, and history of STDs. And the last question, what is the mechanism by which HPV facilitates oncogenesis? The E6 oncogene product binds to p53 and causes it to be degraded. And the E7 oncogene product binds and inactivates RB. And the end result of these actions is that the DNA replication and the cell cycle go unchecked and become uncontrolled. And we have a couple of rapid-fire facts. Grape-like vaginal tumor, that's sarcoma botryoides. Koilocytes, those are those cells with perinuclear halos, and they indicate HPV infection. Okay guys, that's the end of this video. And don't forget to let us know who you think has the best beard. Hashtag DITbeard.
Let's go over the answers to the warm-up review. First question, what are the risk factors for osteoporosis? So you have older age, smoking, glucocorticoid use, chronic heparin use, being white or being Asian, being thin, not exercising, poor calcium and vitamin D intake, and then low testosterone and low estrogen. So thin, elderly, white women who are postmenopausal have a very high risk of osteoporosis. Next, a man presents with exquisite pain and swelling in the MTP joint of his right great toe. Joint aspiration reveals needle-like crystals. So what's the diagnosis? This is gout. Then the last question, which structure connects epithelial cells to the basement membrane? Those are the hemidesmosomes. And then which structure connects adjacent epithelial cells to each other? It's the desmosomes. Now we're ready to get started with the lecture.
Hey everybody, welcome to our video on ovarian pathology. In this video, we'll be talking about problems that can occur with the ovaries, and a good portion of this lecture will be focused on the very high yield topic of polycystic ovarian syndrome. But first, let's start by reviewing some basics about the ovary. The ovary has two basic functions. One is the production of mature eggs, and the other is the production of steroid hormones, namely estradiol and progesterone. You've seen this image before. Remember that every month, under the influence of FSH, a group of primordial follicles starts undergoing maturation. Of that group, one follicle becomes dominant and reaches full maturation while the other follicles become atretic. And that one mature follicle is called the Graafian follicle. Following the LH surge, the Graafian follicle will rupture and release its egg. That is, of course, ovulation. And then what's left of the Graafian follicle becomes the corpus luteum and will produce estradiol and progesterone. If fertilization does not occur, the corpus luteum degenerates after about 2 weeks. So that's what is supposed to happen. Well, at certain points during this process, ovarian cysts can develop. These are called functional cysts or sometimes physiologic cysts. These are extremely common and normal. Do you have 2 X chromosomes? Then you've had or will have one of these. A follicular cyst develops if the Graafian follicle does not rupture at ovulation and instead continues to grow. Most of these will regress spontaneously. A corpus luteum cyst develops if the corpus luteum doesn't degenerate. Remember, it's supposed to involute after about 2 weeks if fertilization doesn't occur, or about 6 weeks if pregnancy does occur. But sometimes the corpus luteum will persist even longer and continue to grow larger, filling with fluid. And these usually resolve spontaneously as well. First aid lists a couple of other types of ovarian cysts. Thecal lutein cysts develop because of high HCG levels. So these are associated with multiple gestations, molar pregnancies, gestational trophoblastic disease, and assisted reproductive techniques. These can be bilateral and often occur in multiples. Dermoid cyst. This is another name for a benign cystic teratoma. These can contain tissues derived from multiple germ layers. We'll talk about these more in another lecture. Hemorrhagic cyst is a kind of general term for any ovarian cyst that contains blood. So, for example, corpus luteum cysts are frequently hemorrhagic. And endometrioid cyst. We talked about this when we discussed endometriosis. This is due to endometriosis in the ovary, which leads to cyclic bleeding within the ovary. We also call this an endometrioma or a chocolate cyst of the ovary. One thing you worry about with ovarian cysts or ovarian masses in general is torsion. This is in your study guide. Ovarian torsion is analogous to testicular torsion. This is where the ovary twists on its supportive ligaments and it can cut off its blood supply, leading to ischemia and eventually necrosis. So this is considered an emergency. The risk of torsion increases if there is an ovarian mass greater than 5 centimeters because the mass acts as a counterweight, facilitating the twisting. So it's generally recommended that persistent masses greater than 5 centimeters be removed. Patients with ovarian torsion will have acute onset of severe pelvic pain. It's often described as sharp or stabbing, and it can radiate to the back or to the groin. And they will often have nausea and vomiting as well. The diagnosis is generally clinical, but a pelvic ultrasound may demonstrate decreased blood flow to the ovary, and treatment is surgery to detorse the ovary. However, if the blood supply to the ovary has been compromised for some time, on laparoscopy, you will see a dark, necrotic ovary. At that point, the only thing you can do is remove the entire necrotic ovary. Now let's talk about polycystic ovarian syndrome, or PCOS. This is a high-yield topic, a 4-star topic, so you're likely to see this on your test. And actually, you're pretty likely to see this in practice as well, since PCOS is extremely common, affecting up to 12% of reproductive aged women. Even so, we still haven't figured out what exactly causes PCOS, and it actually might be due to several different processes, which together result in hormonal dysregulation and a loss of that cyclic pattern to the female reproductive cycle. One thing we see is elevated LH levels. This is thought to be due to disordered release of GnRH, leading to more LH being secreted than FSH. So the LH-FSH ratio increases to greater than 2:1. Remember the 2-cell theory of estradiol production? LH stimulates the theca cells in the ovaries to produce androstenedione. So high levels of LH will lead to an increased production of androgens. And if you have a relative deficiency in FSH, then not all of that androstenedione will be converted to estradiol by the granulosa cells. So one of the main findings in PCOS is elevated androgens, hyperandrogenism. PCOS is also associated with insulin resistance and therefore elevated insulin levels. Well, insulin can also stimulate theca cells to produce androgens, contributing to the hyperandrogenism. Some of those androgens are converted to estrone in the periphery by the enzyme aromatase, which is found in adipose tissue. The estrone feeds back at the HPO axis, but in an unregulated, chronic manner that further prevents normal ovulatory cycles. Estrone also stimulates proliferation in the endometrium. And then, patients with PCOS have decreased levels of sex hormone binding globulin, or SHBG. This is produced by the liver, and its synthesis is suppressed by androgens and insulin. So, lower levels of SHBG mean that there's less of it available to bind circulating estrogens and androgens. And that means there's more free hormone floating around exerting its effects. Look at your study guide. It asks what hormonal abnormalities are seen in polycystic ovarian syndrome. So we said LH is increased, as is the LH to FSH ratio. There is an increase in androgens, an increase in estrogens, specifically estrone, the type produced in the adipose tissue. There's decreased levels of sex hormone binding globulin, which isn't a hormone, but that means that there's increased levels of free hormones. And there are elevated insulin levels as well. Okay, so those abnormalities come together to create a syndrome, a constellation of symptoms. We make the diagnosis of polycystic ovarian syndrome based on symptoms we tend to see in patients. You need to at least 2 of the following 3 things to make the diagnosis. Oligoovulation or anovulation. This manifests as menstrual irregularities and infertility. Next, hyperandrogenism. You can check labs and actually measure elevated levels. Or this can be clinical evidence of excess androgens like acne or hirsutism. Hirsutism is where you have the growth of terminal hairs, those coarse pigmented hairs in a male pattern like on the upper lip, chin, sideburns, and lower abdomen. So with PCOS, the hyperandrogenism causes masculinization. What you don't really see is virilization, like clitoromegaly or deepening of the voice. Those require higher levels of androgens. So if you see that, you should think of an androgen-secreting tumor or exogenous steroid abuse. And then the last criterion is polycystic ovaries on the ultrasound. So if you get an ultrasound, the ovaries will be enlarged and have a bunch of these little follicles along the periphery. Sometimes this is called the string of pearls sign. So oligoovulation or anovulation, hyperandrogenism, and polycystic ovaries on ultrasound. You need at least 2 of those things to make the diagnosis. Not part of the diagnostic criteria, but frequently associated with PCOS are obesity, insulin resistance, and infertility, like I mentioned before. And one more thing that's actually really important for you to know is that these patients are at increased risk for endometrial hyperplasia, which can develop into endometrial cancer. Remember we said that the main risk factor for endometrial hyperplasia is excess of unopposed estrogen? With chronic anovulation, patients with PCOS don't have that progesterone half of the menstrual cycle that opposes the estrogen stimulation. So part of the management of PCOS includes decreasing that risk of endometrial hyperplasia. And what is the management of PCOS? Well, first-line therapy is diet and exercise to achieve weight loss. In some patients, that is enough to cause ovulatory cycles to resume. First-line pharmacotherapy is OCPs. OCPs feed back and inhibit the release of LH and FSH, which decreases androgen production and helps with hirsutism. The estrogen component also increases the sex hormone binding globulin levels, reducing the levels of free hormones. And the progesterone component decreases the risk of endometrial hyperplasia. Cyclic progestins alone can also be used to protect against endometrial hyperplasia. Spironolactone is sometimes used to help with hirsutism. Spironolactone is an aldosterone receptor antagonist, but it also has anti-androgenic properties. Metformin is a treatment option. In many patients, metformin is enough to bring back ovulatory cycles. And then clomiphene is used for ovulation induction in patients who wish to become pregnant. Let's talk about clomiphene in more detail. Clomiphene is one of the first-line medications used in the treatment of infertility due to anovulation. It's classified as a SERM, a selective estrogen receptor modulator. So depending on the target tissue, it can act as an agonist or an antagonist. In the hypothalamus, clomiphene binds to estrogen receptors and prevents the more potent endogenous estrogens from binding. By doing this, clomiphene blocks the negative feedback of the estrogens and that leads to an increased release of FSH and LH from the pituitary, leading to ovarian follicle maturation and ovulation. So clomiphene is used for ovulation induction. Side effects of clomiphene include hot flashes due to clomiphene blocking the estrogen receptors at the hypothalamus, ovarian enlargement, multiple gestations, and visual disturbances like blurred vision or scotomata. These are thought to be due to retinal toxicity and are generally reversible. We've now talked about clomiphene and leuprolide for treating infertility. Let's finish by going over infertility itself. The definition of infertility is the inability to conceive after 1 year of unprotected intercourse. We use that time cutoff because 85% of couples attempting to conceive will be successful within 1 year. What are some of the causes of infertility? Well, we generally say that 1/3 of the cases can be attributed to the female, 1/3 to the male, and 1/3 to both. What are some of the female causes of infertility? I mentioned that PCOS was the most common cause due to anovulation. Remember that endometriosis is associated with infertility, as are uterine fibroids. And an important cause of infertility is pelvic inflammatory disease, PID. This is an ascending affection of the female reproductive tract, and this can lead to scarring and obstruction of the fallopian tubes. The tubes become dilated and filled with a fluid that's thought to be toxic to the development of embryos. A fallopian tube that has this appearance is known as a hydrosalpinx. On ultrasound, these tubes appear as S-shaped fluid-filled structures that appear anechoic, which means they appear black on the screen. So a history of PID is definitely a risk factor for infertility. Certain chromosomal abnormalities. For example, patients with Turner syndrome can have streak ovaries that don't function normally. One more that I want to mention is intrauterine adhesions that develop after a DNC. Do you remember what that's called? Asherman syndrome. Asherman syndrome is usually when intrauterine adhesions develop, usually after a DNC. This list isn't exhaustive, but I think you should be able to recognize these. Let's move on to the evaluation. When you're working up infertility, you're basically looking at 3 things. Is she ovulating? Is there a problem with her reproductive anatomy? Is there a problem with his semen or sperm? That last one's pretty easy to assess. You get a semen analysis. But what about the other 2? There are a number of things you can look for to help you determine if a woman is having ovulatory cycles. This is in your study guide. Cyclic menses are an indication of ovulatory cycles. Some women will actually feel a little bit of pain when they ovulate. This is called Mittelschmerz, and it's thought to be due to peritoneal irritation from the fluid and blood that's released along with the egg. You can look for an LH surge. This is how those ovulation predictor kits you can buy from the drugstore work. They measure LH levels in the urine. There has to be an LH surge for ovulation to occur. And then, if a woman is monitoring her basal body temperature, you should see a 0.5 degree rise in her temperature after ovulation due to an increase in progesterone during the luteal phase. How do you evaluate the female reproductive anatomy? Physical exam might be helpful there, but one of the best ways to assess the uterine cavity and the patency of the fallopian tubes is hysterosalpingography. To get a hysterosalpingogram, you insert a catheter through the cervix into the uterus and then inject contrast dye and take an x-ray. You should see the dye fill the uterus and flow through each of the fallopian tubes and then out the ends of the tubes into the pelvic cavity. If you don't see that dye coming out, then you worry about an obstructed fallopian tube, maybe from scarring secondary to PID. That's it for the lecture. Now it's time for the end of session quiz. First question, which type of ovarian cyst matches each of the following descriptions? Forms from an unrupted Graafian follicle. That's a follicular cyst. Forms if the corpus luteum fails to involute. That's a corpus luteum cyst. Associated with high HCG levels are theca-lutein cysts. Contains tissue from multiple germ cell layers. That's a dermoid cyst, also called a benign cystic teratoma. Chocolate cyst of the ovary is an endometrioid cyst or endometrioma, which is endometriosis of the ovary. Next, what are the clinical manifestations of polycystic ovarian syndrome? Patients with PCOS will have menstrual irregularities like amenorrhea, oligomenorrhea, or menometrorrhagia, hirsutism and acne from hyperandrogenism. Obesity is frequently seen, impaired glucose tolerance due to insulin resistance, and infertility is common in patients with PCOS. Next, a patient with polycystic ovarian syndrome is at increased risk for developing which type of cancer? Endometrial cancer. What is the mechanism of action of clomiphene? Clomiphene binds to the estrogen receptors in the hypothalamus, preventing the more potent endogenous estrogens from binding. This leads to a decrease in the negative feedback and therefore an increase in the secretion of LH and FSH, leading to follicle maturation and ovulation. We have 2 rapid-fire facts. Most common cause of infertility in women is PCOS. Mid-cycle pelvic pain associated with ovulation. That's called Mittelschmerz. Okay guys, that's it for this video.
It's time for another warm-up. Let's get going. Patients with which congenital heart defects would benefit from an increase in afterload? So really any type of right to left shunt will benefit from an increasing afterload. So that's like tetralogy of Fallot, transposition of the great vessels, truncus arteriosus, or if there is Eisenmenger syndrome with a VSD, an ASD, or a PDA. And then what maneuver will increase afterload? Well, you have the patient squat, or if this is an infant, you can actually squat for them by pushing the patient's knees to the chest. Next, what drugs can we use to reverse neuromuscular blockade? Well, it's going to be the cholinesterase inhibitors. Things like neostigmine is the prototype drug that's used for this. And remember that that's only for neuromuscular blockade with a non-depolarizing drug like tubocurarine or vecuronium. Next, which psychiatric disorder is associated with increased levels of norepinephrine? So think about things like anxiety or maybe mania. All right, that brings us to the end of the warm-up. Let's get to that lecture now.
Welcome back. I know you're all voting for my beard in our hashtag DIT beard contest, but it came to my attention recently that Dr. Mike is now trying to throw his hat in the ring and claim that he has the best beard, or at least that he had the best beard before he shaved it. He can't do that. There's no, well, I would beat you if only I had the beard in this game. But worse than that, he actually is taken to making fun of my name. My name? Who does that? What are we in the 3rd grade? That's so immature and childish, and frankly, I expected more from a doctor. But let's give him the benefit of the doubt and take a look what his beard used to look like. Actually, that's not bad. I'm impressed. But that still doesn't change anything. My beard is the best and Dr. Mike is a doo-doo head. In this video, we'll be talking about ovarian neoplasms. There are a bunch of these, and I know it can get complicated and confusing, but hopefully this lecture will help to clear things up. Let's start with an overview of ovarian cancer in general. Ovarian cancer is not as common as uterine or cervical cancer, but it causes more deaths than both of those other 2 cancers combined. This is because we don't have a good screening test for ovarian cancer, so we can't catch it while it's asymptomatic. And many of these really don't produce symptoms until late in the disease course, so patients tend to present after the cancer has already spread. What kind of symptoms can they have when they do present? Well, they can have ascites, abdominal distension, and abdominal pain, which can lead to nausea and early satiety, vaginal bleeding, and also patients can have urinary problems if the cancer spreads to involve the bladder or the ureters. So these are pretty nonspecific, but ascites in an otherwise healthy woman should definitely make you think of ovarian cancer. What are some of the risk factors for ovarian cancer? The big one is family history, especially a history of a heritable syndrome like mutations in the BRCA1 or 2 genes, which can be associated with breast cancer and ovarian cancer, and Lynch syndrome, which is another name for hereditary non-polyposis colon cancer. These patients are at risk for colon cancer, endometrial cancer, and ovarian cancer. The other big risk factor is uninterrupted ovulatory cycles. So going along with this are nulliparity, infertility, early menarche, and late menopause. And things that decrease the number of ovulatory cycles are protective. So increasing parity, breastfeeding, and OCP use are actually associated with a lower risk of ovarian cancer. In fact, a large systemic review indicated that combined hormonal contraceptive use for 1 year confers a risk reduction of 33 to 80% and 58 to 63% for BRCA1 and BRCA2 carriers, respectively. As I mentioned before, there is no recommended screening for ovarian cancer in the general population. There is a serum tumor marker associated with ovarian cancer, CA125, but because this is a glycoprotein produced by mesothelial cells that line the peritoneal, pleural, and pericardial cavities, CA125 levels are very nonspecific and can be elevated in women with adenomyosis, leiomyomas, endometriosis, pelvic infection, pregnancy, and non-gynecologic malignancies, basically any cause of peritoneal irritation. So it's not used for screening, but it is sometimes used to monitor disease progression and response to therapy. Okay, let's start talking about some of these tumors. When thinking about ovarian tumors, I think it's helpful to group them based on where they come from. The outside of the ovary is covered by a surface epithelium. Most ovarian tumors arise from this surface epithelium, and we call those epithelial tumors. Underneath the surface epithelium is the stroma of the ovary, which is derived from the sex cords during development. This is where we find the cells that produce the hormones. We call the tumors that come from here the sex cord stromal tumors. The last group of ovarian tumors is in the germ cell tumors, which come from the primordial germ cells, the pluripotent cells that normally become the oocytes. So look at number 4 in your study guide. What are the 4 main categories of ovarian tumors? We said epithelial tumors, sex cord stromal tumors, and germ cell tumors. And then the last one is metastatic tumors, tumors that come from elsewhere in the body and then spread to the ovaries. So let's get into the specific tumors, starting with the epithelial tumors. These are the most common type of ovarian neoplasm. They make up 65 to 70% of all ovarian tumors and 90% of the malignant ovarian tumors. These tend to occur in middle-aged women in their 40s to 60s, and as a group, these are often bilateral. The malignant forms have a poor prognosis because these are often found late. The 2 most common types are the serous tumors and the mucinous tumors. The benign form of a serous tumor is called a serous cystadenoma, and then the malignant form is serous cystadenocarcinoma. Just like the name says, these are cystic and filled with serous fluid. It's now thought that at least some of these, specifically epithelial cancers found in patients with known BRCA mutations, actually originate in the fallopian tube. So it makes sense that these have fallopian tube-like epithelium, meaning ciliated columnar epithelium. In fact, many gynecologic oncologists recommend completely removing the fallopian tubes instead of performing tubal ligations and taking out the fallopian tubes routinely during hysterectomies, as this may decrease the incidence of these epithelial ovarian cancers down the line. On histology, you'll see psammoma bodies, these concentric calcifications. If you see psammoma bodies in the ovary, that's pathognomonic for a serous tumor. With mucinous tumors, you also have the benign form, mucinous cystadenoma, and the malignant form, mucinous cystadenocarcinoma. These tumors are typically multiloculated and filled with mucin, which is a sticky gel-like substance. And these can get quite large, up to 50 pounds. Several months ago, a woman presented to the ER with abdominal pain and a long history of a slowly enlarging abdomen. She thought she was slowly putting on weight due to her diet. Come to find out, she had one of these tumors, filled with 28 liters of fluid. Saying she felt as light as a feather after she woke up from anesthesia would be putting it mildly. Under the microscope, these can look similar to gastric or intestinal tissue. One term you should be familiar with is pseudomyxoma peritonei. This is when someone has abundant mucinous ascites. So you open up the belly and it's just filled with gelatinous substance. And historically, this was attributed to mucinous ovarian tumors because usually the ovaries would be involved. But now, the thinking is that these are actually probably due to a primary cancer in the appendix and not the ovaries. Next is the endometrioid tumors. These are malignant tumors and they're called endometrioid because they look like endometrium. So you'll see tubular glands. Some of these, about 20%, are associated with endometriosis. Up to 30% coexist with endometrial cancer, and it's thought that these two cancers arise independently. So endometrioid tumors are associated with endometriosis and endometrial cancer. Next are the clear cell tumors. These are now considered a variant of endometrioid cancer. And they're called clear cell tumors because they're made up of cells that have clear cytoplasm. That's pretty easy. These are typically poorly differentiated and carry a poor prognosis. The last epithelial tumor is the Brenner tumor. What you need to know about Brenner tumors is that they're benign and they resemble the epithelium of the urinary tract. So those are the epithelial ovarian tumors. One way you can remember them is the mnemonic: serous epithelial malignancies are clearly bad. S is for serous, the most common type. E is for endometrioid. Then you have mucinous, clear cell, and B for Brenner tumor. Let's move on to the germ cell tumors. These are analogous to the testicular germ cell tumors in males. Germ cell tumors tend to be unilateral, although some can be bilateral. These tend to affect younger women in their teens and 20s, and sometimes even children. Most germ cell tumors are highly responsive to chemotherapy, so the prognosis for these is generally excellent. So let's start with teratomas, which are also commonly referred to as dermoids. These are characterized by multiple tissue types and can even contain tissue from all three germ layers, meaning endoderm, mesoderm, and ectoderm. You'll commonly see hair and sebaceous or oily material, but sometimes you can see teeth and bone or really anything. Benign teratomas contain mature tissue, and they're also called benign cystic teratomas or dermoid cysts. Malignant teratomas are characterized by immature tissue, most commonly immature neuroectoderm. There's a special type of teratoma called struma ovari. This is a teratoma that contains mature functional thyroid tissue. So this thyroid tissue produces thyroid hormones, and patients can actually develop hyperthyroidism. So think of struma ovari in a patient with hyperthyroidism and an ovarian mass. The next germ cell tumor is dysgerminoma. This is analogous to the seminoma in males. These are malignant and they produce HCG and LDH. Just like in seminomas, you'll see sheets of these large cells with clear cytoplasm and central nuclei. These are often described as having a fried egg appearance. Next is the yolk sac tumor. These used to be called endodermal sinus tumors, so you may see that term. These are malignant. And they produce AFP, so that's used as a tumor marker. Under the microscope, you see these glomerulus-like structures called Schiller-Duval bodies. So you see a central vessel surrounded by tumor cells, and then this whole thing is inside of a cystic space lined by tumor cells. So that's a Schiller-Duval body, and that's pathognomonic for a yolk sac tumor. Your review book may include ovarian choriocarcinoma. These are extremely rare, and I think if they ask you about choriocarcinoma, it'll be a question about a placental choriocarcinoma arising after a pregnancy, which we'll cover in one of the pregnancy lectures. So I'll just mention here that choriocarcinomas produce HCG and can metastasize to the lung. Next, let's talk about the sex cord stromal tumors. These can occur in women of any age and tend to be unilateral. And the most important thing about the sex cord stromal tumors is that some of them produce hormones, which can lead to symptoms. So these are actually often discovered at an early age, so the prognosis of these is pretty good. Let's start with the granulosa cell tumors. These do have the potential to be malignant. These can occur in children, but most are found in postmenopausal women. And the important thing to know is that they produce estrogen. So in children, this can lead to precocious puberty. And then in older women, this can cause abnormal vaginal bleeding, postmenopausal bleeding, and even endometrial hyperplasia and cancer. Remember that endometrial cancer is caused by prolonged stimulation by excess estrogen. So granulosa cell tumors produce estrogen, which can lead to endometrial cancer. Grossly, these will often appear yellow because they're filled with cholesterol that's needed to synthesize estrogen. And then on histology, you'll see Call-Exner bodies. In a normal ovary, the granulosa cells surround the oocyte in the follicle. So that's what these Call-Exner bodies are. The granulosa cells trying to make ovarian follicles. So you'll see these rosettes of tumor cells surrounding eosinophilic spaces. Next, let's talk about the Sertoli-Leydig tumors. In males, the Sertoli cells line the seminiferous tubules, and the Leydig cells produce testosterone. So Sertoli-Leydig tumors sometimes can look like seminiferous tubules, and they can produce androgens, which can lead to virilization. So women will develop hirsutism, deepening of the voice, and clitoromegaly. Like granulosa cell tumors, these contain cholesterol, so they look yellow grossly. And these can be malignant, but typically are caught early, so the prognosis is good. Next is the fibroma. These arise from fibroblasts. These are encapsulated, solid, and firm tumors. Fibromas do not produce hormones. One thing you should know about fibromas is that they are associated with Meg syndrome. What is Meg syndrome? It's an ovarian tumor plus ascites plus hydrothorax, which is basically a pleural effusion. So fibromas are associated with Meg syndrome. And the last tumor is the thecoma. These come from spindle cells, but sometimes will be mixed with cells that can produce estrogen. So some thecomas produce estrogen, and you can get precocious puberty or postmenopausal bleeding or endometrial cancer, just like with granulosa cell tumors. All right, so we've covered the 3 classes of primary ovarian cancers. Let's review those now. This is number 5 in your study guide. The epithelial tumors include serous, mucinous, endometrioid, clear cell, and Brenner. Under germ cell tumors, you have teratoma, dysgerminoma, yolk sac, and choriocarcinoma. And then your sex cord stromal tumors are granulosa cell, Sertoli-Leydig, fibroma, and thecoma. The epithelial tumors tend to affect middle-aged and postmenopausal women, so 40s to 60s. The germ cell tumors affect younger females, teens to early 20s. And the sex cord stromal tumors can affect women of all ages. The epithelial tumors are often bilateral, especially the malignant serous tumors and the endometrioid tumors. The germ cell tumors tend to be unilateral, but 15% of teratomas are bilateral. And the sex cord stromal tumors are usually unilateral as well. Under the benign epithelial tumors, you have serous cystadenoma, mucinous cystadenoma, and Brenner tumor. For the germ cell tumors, you have mature teratoma. And for the sex cord stromal tumors, fibroma and thecoma. The malignant epithelial tumors are serous cystadenocarcinoma, mucinous cystadenocarcinoma, endometrioid, and clear cell. And then most of the germ cell tumors, immature teratoma, dysgerminoma, yolk sac, and choriocarcinoma. And then up to 25% of granulosa cell tumors and up to 20% of Sertoli-Leydig tumors can be malignant. We said that the prognosis for malignant epithelial cancers is generally poor because these are found late. For the germ cell tumors, it's excellent because these tend to respond really well to chemotherapy. And the prognosis for sex cord stromal tumors is good because many of these are found early. Now, briefly, let's talk about some cancers that metastasize to the ovaries. You should think of metastasis when you see involvement of both ovaries bilaterally. Most commonly, mets will come from somewhere nearby, the uterus, the fallopian tube, the other ovary, but there can also be metastasis from the GI tract or the breast. The one you should definitely know is Krukenberg tumor. This is gastric adenocarcinoma that metastasizes to the ovaries bilaterally. On histology, you'll see signet ring cells. These cells are filled with mucin, so the nuclei get pushed to the periphery. If you see signet ring cells in the ovary, think Krukenberg tumor and gastric adenocarcinoma. I want to finish by reviewing some pathology images. So I'll show you an image, and I want you to try and identify the ovarian tumor. Let's start with an easy one. This has hair and teeth, so this is a teratoma. Here, the arrows are pointing at the important findings. These are psammoma bodies, those concentric calcifications, and when you see these in an ovary, that's pathognomonic for a serous tumor. What you should notice here are these rosettes of cells around a central eosinophilic lumen. These are trying to make ovarian follicles, so these are called Exner bodies, and this is a granulosa cell tumor. Again, the arrows are pointing at the finding. There's a central vessel surrounded by tumor cells, and this whole thing is in a cystic space lined by tumor cells. So these are Schiller-Duval bodies, which are pathognomonic for yolk sac tumor. Here you see sheets of cells filled with clear cytoplasm and central nuclei. This should make you think of fried egg cells. So this is a dysgerminoma. Okay, this is the last one. What do you see? Signet ring cells, right? Notice how the nuclei are pushed all the way to the periphery of the cells. When you see signet ring cells in the ovary, think Krukenberg tumor and metastatic gastric adenocarcinoma. All right, that's it for the lecture. Now it's time for the end of session quiz. Let's go through the answers. First question, what are the risk factors for ovarian cancer? Family history, especially something like Lynch syndrome or BRCA1 or 2 mutation, and then things associated with uninterrupted ovulatory cycles like nulliparity, infertility, early menarche, and late menopause. Next, which ovarian neoplasm is associated with each of the following statements? Estrogen producing, precocious puberty or postmenopausal bleeding. That's granulosa cell tumor and some thecomas. Androgen producing virilization. That would be Sertoli-Leidig tumor. Contains fallopian tube-like epithelium. That's serous tumors. Contains urinary tract-like epithelium. You see that with Brenner tumors. Historically associated with pseudomyxoma peritoni. That's mucinous tumors, but remember, pseudomyxoma peritoni is probably caused by appendiceal cancers. Next, which ovarian neoplasm is associated with each of the following histological findings? Schiller-Duval body is seen in yolk sac tumors. Call Exner body. That's granulosa cell tumors. Samoma body is serous tumor. Fried egg cells. Think dysgerminoma. And the last question, which ovarian neoplasm is associated with each of the following tumor markers? AFP. That's yolk sac tumor. Yolk sac tumors produce AFP. HCG. That's choriocarcinoma and dysgerminoma. LDH. That's also dysgerminoma. So, dysgerminomas can produce HCG and LDH. Let's finish with a couple rapid-fire facts. Ovarian tumor plus ascites plus hydrothorax, that's Meg syndrome, associated with fibromas. Teratoma, hyperthyroidism, that's called struma ovari. Okay, that's it for this lecture.
Let's go through the warm-up review. First question, which cardiac abnormality is associated with each of the following murmurs? So a systolic murmur, heard best in the second and third right intercostal space close to the sternum, is aortic stenosis. A rumbling late diastolic murmur with an opening snap is mitral stenosis. A pansystolic or holosystolic murmur at the fourth, fifth, and sixth left intercostal spaces adjacent to the sternum could be either tricuspid regurgitation or a VSD. And then a continuous machine-like murmur is a PDA. And then the last question says, outline the pathway by which stimulation of a GQ receptor activates protein kinase C. So GQ receptors activate phospholipase C, and then phospholipase C converts PIP2 to inositol triphosphate, or IP3, and diacylglycerol, or DAG. And then diacylglycerol activates protein kinase C. Now let's move on to the lecture.
In the next two videos, we'll be talking about pregnancy. This lecture will cover some of the pathologies that occur in early pregnancy, and we'll actually review a lot of embryogenesis as we go along. Let's start with twinning. There are two major categories of twins: monozygotic, sometimes called identical, and dizygotic, or fraternal. Dizygotic twins occur when two eggs are released and fertilized by two different sperm. Monozygotic twins come from one zygote that splits into two. And the timing of the split matters because it determines how many chorions and amnions there will be. The chorion and amnion are two of the fetal membranes that enclose the fetus. The amnion is the thin inner membrane, and the chorion is the thicker outer membrane. Remember that during the first 3 days after fertilization, the zygote undergoes successive cleavage divisions, becoming the morula. If the embryo splits during these cleavage divisions, it will produce two separate chorions and two separate amnions, so dichorionic, diamnionic twins. The morula enters the uterine cavity at around day 3 or 4. Then you have formation of an inner cell mass, which will become the fetus, and an outer trophoblast, which will form the fetal component of the placenta. And at this point, the embryo is called the blastocyst. If the embryo splits at this stage, the twins will have two separate amnions, but share a chorion. We call that monochorionic diamnionic. On day 6, the blastocyst starts the process of implantation. By day 8, the inner cell mass gives rise to the bilaminar embryonic disc, made up of the hypoblast and the epiblast. Splitting of the bilaminar embryonic disc results in twins with both a shared chorion and a shared amnion, monochorionic, monoamnionic twins. Conjoined twins result if the split is incomplete. In practice, the more monos in a twin set, the higher risk of pregnancy. If you think of it this way, di-di twins have two placentas and two separate bags of water, two separate environments, essentially two separate pregnancies. Mono-di twins have one placenta and two separate bags of water, which means that this can lead to issues with one fetus stealing blood flow from the other, which is possible because they have the same power source, which can lead to selective growth restriction or anemia. Finally, mono twins have one placenta and one bag of water. Imagine, not only do they share the same power source, but the two fetuses are floating around in the same space, with their two umbilical cords floating around in the same area. The danger here is that this can unfortunately lead to fetal demise if the cords become entangled. Usually these pregnancies are delivered intentionally early to mitigate some of this risk. Now, what happens if the blastocyst implants in the wrong location? We call that ectopic pregnancy. Ectopic pregnancy is any pregnancy that's located outside of the uterine cavity. Most of these, in fact, 98% of these, will be in the fallopian tube, most commonly in the ampulla of the fallopian tube, but ectopic pregnancies can also occur in the ovaries or in the abdomen. We worry most about the ones in the fallopian tubes, though, because if the pregnancy grows large enough, it can cause the tube to rupture, leading to intra-abdominal hemorrhage and possibly even death. What are the risk factors for ectopic pregnancy? Well, we said that the majority of these occur in the fallopian tube, so most of your risk factors are going to be things that affect normal transport through the tubes. So the big ones are a prior ectopic pregnancy and a history of tubal surgery like a tubal ligation or reversal of a tubal ligation. A history of pelvic inflammatory disease increases your risk because PID causes scarring in the fallopian tubes. Smoking is a risk factor, probably because it impairs tubal motility. A history of infertility increases your risk. And then having an IUD in place. But be careful with that one. If you have an IUD, your overall rate of pregnancy will be lower, but if you do get pregnant, there is an increased risk that that pregnancy will be ectopic. Okay, so how do these patients present? Well, the classic triad for ectopic pregnancy is amenorrhea, vaginal bleeding, and ipsilateral abdominal pain. And then if that ectopic ruptures and there's intra-abdominal bleeding, patients can have severe abdominal pain or even referred pain to the shoulder. Sometimes they'll feel the urge to defecate from blood pooling in the pouch of Douglas. And then you also have to watch out for dizziness or loss of consciousness or any other signs of blood loss. On your physical exam, you might find lower abdominal tenderness and maybe an adnexal mass. But if the fallopian tube ruptures, you could see signs of peritonitis like rebound tenderness or guarding, which is why these are sometimes mistaken for appendicitis. Your workup should include a serum beta-HCG level and an ultrasound. The beta-HCG level will be elevated because the patient is pregnant, but the level may be lower than normal because these are not normal healthy pregnancies. The treatment for ectopic pregnancy is usually surgical, but in some cases you can use the medication methotrexate. You'll learn more about methotrexate in more detail later on in the course, but I'll just mention that methotrexate is a folic acid antagonist that inhibits dihydrofolate reductase, an enzyme involved in DNA synthesis. Let's move on and talk about gestational trophoblastic disease. Remember that the blastocyst has an inner cell mass that becomes the fetus, and then there's the outer trophoblast. And the trophoblast is composed of the cytotrophoblasts and the syncytiotrophoblasts. The syncytiotrophoblasts make up the layer that's closest to the mom. These are the cells that produce HCG. And they also invade into the endometrium and create the lacunae that fill with maternal blood. And then the cytotrophoblasts, which make up the layer closest to the fetus, form the chorionic villi, the finger-like projections that grow into these pools of blood. So exchange of oxygen and nutrients and wastes between the mom and the fetus can occur. So gestational trophoblastic disease arises from these cells, the cytotrophoblasts, which make up the chorionic villi, and the syncytiotrophoblasts, which secrete HCG. So one of the key points to remember is that gestational trophoblastic disease is associated with elevated levels of HCG. We break up gestational trophoblastic disease into three main categories: hydatiform moles, invasive moles, and choriocarcinoma. This is actually a spectrum of disease, with hydatiform moles being benign and producing a little bit of extra HCG, and choriocarcinomas being extremely malignant and producing a lot of extra HCG. Let's start by talking about hydatiform moles. There are two types, partial and complete. Both of these are due to abnormal fertilization. So there isn't normal fetal development, but the patients are pregnant. They'll feel pregnant. They'll have positive pregnancy tests. Partial moles occur when 2 sperm fertilize 1 egg, so there's an extra set of chromosomes. The karyotype is 69XXX, XXY, or XYY. And then complete moles result from 1 sperm fertilizing an empty egg and then duplicating its chromosomes, or from 2 sperm fertilizing an empty egg. In either case, you have a normal number of chromosomes. The karyotype is 46XX or 46XY. But don't let that deceive you. Complete moles are very abnormal. In fact, embryogenesis is so disrupted in complete moles that complete moles contain no fetal parts, whereas partial moles usually do. Both will contain chorionic villi on histology. Swollen hydropic villi are the hallmark of hydatiform moles. Grossly, the swollen villi look like grape-like clusters, and on ultrasound, this can produce a snowstorm appearance. In partial moles, the uterus is usually either normal size or smaller than you'd expect based on gestational age. Complete moles usually cause uterine enlargement. HCG production in partial moles is elevated, but it's even higher in complete moles. There is a smaller risk of partial moles becoming invasive, about 3 to 5%, but a larger risk with complete moles, 15 to 20%. And partial moles do not carry an increased risk of choriocarcinoma, but complete moles do, about 2.5% risk. So remember that complete moles are completely worse. The treatment for molar pregnancies is a DNC, dilation and curettage. Then we follow the HCG levels to make sure they go down to 0 and stay there. Now let's talk about invasive moles and choriocarcinoma. We said that both partial moles and complete moles can become invasive, but it's more common with complete moles. Invasive moles invade locally through the uterine wall. This can sometimes lead to uterine rupture and hemorrhage. Choriocarcinoma is the metastatic malignant form of gestational trophoblastic disease. Most, 50%, arise from complete hydatiform moles, but they can also occur after miscarriages, normal pregnancies, ectopic pregnancies, or even just spontaneously. Choriocarcinoma most frequently metastasizes to the lung, but it can also go to the vagina, brain, liver, and other organs. But definitely remember the lung. These most commonly present as a bloody brown discharge, but you can also have other symptoms such as dyspnea, depending on what organs are involved. With a normal pregnancy, it's normal to have some discharge after delivery, known as lochia. At first, it's bloody, but then becomes yellowish white before gradually resolving around 4 to 6 weeks postpartum. But a persistent brown, bloody discharge is abnormal. With choriocarcinoma, serum HCG levels will be extremely high. The treatment for invasive moles and choriocarcinoma is chemotherapy, usually including methotrexate, plus or minus surgery. And then, again, you'll follow the HCG levels. These are generally really responsive to chemotherapy, so the prognosis is usually excellent. Let's switch gears and talk about the umbilical cord. The umbilical cord contains 2 umbilical arteries and 1 umbilical vein, surrounded by a mucoid connective tissue called Wharton's jelly. Sometimes there's only a single umbilical artery, and this is associated with other fetal anomalies, but it can be an isolated finding as well. The 2 umbilical arteries carry deoxygenated blood from the fetus to the placenta, and the umbilical vein carries oxygenated blood from the placenta to the fetus. We cover fetal circulation elsewhere in the course. What I want to focus on are 2 other structures found within the umbilical cord, the urachus and the vitelline duct. During development, the proximal part of the allantois gives rise to the urachus, a duct that runs between the fetal bladder and the umbilicus. The urachus is supposed to involute after birth, becoming the median umbilical ligament. If it doesn't, if some or all of it persists, you can see a couple of things. If there's a remnant where the urachus meets the bladder, that's called a vesicourachal diverticulum. So that's a little outpouching of the bladder. If the urachus obliterates at the bladder and the umbilicus, but not in the middle, you can get a urachal cyst. And if the urachus doesn't obliterate at all, you get a patent urachus. You would suspect a patent urachus in a child with a persistently wet umbilicus because with these, urine continuously leaks from the umbilicus. The vitelline duct, also called the omphalomesenteric duct, connects the yolk sac to the lumen of the mid-gut. Normally, this connection disappears in week 6 of development. If it remains patent, you get a vitelline fistula, which connects the terminal ileum to the umbilicus. So these infants will have meconium coming from the umbilicus. If there's a small remnant at the ileum, this becomes a mecal diverticulum, an outpouching of the intestine. These sometimes contain gastric tissue, which can bleed, so these often present as a lower GI bleed. As you know, the fetus develops within the amniotic sac, which contains amniotic fluid. And the amniotic fluid is extremely important. It protects the fetus from trauma and gives it room to move and grow. The fetus swallows the amniotic fluid, which helps the GI tract develop, and the fetus breathes in the fluid, and that's essential for normal lung development. Having too little amniotic fluid is called oligohydramnios, and having too much fluid is called polyhydramnios. I wouldn't worry too much about the cutoffs or what qualifies as oligo or poly, but you need to know some of the causes of these. So, what are some of the causes of oligohydramnios? Well, in the second half of pregnancy, fetal urine becomes the most important source of amniotic fluid. So you want to think of things that decrease fetal urine output. Placental insufficiency. If the fetus isn't getting enough blood, it may shunt blood away from the kidneys, resulting in decreased urine production. Bilateral renal agenesis, where the kidneys don't develop normally. This can result in Potter sequence, where the infant has pulmonary hypoplasia and other congenital malformations due to this oligohydramnios. You'll learn more about Potter sequence in the renal section of this course. And then, obstruction of urine flow for example by posterior urethral valves in males, that can lead to oligohydramnios. And what are the causes of polyhydramnios? Here, you want to think of things that would prevent the fetus from swallowing fluid, like esophageal or duodenal atresia, and anencephaly or some other CNS abnormality that would impair fetal swallowing. And also think of things that result in too much urine production. For example, multiple gestations. 2 fetuses will produce more urine than 1 fetus. Uncontrolled maternal diabetes, because this can result in glucosuria, then polyuria in the fetus as well. Certain congenital infections like parvovirus B19, and fetal anemia due to Rh alloimmunization. So one of the prenatal labs you always check is a type and screen to see if the mother is RhD negative and therefore at risk for Rh alloimmunization. Let's talk about some of the other prenatal testing you can do. In the second trimester between 15 and 20 weeks, we can do maternal serum screening. This is known as the triple screen or the quadruple screen, depending on how many markers you test for. The main ones you look for are alpha-fetoprotein, AFP, estriol, which, remember, is the estrogen produced by the placenta, and HCG. And then you can add on inhibin to make it a quad screen. So you measure these markers in the mom's serum, and abnormal levels can point to a problem with the fetus. What causes an elevated AFP? Abdominal wall defects like gastroschisis or omphalocele, neural tube defects, multiple gestations, incorrect dating. With trisomy 18, Edwards syndrome, all the markers are down. AFP, estriol, and HCG are all decreased. With trisomy 21, Down syndrome, you'll see decreased AFP, decreased estriol, and increased HCG. And inhibin is increased as well. Adding inhibin improves the sensitivity of the test. So maternal serum screening is used for screening. We also have a couple of tests that are helpful for diagnosis. Amniocentesis is where you insert a needle into the amniotic sac and take out some of the amniotic fluid. The fluid will contain some fetal cells that can be karyotyped, so this is actually used to test for aneuploidies or genetic diseases. In the past, we also used to measure AFP and acetylcholinesterase levels by amniocentesis to confirm a neural tube defect, but nowadays we mostly use sono to do that. Chorionic villus sampling, or CVS, is another invasive diagnostic test that's used for fetal karyotyping and genetic testing. The advantage of CVS is that it can be done earlier in pregnancy, between 10 and 13 weeks. Cell-free fetal DNA testing, which can be used to determine fetal sex early, in addition to providing an early screening modality for aneuploidy. I want to finish this lecture by talking about some of the physiologic changes that take place during pregnancy. Obviously, there are a number of big changes, but I want to focus on just a few. Take a look in your study guide. You don't need to memorize these numbers, but be comfortable with the concepts. The first one says, basal metabolic rate increases 10 to 20%. And this is in order to meet the demands of the growing fetus. So pregnant women have increased caloric requirements. That's pretty intuitive. Next, plasma volume expands by 30 to 50%, and red blood cell mass increases by 20 to 30%. This protects the mother from the blood loss that will occur with delivery. The increase in blood volume can manifest as some changes on cardiac auscultation. 90% of pregnant women will have a systolic ejection murmur, a flow murmur, and some will have an S3 heart sound. And then, because there's more blood for the heart to pump, the cardiac output increases by 30 to 50%. What's the formula for cardiac output? Stroke volume times heart rate. So this increase in cardiac output comes from both an increase in stroke volume and an increase in heart rate. Next, blood pressure decreases in early pregnancy, reaches an nadir at 24 to 26 weeks, and returns to pre-pregnancy levels by term. So this becomes important when you talk about hypertension in pregnancy, which we'll cover in the next lecture. Increased GFR leads to a decrease in BUN and creatinine. And the last one, increased procoagulation factors leads to a hypercoagulable state. So during pregnancy, and actually in the first few weeks postpartum as well, women are at increased risk for DVT and PE. Okay, that's it for the lecture. Now it's time for the end of session quiz. What are the risk factors for ectopic pregnancy? Prior ectopic pregnancy, history of tubal surgery, history of PID, smoking, infertility, and IUD in place. Next, which type of ovarian cyst is associated with molar pregnancies? We didn't talk about this, but remember, molar pregnancies are associated with elevated levels of HCG. And which ovarian cyst occurs because of high levels of HCG? That's the theca-lutein cyst. Next, what is the most common location for metastasis in choriocarcinoma? The lung. So think of choriocarcinoma in a patient with shortness of breath and an elevated HCG level after pregnancy. Next, failed involution of what embryological structure is associated with each of the following statements? Drainage of urine from the umbilicus, urachus. Drainage of meconium from the umbilicus, vitelline or omphalomesenteric duct. Next, what condition is suggested by each of the following abnormalities on second trimester maternal serum screening? Elevated AFP, neural tube defects, abdominal wall defects, such as gastroschisis omphalocele, multiple gestations, incorrect dating. Low AFP, low estriol, and high HCG. That's trisomy 21, Down syndrome. And lastly, low AFP, low estriol, and low HCG. That's trisomy 18, Edwards syndrome. And we have one rapid fire fact. Snowstorm appearance on ultrasound is a hydatiform mole. Okay, that's it for this video. I'll see you next time.
Let's go over the warm-up review. First question, what effect will stimulating each of the following receptors have on heart rate? So stimulating beta 1 will increase heart rate. Stimulating beta 2 will also increase the heart rate, kind of indirectly, because beta 2 stimulation causes vasodilation, which lowers the blood pressure, so the heart rate rises to compensate. And then stimulating M2 receptors will decrease the heart rate. Next, what are the primary mechanisms of action of the different classes of antiarrhythmics? So the mnemonic is no bad boy keeps clean. So class 1 is sodium channel blockers, class 2 is beta blockers, class 3 is potassium channel blockers, and class 4 is calcium channel blockers. And the last question, a patient comes to the clinic complaining of anterior shoulder pain that radiates down the forearm. On examination, there's swelling of the biceps muscle. So what's the most likely diagnosis? Biceps tendon rupture. Now we're ready for the lecture.
Welcome to another Step 1 video. I'm Dr. T. In this lecture, we'll continue talking about some of the complications we encounter in pregnancy, and then we'll finish by discussing some of the medications we use during pregnancy. Let's start with abnormal placentation. Last time we talked about how the placenta develops.
Well, what's going on?
Hey, what are you doing here? I thought you were off today.
Nope.
Oh.
Look, we've talked about this before. You can't be my stand-in, okay?
I know.
So, may I take it from here?
Okay.
So, normally the placenta is located up here near the fundus of the uterus, well away from the cervical os. However, sometimes the placenta implants down here in the lower uterine segment. And if it covers the internal cervical os, it's called a placenta previa. Placenta previa is when the placenta overlies the cervical os. Risk factors for this include increasing maternal age and multiparity, so increasing number of pregnancies. But the big risk factor to know is a history of a C-section. And this is because it's thought that scarring from the C-section keeps the placenta from implanting in a normal location. As the pregnancy progresses, changes in the cervix and the lower uterine segment will cause the placenta to detach in small spots. So these patients present with painless vaginal bleeding, usually in the second half of pregnancy. and then you would get an ultrasound to make the diagnosis. One important point that you have to get the ultrasound before you do a digital exam, because if you accidentally stick your finger through a placenta previa, you'll cause a massive hemorrhage. The treatment for a bleeding previa is a C-section. Both placenta previa and a history of a C-section are risk factors for 3 other types of abnormal placentation: placenta accreta, placenta increta, and placenta percreta. Placenta accreta is when the placenta is abnormally adhered to the myometrium. Placenta increta is when the placenta invades into the myometrium. And placenta percreta is when the placenta invades through the myometrium and serosa. So placenta percreta penetrates through the uterus. Percretas can even invade surrounding structures like the bowel, bladder, or large pelvic vessels like the iliac arteries. So accreta adheres, increta invades, and percreta penetrates. Like I said, these are associated with previas and with prior C-sections. Again, it's thought that the scarring from the C-section prevents normal development of the placenta. These can be diagnosed on ultrasound, and oftentimes MRIs are also used in an attempt to pinpoint the degree of placental invasion. But sometimes they're not found until after delivery, when you try to deliver the placenta and it won't detach. These can cause massive, life-threatening hemorrhage as well. So the treatment is usually C-section followed by hysterectomy. Let's move on to placental abruption, which you may also see referred to as abruptio placentae. This is a premature separation of the placenta from the uterus before delivery. This is bad because then the fetus is deprived of oxygen and the mom can lose a lot of blood. The moms can also develop DIC, so this is a very serious complication, both for the mom and the baby. Risk factors for placental abruption include history of a prior abruption, hypertension, including pregnancy-induced hypertension, trauma like a car accident, smoking, and cocaine use. Test writers especially like to use cocaine use as a clue for placental abruption, so remember that one. Placental abruption presents as sudden onset, painful vaginal bleeding in the second half of pregnancy. So we said placenta previa causes painless bleeding late in pregnancy, while placental abruption causes painful bleeding. And this is associated with contractions and evidence of fetal distress on the fetal heart rate monitor. The treatment for placental abruption is an emergency C-section. We've talked about some of the causes of bleeding late in pregnancy like placenta previa and placental abruption. What about bleeding after delivery? This is called postpartum hemorrhage. You usually encounter it right after delivery, within minutes, but sometimes you can have delayed postpartum hemorrhage, occurring in the first couple of days postpartum. So what are some of the causes of postpartum hemorrhage? This is number 4 in your study guide. The most common is uterine atony. After the placenta detaches, the ends of the spiral arteries in the uterus are still open and bleeding. And what stops that bleeding is the myometrium contracting down to constrict those vessels. So if the uterus doesn't contract, if it's atonic, then the spiral arteries remain open and you get a lot of bleeding. They'll describe this on your test as an enlarged, soft, boggy uterus. And the risk factors include an overdistended uterus, like with a large fetus or with a multifetal gestation, induced or augmented labor, or prolonged labor. You can think of it as the uterus being overworked and then too tired to contract effectively to stop the bleeding. Retained placental tissue is a cause of postpartum hemorrhage. The retained tissue prevents the myometrium from contracting down. Genital lacerations are a common cause. We mentioned that placenta accreta, increta, and percreta can present as excessive bleeding at delivery. And uterine rupture is a rare but potentially very serious cause. Let's switch gears and talk about hypertension in pregnancy. Hypertension is a common problem in pregnancy, and there are a few different types, so let's go through them. Chronic hypertension is the term used to describe someone who has hypertension already before pregnancy. So a patient who has a history of hypertension, maybe she's already on antihypertensives, and then she becomes pregnant. Do you remember which common antihypertensive is a teratogen? ACE inhibitors, and you worry about renal abnormalities with those. 5 antihypertensives that we do use during pregnancy are methyldopa, labetalol, amlodipine, as well as nifedipine and hydralazine. Methyldopa is a central-acting alpha-2 receptor agonist. Labetalol is a combined alpha-beta adrenergic blocker, and amlodipine is a calcium channel blocker. Gestational hypertension is hypertension that arises during pregnancy and then resolves postpartum. So this is a new onset hypertension greater than 140/90 after 20 weeks of gestation. And this is not associated with proteinuria. Generally, we do not treat gestational hypertension with antihypertensives because it hasn't been shown to improve outcomes. So the management is basically close monitoring to catch any progression of the disease. Preeclampsia is gestational hypertension plus either proteinuria or end organ dysfunction. We don't know exactly why preeclampsia occurs, but one theory is that there's abnormal development of the placental blood vessels, leading to placental ischemia and an inflammatory response. Another theory is that the mom's immune system reacts to paternally derived antigens in the placenta. In any case, what happens is widespread endothelial dysfunction, leaky vessels, and vasospasm, leading to hypertension, proteinuria, and possibly damage to other organs. Risk factors include a history of preeclampsia, extremes of age, so women less than 18 and women older than 40, nulliparity, so women in their first pregnancies, chronic hypertension, diabetes, multifetal gestations, and hydatiform moles. So, preeclampsia is diagnosed if someone has new onset hypertension greater than 140/90 after 20 weeks gestation, as well as proteinuria. And that proteinuria has to be at least 300 milligrams in 24 hours. If there is no proteinuria, you can still make the diagnosis if there's evidence of end organ dysfunction like thrombocytopenia, renal insufficiency, elevated LFTs, pulmonary edema, or cerebral symptoms like headache, visual disturbances, and seizure. Preeclampsia is considered severe when there's evidence of end organ dysfunction, all those things I just mentioned, or if the blood pressure is greater than 160/110. Then there's a variant of severe preeclampsia known as HELP syndrome. HELP stands for hemolysis, elevated liver enzymes, and low platelets. And finally, eclampsia is when someone with preeclampsia has a seizure. This is due to CNS involvement. The anticonvulsant of choice for this is magnesium sulfate. So this is different from other seizures. With eclampsia, use magnesium sulfate to terminate the seizure. The management is generally the same for severe preeclampsia, HELP syndrome, and eclampsia. We give rapid-acting antihypertensives like hydralazine, labetalol, or nifedipine to bring the blood pressure down if it's greatly elevated, over 160/110. This is to prevent the patient from having a stroke. We also give magnesium sulfate to prevent seizures or to terminate a seizure in eclampsia. And then the definitive treatment is delivery. And this doesn't necessarily have to be a C-section. You can also induce labor. We'll talk about some of the medications we use for this later in the lecture. But keep in mind that it takes a few days for the dangers of severe preeclampsia to resolve. In fact, the highest chance a woman has for developing an eclamptic seizure is in the first 24 hours after delivery. Similar to how you can have pregnancy-induced hypertension, you can also have pregnancy-induced diabetes, and we call that gestational diabetes. This is number 5 in your study guide. During pregnancy, the placenta secretes a hormone called human placental lactogen, or HPL. One of the functions of HPL is to decrease insulin sensitivity in the mother so that she doesn't utilize as much glucose, and instead the glucose is available for the fetus to use for nutrition and growth. But sometimes this response is exaggerated, leading to gestational diabetes. So gestational diabetes is diabetes that arises during pregnancy but then resolves postpartum. We screen for this in everyone. using an oral glucose tolerance test between 24 and 28 weeks of gestation. And then the management is with a diabetic diet plus or minus insulin if better control is needed. The main complication we worry about with gestational diabetes is fetal macrosomia, or big babies. These infants are at risk for labor complications such as a shoulder dystocia during delivery, and they can also become hypoglycemic after delivery. And why is that? During pregnancy, if they're exposed to too much glucose, the fetal beta cells in the pancreas will undergo hyperplasia to produce more insulin. And then once you take away all that glucose after delivery, the infants can become hypoglycemic. Now, what about those people who are already diabetic, either type 1 or type 2 diabetic, and then become pregnant? We call that pregestational or overt diabetes. We manage this with insulin to get really tight glucose control. While we worry about macrosomia and post-delivery hypoglycemia here as well, infants of these mothers can have even more serious complications, including congenital abnormalities like cardiac defects or caudal regression syndrome, which is a sacral dysgenesis. The lower part of the body doesn't form properly. There is also an increased risk for unexplained stillbirths, so these patients are usually delivered a little earlier. I want to finish by talking about a few of the medications we use during pregnancy, starting with terbutaline. Terbutaline is an asthma medication that's also sometimes used as a tocolytic, a medication to delay preterm labor. Terbutaline is a selective beta-2 agonist, so it causes bronchodilation in the lungs, making it useful for asthma. But beta-2 receptors are also found in the uterus, and activating them there leads to uterine relaxation. So if you can make the contractions stop, this delays labor. Usually this delay is only on the order of hours to a couple of days, so this isn't a cure for preterm labor. It's basically just gives you some time so that you can give the mother glucocorticoids to promote fetal lung maturity. Some of the side effects of terbutaline include tachycardia, hypotension, and pulmonary edema. Step Up also mentions ritodrine, which is another selective beta-2 agonist. Ritodrine is also approved for preterm labor, but it's not available in the US. Another class of drugs we use quite often in obstetrics is the prostaglandin drugs. Generally, these cause cervical dilation and uterine contractions, so we use these early in pregnancy to terminate the pregnancy, or late in pregnancy to induce labor. There are a bunch of different ones available, but I think the two you should know are misoprostol and dinoprostone. Dinoprostone is a prostaglandin E2 analog, and misoprostol is a prostaglandin E1 analog. Misoprostol is also used to prevent peptic ulcers in people taking NSAIDs, and it can also be used to keep patent ductus arteriosus open. For both dinoprostone and misoprostol, you worry about uterine hyperstimulation or excessive contractions, which can cause fetal distress and even uterine rupture. In fact, if during labor induction the administration of misoprostol causes inadvertent uterine hyperstimulation leading to fetal distress, a medication now familiar to you, terbutaline, can be used to acutely stop the hyperstimulation and relieve the stress on the baby. The next drug is mifepristone, also known as RU486. Mifepristone is a competitive antagonist at the progesterone receptor, so it's an anti-progestin. Now remember, we said that progesterone is progestational. It's necessary for maintaining a pregnancy. So if you give mifepristone, an anti-progesterone, early in pregnancy, that causes the blastocyst to detach and the myometrium to contract, ending the pregnancy. So that's what mifepristone is used for, the medical termination of early pregnancy. And you usually give mifepristone along with misoprostol. The misoprostol increases the uterine contractions to ensure that the detached blastocyst is expulsed. Side effects of this regimen include vaginal bleeding, abdominal pain, and cramping, nausea, vomiting, and diarrhea. Okay, that's it for this lecture. Now it's time for the end of session quiz. Which placental abnormality matches each of the following descriptions? Placenta covers internal cervical os. Placenta previa. Premature separation of placenta. Placental abruption, abruptio placentae. Abnormal adherence of placenta to myometrium. Placenta accreta. Invasion of placenta into myometrium. Placenta increta. Invasion of placenta through myometrium and serosa. Placenta percreta. Presents as painless vaginal bleeding late in pregnancy. Placenta previa. Presents as painful vaginal bleeding late in pregnancy. Placental abruption. Next, what is the most common cause of postpartum hemorrhage? Uterine atony. Next, what condition is best described by each of the following statements? Patient with past medical history of hypertension becomes pregnant. Chronic hypertension. New onset hypertension during pregnancy with no proteinuria. Gestational hypertension. New onset hypertension during pregnancy plus proteinuria or end organ dysfunction. Preeclampsia. Patient with preeclampsia has a seizure. Eclampsia. Patient with preeclampsia has low haptoglobin, low platelet count, and high AST. HELP syndrome, hemolysis, elevated liver enzymes, and low platelets. Next, what is the mechanism of action of mifepristone? What is the mechanism of action of terbutaline? Mifepristone, or RU486, is a competitive inhibitor at the progesterone receptor, so it's an anti-progestin, and it's used to terminate early pregnancies. Terbutaline is a beta-2 agonist, so it causes uterine relaxation, and it's used to delay preterm labor. That's it for this video.
Ooh. Can I at least do the outro?
Sure.
Oh, yeah. That's it for this video. Good luck on your exam, and don't forget to vote for me, Dr. T, and my beard using the hashtag #DITBeard.
Hello boys and girls, I'm Dr. Lewis, and welcome to Lou's Clues, the show where we learn about medical stuff. Let's get started! Yay! Today our special guest is my daughter Rebecca. Say hi, Rebecca.
Hi.
Great, let's get started. Now Rebecca, do you know where babies come from? It's not from a stork.
Dad, everyone knows that. Babies come from mommy's tummies.
Well, it might be more complicated than you think. Do you have any questions about how babies grow?
Not really.
Really? Nothing? Nothing at all?
Oh, okay. What's a placenta?
Wow. Rebecca, if I had a nickel every time a 7-year-old asked me about placentas, I'd be a rich man. But let me answer your question. The placenta is an organ that connects the developing baby to the uterine wall to allow nutrient uptake, waste elimination, and gas exchange via the mother's blood supply.
Yeah, I already knew that.
Really?
Uh-huh. What about placenta previa?
What are they teaching you in first grade? Well, the placenta previa is where the placenta covers the internal cervical os, but...
Oh yeah, that's only diagnosed in the 3rd trimester. Now I remember.
What? Where is this coming from? Okay, if you're so smart, how do you cure a placenta previa?
Trick question, Dad. Everyone knows you need a C-section with a placenta previa.
Let's go over the warm-up review. First question, what are the signs and symptoms of excessive cholinergic stimulation? So the mnemonic is dumbbells, which stands for diarrhea, urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle and the CNS, lacrimation, sweating, and salivation. So remember, you get leaky everywhere. Leaky bowels, leaky bladder, tears, sweating, and drooling. Good times. Next, which psychiatric disorder is associated with decreased norepinephrine? That's depression. And the last question, Patients who have migraines with aura are at an increased risk for what other neurological condition? They're at increased risk for strokes. Now let's move on to the lecture.
Hello everyone and welcome to our Step 1 video on chromosomal disorders. Guys, this one is chock full of high yield stuff, so you better bring all 46 chromosomes along with you because you're gonna need them. In fact, borrow an extra chromosome from a friend for good luck. And if you don't know why that's a bad idea, then you better pay attention. Alright, so first we're going to talk about the autosomal trisomies. Now the three that you need to know are Down syndrome, Edwards syndrome, and Patau syndrome. So let's start with the big one, Down syndrome. Down syndrome, also referred to as trisomy 21, where you have all or part of a third copy of chromosome 21. Now Down syndrome is the most common of the trisomies, about 1 out of 700 live births. Now the findings include intellectual disability, that flat facies, prominent epicanthal folds, simian crease. There's an increased gap between the first and second toes. Now patients can have other things, duodenal atresia or a blind duodenal pouch. Down syndrome patients can acquire endocardial cushion defects, and the endocardial cushion defects may cause an ASD or a VSD, or an abnormal connection between the atrium and the ventricles, or an abnormal connection between all 4 chambers of the heart, because that's basically where the endocardial cushion is located. Now it's also associated with the increased risk of ALL and Alzheimer's disease. Now it's also going to have a bit of a smaller association with AML, but most questions are looking for ALL as the answer. Now, one way to remember this is with the Ring Around the Rosie song. Remember when you say all fall down. So all ALL is associated with Down syndrome. Now, there is a specific gene on chromosome 21 that is associated with Alzheimer's disease or dementia. And when you have 3 copies of that gene, unfortunately, you're more likely to acquire Alzheimer's dementia. Now, another pathology seen in Down syndrome is that 65% of newborns with Down syndrome have polycythemia. Now, Down syndrome is the most common chromosomal disorder and the most common genetic cause of intellectual disability. What is the number 2 genetic cause? That's going to be Fragile X syndrome. And then what is the most common overall cause of intellectual disability? It's actually fetal alcohol syndrome. Now, one way to help screen for Down syndrome is with the quad screen. Very important here. The pregnancy quad screen will include a decreased alpha-fetoprotein level, increased beta-HCG, decreased estriol, and increased inhibin A. So this is a series that is worth knowing. Let me repeat that. That's how important this is. Decreased alpha-fetoprotein, increased beta-HCG, decreased estriol, and increased inhibin A. Now, if you see that constellation on a pregnancy quad screen, it raises a flag for Down syndrome. Now, here's another great way to remember the labs in Down syndrome. Put the labs in alphabetical order, starting with Down and then alternate. So AFP down, beta-HCG up, estriol down, inhibin A up. Now, ultrasound in the first trimester is going to show something called an increased nuchal translucency. And just one FYI, you might also see this with Turner syndrome as well. Now, 95% of these cases are due to maternal non-disjunction during anaphase of meiosis 1 of homologous chromosomes. Let me repeat that one again. That's another high-yield one. Mostly caused by maternal non-disjunction during anaphase of meiosis 1. And this non-disjunction is associated with advanced maternal age. The risk of Down syndrome is actually pretty small in younger age women delivering children, but as you grow older, specifically older than 35, the risk starts to go up. And then over 45, the risk is even higher. 1 out of 25 live births will have Down syndrome over the age of 45 with maternal age. Now, 1% of cases are due to Down mosaicism, where there's no maternal association at all. And again, mosaicism is where not all of the cells are identical. Some of the cells will have trisomy 21, some of the cells do not have trisomy 21. So that's mosaicism. So let's move on to another concept here, Robertsonian translocation. So about 4% of Down syndrome cases are going to be due to a Robertsonian translocation. So a Robertsonian translocation is a very unique phenomenon. It's a non-reciprocal chromosomal translocation that commonly involves chromosome pairs. So one of the most common types is where translocation occurs when the long arms of 2 acrocentric chromosomes fuse at the centromeres, and the 2 short arms are then lost. So you're left with really a very long chromosome. And it's really long chromosome, and it has all the important genetic material of 2 chromosomes really put into 1.
And though these people only have 45 chromosomes at that point because you've lost these, the short arms of these, you can actually turn out fine. There's no major loss of genetic material, and they just have a normal phenotype at that point. But in the case of Down syndrome, we see a Robertsonian translocation between chromosomes 14 and 21. So they make a really big long chromosome that has the genetic material of 14 and 21. And for that first child, you may not have any problems. This might be a normal situation. The child will have 45 chromosomes, but all the important genetic info is still present. But that next generation might develop a gamete that has the mega 14/21 combo chromosome and a regular chromosome 21. And then when that gamete joins with another gamete that has a regular chromosome 21, then the result is 3 copies of chromosome 21. So that's what we're talking about with this Robertsonian translocation, where the long arm of chromosomes are fused with another chromosome, and then that is passed on through the germline. And so that 4% of cases of Down syndrome can have from that because you're getting 3 copies of 21. And this is, again, one type of mutation causing that Down syndrome, but it's not associated with advanced maternal age. Very important there. Okay, so now let's move on to Edwards syndrome, or trisomy 18. It's about 11 times less common than Down syndrome. Now, one way to remember that it's on chromosome 18 is that Edward has 6 letters and trisomy is 3, so 6 times 3 is 18. So patients will present with severe intellectual disability. They're also going to get what's called rocker bottom feet and micronanthia, so undersized jaw. You're also going to see some clenched hands, prominent occiput. That's a big, huge clue as well. Death, unfortunately, usually occurs within 1 year of birth, and this is the most common trisomy resulting in a live birth after Down syndrome. Now, what would you see on a quad screen, or sometimes you'll get a tri-screen on this one? So you would see decreased beta-HCG, so that's different than with Down syndrome. You would see a decreased alpha-fetoprotein, a decreased estriol, and then potentially a normal inhibin if you actually tested for it. So basically, everything is decreased, but the inhibin A is going to be normal. Nuchal translucency could be seen here as well. And then we have Patau syndrome. Patau syndrome is trisomy 13, even rarer than Edwards syndrome. You have similar things again: intellectual disability, rocker bottom feet, microcephaly, cleft lip, and cleft palate. One of the unique things with Patau, a hollow prosencephaly is that single midline eye that can happen here as well. That is also associated with defective sonic hedgehog gene. It's also associated with polydactyly and congenital heart disease. Also with this one, death usually is going to occur within 1 year of birth. Pregnancy screening here would reveal a decreased beta-HCG, but then you're also going to get something called the decreased PAPPA, so pregnancy-associated plasma protein A, it's a mouthful there, and increased nuchal translucency as well is also possible. You can't use the second trimester quad screen to detect trisomy 13 effectively. You may see a slight decrease in estriol, but you can see abnormalities in that first trimester combined test. All right, so let's review now some of these serum markers and the trisomies in another Lewis Notes. All right, guys, it's time for another Lewis Notes, and we're looking at our trisomies today, and we have to look at our quad screen or some of our early screening tests that we can do. This is pretty high yield stuff. They love to put in these things because they're confusing, because some are high, some are low, and you have to know the pattern. So the first one here is our trisomy 21. That's going to be our Down syndrome. What are we going to see here? Well, first we're going to look at our alpha-fetoprotein. We're going to see a decrease in alpha-fetoprotein. Next, what are we going to see on beta-HCG? This is going to be increased, so put that there. For estriol, we're going to have another decrease here in regards to that. And then for inhibin A, we're going to have an increase. Now, what about trisomy 18? This is our Edwards syndrome. So here we're going to see a little bit of a different pattern here. We're still going to see a decrease in our alpha-fetoprotein. Our beta-HCG is going to be decreased. That's where we're going to see one of your first differences here between here and trisomy. For estriol, we're going to have a decrease again. And then for inhibin, this is going to be normal. Now, what I would probably do for our trisomy 13 is Patau. So one thing you really have to kind of realize here, though some of the same tests are going to be used, we're actually not using quad screen. So don't use quad for our trisomy 13. You actually have to look at some earlier testing in order to get something out of your screening in order to look for trisomy 13. Now, you're still going to see a decrease in beta-HCG. And the other thing you can look at is you can look at this PAPPA. thing here, and that's for pregnancy-associated plasma protein A, and that's going to be decreased as well. So that's one way you can look at this. Now remember, you can also see a nuchal translucency. You can see that in trisomy 21 and in trisomy 13. So look for that nuchal translucency in those two as well. So if you can remember these patterns here, I'm pretty confident if you just know this level of detail, then you're bound to get the question that they're going to ask you on step 1 regarding this stuff. All right, that's going to be it for our trisomies. All right, so next we're going to talk about our sex chromosome disorders, and this is a 4-star topic. You're going to have a question on probably either Klinefelter or Turner syndrome or both, so make sure you know the ins and outs of Klinefelter and Turner. Very high yield. So first let's start with Klinefelter syndrome. So this is a genetic disorder where you have an extra sex chromosome. So instead of our usual 46XY, you're a 47XXY. So there's another, if you want to think about it, another female chromosome, another X chromosome thrown into the mix here. Now, one way I like to remember the characteristics of Klinefelter is that this is a male, so it's an XY with an extra X chromosome. So this is going to have maybe more female-like qualities with that extra X chromosome. Therefore, these patients will have testicular atrophy, which will lead to decreases in testosterone. And without much testosterone, these males will have less muscular bodies, less facial hair, less body hair, broader hips. They're going to be tall, they're going to have long extremities, maybe some gynecomastia, and there might be some female hair distribution as well. Now, they may have the presence of what's called the inactivated X chromosome. This is called the Barr body. So whenever you have 2 X chromosomes, really only one of them is active. So here you have 2 X chromosomes in Klinefelter, one is inactive. Now, males are often infertile or may have reduced fertility. Other problems will include dysgenesis of the seminiferous tubules, which will lead to decrease in inhibin. And then with that decrease in inhibin, you may see an increase in FSH or follicle stimulating hormone. So let's now talk about Turner syndrome. The incidence of Turner syndrome is 1 out of 3 to 4,000, and the chromosomal abnormality here is 45XO. So you're actually missing that other sex chromosome. You just have one X. Now, affected patients, as you would expect, are all female because there's no Y chromosome here. So are they going to have a Barr body like we saw in Klinefelter? Well, no, they just have one X chromosome. There's no inactivated X chromosome here. So how does this present? Well, patients will have short stature, sometimes even less than 5 feet. They're going to be broad-chested, sometimes referred to as a shield chest. You're going to see a low hairline, low set ears, and webbing of the neck is also very interesting. Now, patients will have gonadal dysfunction, which results in amenorrhea and infertility. So this will sometimes be referred to as streak ovaries. So Turner syndrome is the most common cause of primary amenorrhea. Cardiovascular involvement can include a bicuspid aortic valve and preductal coarctation of the aorta. Now, there's classic Turner syndrome, which is everything that we've just described, but a lot of women that have Turner syndrome don't know that they actually have it because many of the physical manifestations are much more mild than what we've just talked about. Some women will present to the office maybe even just in high school because they've never had a period. They don't have those typical physical findings. They just haven't had a period yet. So you always want to rule out Turner syndrome in anyone with primary amenorrhea. Now, if you look at hormones, then you'll see decreased estrogen, which then leads to an increased luteinizing hormone and increased follicle stimulating hormone. Now let's move on to the double Y males, another sex chromosome disorder, those double Ys. So it's kind of like Klinefelter, but instead of an extra X, now you have an extra Y. But these patients are phenotypically normal. They tend to be pretty tall, though. They can have severe acne. One controversial issue is that the presence of antisocial behavior. So there was a study at one point that looked at criminal inmates, and they found that there was a higher likelihood of double Y males in criminal inmates than there was in the general population. But that study in and of itself doesn't prove causality. They do have normal fertility. There's also some possible association with autism spectrum disorders as well. Next, we have Cri-du-Chat syndrome. So Cri-du-Chat syndrome is the next one. This is a relatively high yield for step 1, so make sure that you know about this. It's actually pretty easy to identify on most test questions. Patients are going to have microcephaly, moderate to severe intellectual disability. So several of these diseases that we covered today are going to have that microcephaly and intellectual disability. The manifestation that gives this one away is that high-pitched crying and sometimes referred to as mewing sounds that the patient's going to make. So that's pretty unique to the Cri-du-Chat, thus the name.
name cry of the cat syndrome. Patients will have epicanthal folds as well, cardiac abnormalities, but they almost always have to say something about a high-pitched cry or mewing, like a kitten with that cri du chat. That's kind of your tip-off for step one. Now, the genetic cause for this syndrome is a 5p deletion. So there's a missing part of chromosome 5. And this may also be actually referred to as a chromosome 5p deletion syndrome. Next, we have Williams syndrome. Williams syndrome, think about Will Ferrell on this one. He was in that movie Elf. So the findings you have here is distinctive, what we call elfin facies, intellectual disability. You're also going to see hypercalcemia, and this is going to be due to a hypersensitivity to vitamin D. These patients actually have pretty good verbal skills, and what's also interesting is they're very, very friendly. A lot of friendliness even with strangers. Now, this is due to a microdeletion of the long arm of chromosome 7. Again, think about Will Ferrell in the movie Elf, Williams syndrome. That's a good clue for you there. And then the last one we have to talk about are the 22q11 deletion syndromes. So these syndromes are due to a heterozygous chromosomal deletion at that 22q11.2, get very specific there. And those 22q11.2 syndromes include things like DeGeorge syndrome and the velocardiofacial syndrome. Clinical manifestations can be pretty variable. It can include things like cleft lip, abnormal facies again, thymic aplasia resulting in T-cell deficiency, cardiac defects, hypocalcemia due to parathyroid hypoplasia, and it's specifically associated with those thymic and parathyroid cardiac defects. So a lot of variability there. All right, guys, that brings us to the end of the video part. It's time for that end of session quiz. Try to answer those first, and then we'll go through them together. First question, what prenatal ultrasound finding is a clue that the fetus may have Down syndrome? Well, this isn't particularly specific, but nuchal translucency you might see in a Down syndrome, but it might also be seen in some of the other trisomies as well. Next question, what is the most common event that causes Down syndrome? Is it meiotic non-disjunction, mosaicism, or the Robertsonian translocation? Well, it's going to be that meiotic non-disjunction, and more specifically, it's the maternal non-disjunction during anaphase of meiosis 1. Next, what are the clinical features of Williams syndrome? So remember, you get that intellectual disability, you get those classic elfin facies or effects that can be present on the face. They can get the unique feature of that friendliness and that strength in verbal skills, especially with strangers. And then you can also see some cardiovascular defects, usually valvular defects. Next, what are the possible defects in cases of chromosome 22q11 deletion? So a lot of variability here, but you can see that abnormal facies, cleft palate, you got to remember, thymic aplasia, hypocalcemia, and cardiac defects. Next, what are the distinguishing characteristics of Klinefelter syndrome compared to Turner syndrome? So remember, Klinefelter occurs in males who are genetically XXY, they have that extra X. They are potentially tall with long extremities, testicular atrophy, gynecomastia, more female characteristics. Turner syndrome occurs in females who are XO, so they lost a chromosome. There would be here short stature, webbing of the neck, a shield chest, and some primary amenorrhea as well. All right, guys, that brings us to the end of session quiz. Now, we do have a couple rapid fire facts. First one here, most common genetic cause of intellectual disability, remember, Down syndrome. Second most common genetic cause of intellectual disability, that's going to be Fragile X syndrome. Horseshoe kidney, congenital heart defects, streak ovaries, and cystic hygroma. That should make you think of Turner syndrome. Rocker bottom feet, clenched hands, microcephaly, prominent occiput, small jaw. That's going to be trisomy 18 or Edwards syndrome. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
Let's go over the warm-up review. First question, which serum lab marker is helpful in assessing the appropriate oxygenation of tissues? What's lactic acid? If lactic acid is high, that suggests that the tissues aren't adequately oxygenated. Next, what are the 5 branches of the facial nerve? So the facial nerve is cranial nerve 7, and the mnemonic for the branches of it is to Zanzibar by motor car. So T is for temporal, Z is for zygomatic, B is for buccal, M is for marginal mandibular, and then the C is for cervical. The last one. What should be suspected as a cause of headache in a patient using topical retinoic acid for the treatment of acne? Well, this ought to make you think about idiopathic intracranial hypertension, or IIH, because retinoic acid is vitamin A, and vitamin A toxicity can cause IIH. And what's the old name for IIH? Pseudotumor cerebri. Now you're ready for the lecture.
Hello everyone and welcome to our Step 1 video on genetic diseases, autosomal dominant and trinucleotide repeats. Alright, so a blind man, a horse, and a luchador all go into a bar. Stop right there! Who are you?
Well, I'm future you from, well, the future.
Wow, I guess that's cool.
I'm here to stop you from doing that bad joke. It's really bad.
You're here for that? Shouldn't you use time travel to, I don't know, stop wars or cure diseases or something?
Well, I could, but man, this joke is terrible. I mean, really amateur stuff. Okay, well, I guess that's about it. Oh, whatever you do, don't put a banana in your back pocket, March 2nd, 2021. All right, later, loser.
Well, I guess I won't finish that joke then. Man, future me is kind of a jerk. All right, so we're talking about some genetic diseases today, and that can be a bit tricky because it's difficult to remember which diseases are autosomal dominant, which are autosomal recessive, which are X-linked, and unfortunately it's important to remember which ones are which. Now I'm also going to sprinkle in this lecture some clinical scenarios to kind of spice things up as well. All right, so let's start with autosomal dominant diseases. A 52-year-old man presents with flank pain and gross hematuria for the past several weeks. On physical exam, his blood pressure is 160/100. Urinalysis reveals hematuria, and serum lab studies show a creatinine of 2.9. An ultrasound of the abdomen reveals bilateral enlarged kidneys with multiple cysts present. Cysts are also seen in the liver and the pancreas. What's the diagnosis? So this one's not too hard. This is autosomal dominant polycystic kidney disease. Now you may have known this in the past as adult polycystic kidney disease, but now it's referred to as autosomal dominant. Now this primarily affects the kidneys, but it can affect other organs as well, including the liver, the pancreas, the brain, arterial blood vessels even. Now generally you see enlargement of the kidneys due to multiple large cysts, and it's always going to be bilateral. Now diagnosis is often made by CT scan or ultrasound. Patients present with flank pain, hematuria, hypertension, progressive renal failure. Now the disease is due to a mutation of what's called the APKD1 gene on chromosome 16. It's also a high yield to know that autosomal polycystic kidney disease is associated with berry aneurysms. All right, so now let's move on to achondroplasia. So this is also referred to as dwarfism. So this is a defect of the fibroblast growth factor receptor, so also referred to as the FGF receptor number 3. And it's associated with advanced paternal age. So older men having children are more likely to have those children have achondroplasia. Now it can be inherited as an autosomal dominant disease, but it occurs as a sporadic mutation in 75% of cases. Next, we have familial adenomatous polyposis. So this is where the colon becomes covered with adenomatous polyps after puberty, and it can progress to colon cancer unless those polyps are resected. So basically, these patients are going to have a colectomy or they're going to get colon cancer. Now, a mutation of the APC gene is responsible for this, and you can use the AD in adenomatous to help you remember it's autosomal dominant. Now, there are a few other genetically similar disorders that are associated with the APC gene mutation. So FAP is the first one, familial adenomatous polyposis. And then there's also what's called Gardner syndrome. Gardner syndrome is autosomal dominant. It presents with polyps in the colon as well, but also tumors outside of the colon. I think of kind of a gardener growing lumpy vegetables. I don't know, some crazy looking squash. Well, this is a syndrome where you grow lumpy and bumpy all over from a lot of different things. So Gardner syndrome will result in osteomas, in lipomas, in sebaceous cysts, colon polyps, and then colon cancer develops later in life as well. All right, so now we have another scenario. A 22-year-old man presents to the ER with chest pain and shortness of breath for the past hour. He has had progressively worsening dyspnea on exertion for the past several months. His ECG reveals ST segment elevation in multiple leads, and his troponin I is elevated. On exam, his heart rate is 110, respiratory rate is 25. He has yellowish papules on the medial side of each upper eyelid. What is the primary cause of this patient's myocardial infarction? Well, this is going to be familial hypercholesterolemia, and this is going to be type 2A hyperlipidemia. So the LDL becomes markedly elevated because of a defective or absent LDL receptor. It's not very rare to be heterozygous for this disorder, but homozygous is different. Patients will have LDLs above 300, Homozygotes, which are very rare, as I said, have excessively elevated cholesterol, so that LDL over 700 even. A very severe atherosclerotic disease very early in life. So these patients will have tendon xanthomas, xanthelasmas, that's that yellowish deposit of fat under the skin around the eyelids. And unfortunately, these patients will have potentially myocardial infarctions even before the age of 20. Moving on to hereditary hemorrhagic telangiectasia, also referred to as Osler-Weber-Rendu syndrome. So this is an inherited disorder that leads to abnormal blood vessel formation in multiple areas, the skin, mucous membranes, and in organs as well. So imagine what that might cause: telangiectasias, recurrent epistaxis, skin discolorations, AVMs, chronic GI tract bleeding as well. Now, a student suggested that we call it a Schnosler-Weber-Rendu to help remember that it causes a lot of nosebleeds. All right, another scenario. 25-year-old woman comes to the physician for fatigue and skin yellowing. She reports that she's been anemic in the past, but she's never felt this poorly before. She had a viral illness 1 to 2 weeks ago. On exam, her heart rate is 120, her skin is jaundiced, serum analysis shows hemoglobin of 8.1, a mean corpuscular volume of 85, and a mean corpuscular hemoglobin concentration of 39. And now an osmotic fragility test shows increased cell hemolysis. What's the diagnosis? It's one a little tricky. A little vague also because I left out the peripheral smear, which would actually just kind of give this away, which would show the round-shaped red blood cells. So this is going to be hereditary spherocytosis. So instead of having the normal biconcave shape of red blood cells, you have spheroid erythrocytes, and they're just kind of circular big fatties erythrocytes due to a spectrin or an ankyrin defect. Remember that, spectrin or ankyrin. Spectrin and ankyrin provide the structural framework of the red blood cell that allows it to have a biconcave shape and allows it to be kind of flexible and be able to move through capillaries. Well, if it can't do that, you're going to increase the viscosity of blood. So these sphere-shaped cells are also more prone to hemolysis. Therefore, it can result in hemolytic anemia and jaundice. The hemolysis can worsen with viral infections as well. MCV tends to be normal or slightly low, so that it's not much of a help for diagnosis. The MCHC is going to be elevated. So what is the MCHC? Well, it measures the concentration of hemoglobin in a given volume of red blood cells. Now, this elevation in the MCHC is reflecting membrane loss and red cell dehydration. Well, how do we take care of this potentially? Well, one reason why you have hemolytic anemia is because your macrophages in your spleen are identifying these red blood cells as abnormal and they're removing them from the circulation. So you can improve this by removing the spleen. And then these red blood cells are allowed to exist a little bit longer and the risk of anemia decreases. And how do we diagnose this in the first place? Well, the diagnosis is made by pretty easily by that hemolytic anemia, the spherocytes on the peripheral smear, and an abnormal osmotic fragility test. Now, these red blood cells are more susceptible to osmotic damage and osmotic induced lysis other than other biconcave normal red blood cells. So next, let's hit Huntington disease. So this is a neurodegenerative disorder that affects muscle coordination and also results in cognitive decline and psychiatric problems. So patients will have depression, progressive dementia, the core form, the very wild movements, and caudate atrophy. And also you're going to see a decreased level of GABA and acetylcholine in the brain. So you try to remember the C's of Huntington disease. That's how we're going to remember this. So they include cognitive decline, caudate atrophy, chorea, the CAG repeats. So this is a trinucleotide repeat disorder as well. And then we start to reach a little bit further after that. There's the C for chromosome 4, so chromosome 4, C for 40, which is the typical age of presentation, around 40, and then decreased acetylcholine is another way to remember that well. So we're stretching just a little bit. Remember all the C's for Huntington. And then we have Marfan syndrome. So this is a connective tissue disorder affecting the skeleton, heart, and eyes. Patients are tall, very long extremities, and this is due to a fibrillin gene mutation. Patients will present with pectus excavatum, hyperextensible joints, long fingers and toes, so we call that arachnodactyly. Patients may also develop cystic medial necrosis of the aorta, which can lead to aortic valve regurgitation, even aortic aneurysm and dissection. You also have a very floppy mitral valve, which can lead to mitral valve prolapse. Subluxation of the lens is pretty unique to this situation, and it's associated with Marfan. In the past, it was thought that there was an association between Marfan and Barry aneurysms, but new evidence suggests that's probably not so. Let's move on to the multiple endocrine neoplasia. So MEN, MEN1 or MEN2 are disorders that predispose patients to tumors of many of the hormone-producing glands in the body. Now, we cover this in more detail in the endocrine section. These are autosomal dominant, but let's hit them a little bit here. So MEN1 is associated with the MEN1 gene. MEN2A and then there's MEN2B. Those are associated with the RET gene mutation. So again, each of these will feature different tumors of the endocrine glands. And there's a kind of nice mnemonic here to remember the tumors that are associated with each of these. So with MEN1, think of PPP. So that's going to be for parathyroid adenomas. So you could actually get some hyperparathyroidism with that. Also, pituitary adenomas is the second P, and the third P is pancreatic tumors. And then there's MEN2A, so that's going to be PPM, so we're adding an M on this one. So it's going to be parathyroid adenomas, pheochromocytoma, and medullary thyroid cancer is the M there. And then the MEN2B is PMM, so we're replacing another P with an M. And that's going to be for pheochromocytoma, medullary thyroid cancer again, and then mucosal neuromas is the last one. Let's move on to neurofibromatosis type 1, also referred to as von Recklinghausen disease. So this is autosomal dominant again, and it's caused by a mutation of a gene on chromosome 17. So this gene is responsible for control of cell division. Without that control on cell division, we see tumors in the nervous system. Now, the symptoms include the café au lait spots, very, very important for this one, pigmented macules, and neural tumors. You also have what's called the Lisch nodules, which are pigmented iris hamartomas. And patients will also develop scoliosis as well. All right, so another clinical scenario. A 20-year-old man presents with hearing loss, tinnitus in both ears, decreased vision, and several hyperpigmented skin lesions. On exam, he has difficulty with cerebellar testing, he has bilateral cataracts, decreased hearing in both ears, and then you do see 4 hyperpigmented macules on the arms. What is the diagnosis? Well, the key to this one is the bilateral ear involvement. So this is actually neurofibromatosis type 2. And this can be associated with bilateral acoustic neuromas. So these are generally benign brain tumors in the region of the cranial nerve number 8. Therefore, you can expect patients to have a lot of hearing loss, tinnitus, balance problems. So it's associated with a mutation on chromosome 22. A good way to remember this one is that there are a lot of 2s. Neurofibromatosis type 2 on chromosome 22, and it's bilateral. Patients may also develop cataracts, other neurologic tumors, and cutaneous manifestations. Moving on to tuberous sclerosis. So this is a result of a mutated hamartin or tuberin gene. This results in non-malignant tumors in the brain and on other organs. Facial lesions are common, which are called adenoma sebaceum. Patients will have hypopigmented ash leaf spots on the skin. You can have cortical and retinal hamartomas, you can have seizures, you can have intellectual disability as well. It's also associated with cardiac rhabdomyomas and astrocytomas. A lot of stuff on this one. Next, we have von Hippel-Lindau disease. So this is, again, an autosomal dominant disorder that predisposes patients to multiple types of tumors. So patients will have hemangioblastomas of the retina, cerebellum, and medulla. About half of the affected individuals develop multiple bilateral renal cell carcinomas and other tumors as well. And one of the other tumors is going to be a pheochromocytoma as well. Now, it's going to be associated with deletion of the VHL gene, kind of fits with von Hippel-Lindau gene. Now, this results in expression, though, of something called HIF, and that's going to be a transcription factor that leads to activation of angiogenic growth factors, which is why you have all these hemangioblastomas. All right, so we're finally done with those autosomal dominant diseases. Let's move on to the trinucleotide repeat diseases, and there's 4 that you need to know about. First, there's Huntington, and we actually already mentioned this one earlier, and that's that CAG repeat disorder. We're not going to talk about it again. But remember, C for Huntington's has a lot of C associations. That CAG is the actual repeat. Myotonic dystrophy is another one, Fragile X syndrome, and then we have Friedreich's ataxia. So what do all of these disorders have in common? They have the 3 nucleotides that continually get repeated in the human genome. And for each generation, more and more of these repeats come about, and it causes lots of problems. Now, genetic anticipation is a result of this, and as a consequence, either the disease severity increases or the age of the disease onset decreases with a successive generation. So you get younger and younger when you start seeing symptoms.
All right, so let's go ahead and talk about Fragile X syndrome. So this is an X-linked disorder, and it's a trinucleotide repeat disorder. So the repeated 3 nucleotides are CGG. Now this is going to affect the expression of the FMR1 gene, and the way I remember this is I think FMR, fragile mental retardation, because Fragile X can cause mental retardation, or what we refer to now as intellectual disability. It's one of the most common causes of intellectual disability, but you need to take it to the next step. You need to know what the gene does, and it's a gene that codes for FMRP, which is a cytoplasmic protein found in the brain and in the testes, and it's involved in mRNA translation of axons and dendrites. It is the second most common cause of genetic intellectual disability, as we mentioned, and third most common overall. So fetal alcohol syndrome overall is the most common, Down syndrome, and then Fragile X syndrome. So findings, macroorchidism, so enlarged testes, which makes sense because we mentioned that FMR protein is found in the testes and again also in the brain. Patients might also have long faces with large jaws, large everted ears as well. Mitral valve prolapse is also common in this disorder. Let's move on to Friedreich ataxia. So what is Friedreich ataxia? This is an autosomal recessive disorder and again a trinucleotide repeat disorder. The repeated trinucleotides here are going to be GAA. Now with Friedreich ataxia, the gene that's problematic is the gene that codes for a protein called frataxin, which is a mitochondrial protein that deals with iron detoxifying and storage. Now the primary pathology is degeneration of sensory neurons, but it also causes hypertrophic cardiomyopathy and diabetes mellitus. Patients will have a staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, and hammer toes. Now this presents in childhood potentially with just kyphoscoliosis. All right, that's it. It's time for the end of session quiz. Try to answer those questions on your own, and then we'll go through them together. First question, what genetic defect is responsible for achondroplasia? Well, there's going to be a cell signaling defect of FGF, the receptor, which is that fibroblast growth factor receptor. Next, we have a genetic defect in which proteins result in hereditary spherocytosis. Remember that defect is going to mean those proteins spectrin or anchorin. So this defect causes spherocytosis and that hemolytic anemia. Next, what autosomal dominant disease fits each of the following statements? So a big review here. Associated with floppy mitral valve, dissecting aortic aneurysm, think of Marfan syndrome. Associated with mitral valve prolapse, liver disease, and Barry aneurysms is going to be autosomal dominant polycystic kidney disease. Neural tumors, pigmented iris hamartomas, that's going to be neurofibromatosis type 1. Very strong association with colon cancer. That's going to be that familial adenomatous polyposis coli, or FAP. Remember, it's that APC gene mutation. MI before age 20, that's going to be familial hypercholesterolemia. Hemangioblastoma of the retina, cerebellum, and medulla, that's going to be the von Hippel-Lindau. Increase MCHC in hemolytic anemia. Again, think about hereditary spherocytosis. Bilateral acoustic neuroma, so you're going to have that hearing loss. That's going to be a neurofibromatosis type 2. Facial lesions, seizure disorder, and increased cancer risk. Think of tuberous sclerosis. Caudate atrophy and dementia. Remember all the C's of Huntington disease. Cystic medial necrosis of the aorta. That's going to be Marfan syndrome again, and that can lead to aortic dissection. And then a defect of fibroblast growth factor receptor 3, achondroplasia. All right, next question. What are some of the disorders resulting from trinucleotide repeats? So there's Huntington disease, which is a CAG nucleotide repeat disorder. We also have Fragile X syndrome, Friedreich ataxia, and then myotonic dystrophy. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time.
This is the warm-up for Reproduction 16. First question, what are the defects in tetralogy of Fallot? So you have pulmonary valvular stenosis, right ventricular hypertrophy, a VSD, and an overriding aorta. The opening of the aortic valve kind of sits right over the VSD. Next, what's the defect in Epstein anomaly? So Epstein anomaly, again, is going to be seen in babies who are born to mothers taking lithium. Epstein anomaly is that the tricuspid leaflets are displaced downward into the right ventricle, and then the right ventricle is usually hypoplastic and there can be some tricuspid regurgitation or tricuspid stenosis. Next, which antibiotic class is known to increase the risk of tendon rupture in adults? It's the fluoroquinolones. All right, let's get started with the lecture.
Hello everyone and welcome to our Step 1 video on genetic diseases. This one's covering autosomal recessive, lysosomal storage, and X-linked. No intro today because I'm hungry, and the sooner I get done with this video, the closer I am to a sweet, sweet sandwich. What? Rule number 3 of medicine is never miss a meal. All right, so let's get started on our autosomal recessive diseases. So this video is going to cover some of these. Many of these are actually covered in other lectures in this course, so we won't spend an exhaustive amount of time with each one. So we're really just going to be hitting this super high yield highlights, and even just some of them, not all of them. So the first one we really need to cover is cystic fibrosis. Again, an autosomal recessive defect in the CFTR gene in chromosome 7. CFTR stands for cystic fibrosis transmembrane regulator. So what does the CFTR gene code for? Well, it codes for a transmembrane protein that puts chloride from the cell into the lumen of the pancreatic ducts and into the lumen of your airways. So if you look at this transmembrane protein, it's secreting that chloride into the lumen side. So you wouldn't think that that's such a big deal, but where chloride goes, sodium is probably going to follow to balance out the charge. And then where sodium chloride goes together, water is going to follow. So normally, sodium and chloride are going into the lumen of your airways, into your pancreatic ducts, and that's going to allow for a watery, thin secretion. Well, if you can't put chloride in, the sodium's not going to follow and the water's not going to follow, so you get very thick, very viscous secretions in your airways and in your pancreatic ducts. And they get all clogged up, and that causes a lot of problems. Now, the CFTR channel actively secretes that chloride into the lungs and the GI tract, actively reabsorbs chloride from sweat. Now, as a result, patients will get recurrent pulmonary infections. And also what you need to know, Pseudomonas is famously associated with cystic fibrosis. So you're also going to see bronchiectasis. You're also going to see pancreatic insufficiency and also meconium ileus in newborns. So this is one of the earliest signs of cystic fibrosis, and this is the most common lethal genetic disease of Caucasians. So going back to this, what is meconium ileus? Well, meconium is that first stool that a baby passes, really nasty black looking stuff. And if they don't pass that first stool within, on average maybe 48 hours, that might actually indicate a problem. Cystic fibrosis is a possibility, but Hirschsprung disease is another disease that's going to be associated with meconium ileus in that newborn. Other findings include infertility in males, and this is due to another association, a bilateral absence of the vas deferens. You're also going to have fat-soluble vitamin deficiencies, and that can present as failure to thrive. Also, because you don't reabsorb chloride from sweat, patients will actually taste salty. So maybe a mom tastes salt every time she kisses her baby. So how do you diagnose this? Well, you can diagnose this with that chloride sweat test. The increased concentration of chloride ions in the sweat test is diagnostic. Now, specifically, the chloride ions are greater than 60 milliequivalents per liter. So how do we treat cystic fibrosis? Well, we don't have a lot of great treatments. We can use something like N-acetylcysteine to loosen up mucus plugs. We're not using it as much as we used to. This is an inhaled medication. It cleaves to disulfide bonds within the mucus glucoproteins. You may also recognize that N-acetylcysteine as a potential antidote to acetaminophen toxicity. Patients will need antibiotics anytime they get bronchitis or some type of lung infection. Most of the time, we don't use a lot of the fluoroquinolones in kids. But the exception here is cystic fibrosis. A lot of times, children with cystic fibrosis have to be put on a fluoroquinolone for Pseudomonas infections. Pancreatic enzyme replacement is also important because their pancreas doesn't function very well. And fat-soluble vitamin replacement is also very important in this group. All right, so now let's move on to some lysosomal storage diseases. These are always really, really tough. So what is a lysosomal storage disease? So these are rare and are generally due to a deficiency in an enzyme that is required for the metabolism of a lot of different things like lipids, things like glycoproteins, things like mucopolysaccharides. So if you can't break something down, then you end up with an accumulation of something you probably don't want. And that's where we have our problem. Too much garbage or back product is building up. So let's go through these. All right, so our first lysosomal storage disease is Fabry disease. So this is an X-linked disease. Now, the deficient enzyme is the alpha-galactosidase, and it leads to an accumulation of ceramide trihexoside. So the symptoms begin in early childhood, and they include pain primarily. This is due to damage of peripheral nerves. That's going to lead to some neuropathy. You're also going to get some lipid accumulation in the GI tract, and that's in those blood vessels of the GI tract, and that's going to lead to ischemia and also pain. You're also going to see some renal failure. You're going to see some hypertension and cardiomyopathy. You also get something called angiokeratomas. Those are kind of be tiny but painless papules. They can appear primarily around the lower abdomen, in the buttock area, and in the groin area as well. All right, so our next disease is called Gaucher disease. Sometimes people mistakenly call it Gaucher disease, but it's Gaucher. So this is an autosomal recessive disease, and this is the most common of the lysosomal storage diseases. Now, the enzyme deficiency here is glucocerebrosidase, and patients will accumulate the glucocerebroside, which is a lipid-like substance, which can then build up in macrophages, also in the spleen, and the liver, and the kidney, and the lungs, and the brain, and the bone marrow. So a lot of different places. Patients will develop hepatosplenomegaly. They're going to have painful bony lesions. They're going to have anemia. They're going to have fatigue. They're also going to have thrombocytopenia. That's due to an enlarged spleen. Now, under the microscope, macrophages will have prominent blue cytoplasmic fibrils. Some have described these macrophages as looking like they kind of have crumpled tissue paper. The next thing we're going to talk about is Niemann-Pick disease. So this is an autosomal recessive disease again, and the deficient enzyme is sphingomyelinase. So you're going to accumulate sphingomyelin. Now again, this is a lipid-like substance. So like in Gaucher's disease, we see hepatosplenomegaly and thrombocytopenia. Niemann-Pick has a lot of accumulation in the CNS, including the cerebellum, which leads to ataxia, dysarthria, and dysphagia. Patients will have a gradual worsening of intellectual function as well. Now, a high-yield characteristic of Niemann-Pick is that cherry red spot on the macula, which is also caused by an accumulation of substrate in the cell layers of the retina around the macula. Also somewhat unique to Niemann-Pick are the foam cells. So under the microscope, we see numerous small vacuoles which give that cytoplasm kind of a foamy-looking appearance. So next, let's talk about Tay-Sachs disease. So Tay-Sachs is an autosomal recessive disease, and the deficient enzyme is hexosaminidase. Now, you're going to see an accumulation of the GM2 ganglioside here. Now, as with many of these disorders, patients will have progressive worsening of mental and physical abilities. Now, in the infantile type, symptoms begin very early in life at around 6 months. Death generally occurs at the age of 4 years. Now, there are other forms of Tay-Sachs where the onset of symptoms can be much later in life. Now, similarly to Niemann-Pick, we see the cherry red spot of the macula in Tay-Sachs. Now, it can actually be kind of difficult sometimes to differentiate Tay-Sachs from Niemann-Pick on a step 1 question. Now, one clue is that there is no hepatosplenomegaly in Tay-Sachs patients, but there is going to be that hepatosplenomegaly in patients with Niemann-Pick disease. Now let's move on to Krabbe disease, great name. So this is an autosomal recessive disease again. The deficient enzyme here is galactocerebrosidase, and you accumulate galactocerebroside. Now this disorder affects the myelin sheath, which will lead to peripheral neuropathy, seizures, optic atrophy, weakness, and developmental delay. Now, symptoms begin early again at the age of maybe about 3 to 6 months and is fatal usually before the age of 2 years. Now, this may not help you, but Krabbe makes me think of Zoidberg from the show Futurama. He was kind of a lobster dude from space, which makes me think of that galactic, which reminds me of the galactocerebroside. Moving on to the metachromatic leukodystrophy. So this is an autosomal recessive again. The deficient enzyme here is aryl sulfatase, and you accumulate a cerebroside sulfate. Now, similar to Krabbe, this affects myelin sheaths. Symptoms begin after the first year of life, so a little bit later here. Patients have muscle wasting, they're going to have a lot of weakness, progressive vision loss, and even dementia. Moving on to Hurler syndrome. So this is, again, autosomal recessive. Now, the deficient enzyme here is alpha-L-ironidase, and the buildup is in heparan sulfate and dermatan sulfate. Now, these patients are normal at birth, but like many of the other diseases, we see progressive deterioration. Coarse facial features is another one, hepatosplenomegaly, and intellectual disability starting at about 6 months of age. Now, these patients do not grow very well, which leads to something that resembles dwarfism. Now, because of the coarse facial features and the other characteristics, this is sometimes referred to as gargoylism, which is pretty crude and somewhat cruel to describe people like this, but that kind of gives you an idea of coarse facial features in short stature. Now, these patients will also get corneal clouding, which will lead to vision loss. Now, there are two lesser forms of Hurler syndrome, and they are called Hurler-Scheie syndrome and then just Scheie syndrome. So they have the same enzyme deficiency, and they tend to have a later onset of symptoms. Next, we have Hunter syndrome. So this is an X-linked one. So remember, we have two X-linked lysosomal storage diseases that we're talking about, Hunter and Fabry. Now, one way to remember this is that X marks the spot for Hunter's. Now, the deficient enzyme is iduronate sulfatase, which results in an accumulation of heparin sulfate and dermatan sulfate. Now, that should look pretty familiar because it's the same substrates for Hurler syndrome, but realize that the enzyme deficiency is different from Hurler. Now, Hunter syndrome is generally speaking just a milder form of Hurler syndrome. Now, there is a later onset where the symptoms begin between the ages of 1 and 2 years, and there's no corneal clouding with this one. And these patients also tend to have more aggressive behavior as well. All right, guys, it's time to hit the high-yield characteristics that will differentiate these diseases in an episode of Game Show. Remember to yell out the answers. You may want to stop the video in between each one and write these down to review them again later because this stuff is really hard. Let's get started. First one, optic atrophy, myelin sheath involvement, galactocerebrosidase deficiency. Answer, Krabbe disease. Next, renal failure, angiokeratomas, alpha-galactosidase deficiency. The answer, Fabry disease. Next, dwarfism, corneal clouding, alpha-L-iduronidase deficiency. That's going to be Hurler syndrome. Next, we have thrombocytopenia, macrophages with cytoplasmic fibrils, glucocerebrosidase deficiency. The answer, Gaucher disease. Next, cherry red spot on the macula, no hepatosplenomegaly, hexosaminidase A deficiency. Answer, Tay-Sachs. Next, aggressive behavior, no corneal clouding, iduronate sulfatase deficiency. The answer, Hunter syndrome. Next, we have progressive vision loss and dementia, similar to Krabbe, aryl sulfatase deficiency, metachromatic leukodystrophy. Next, cherry red spot on the macula, foam cells, sphingomyelinase deficiency. The answer, Niemann-Pick disease. Okay, so now we're going to very briefly talk about some X-linked recessive disorders. So what is an X-linked recessive disorder? Well, the mutation is on the X chromosome. Therefore, even though the disorder is recessive, males who get one effective X chromosome will actually express the gene because they only have one X chromosome. Now, females will need 2 affected X chromosomes for the gene to be expressed. So the X-linked recessive disorders include a lot of things. Bruton's agammaglobulinemia, Wiskott-Aldrich syndrome, Fabry syndrome, G6PD deficiency, ocular albinism. Now realize that general albinism is actually an autosomal recessive disease, but just the ocular albinism is X-linked. Lesch-Nyhan syndrome, Duchenne and Becker muscular dystrophy, Hunter syndrome, hemophilia A and B. Now we covered a couple of these in this lecture, and then the rest are actually covered in other lectures in a lot more detail. So for this lecture, all I want you to do is remember that these are all X-linked recessive disorders, and we have a mnemonic that we're going to use for this. So it's oblivious female will give her boys her X-linked disorder. So that's for ocular albinism again, Fabry disease, Wiskott-Aldrich, G6PD deficiency, Hunter syndrome, Bruton agammaglobulinemia, hemophilia A and B, Lesch-Nyhan syndrome, and Duchenne muscular dystrophy. So you can kind of pull that all together with that mnemonic there. All right, guys, that brings us to the end of the lecture part. It's time for that end of session quiz. Try to answer those on your own, and then we'll go through them together. First question, what gene is defective in cystic fibrosis? So remember, in cystic fibrosis, it's that CFTR gene, and where is it? It's on chromosome 7. Next, what is the traditional test used to diagnose cystic fibrosis? Remember, it's that sweat chloride test. So when the concentration of the chloride ion exceeds 60 milliequivalents per liter, this is diagnostic for cystic fibrosis. Next, what two diseases can present with a cherry red spot on the macula? So remember, it was Niemann-Pick and it was Tay-Sachs. Next, which lysosomal storage disease has prominent blue cytoplasmic fibrils that resemble crumpled tissue paper? Remember, that was the Gaucher disease. Next, which two lysosomal storage diseases have myelin sheath pathology leading to peripheral neuropathy? Remember, that's the Krabbe and also the metachromatic leukodystrophy diseases. All right, guys, that brings us to the end of our video. I hope you learned something. I'll see you next time. It's time for another warm-up review. Let's get going. Describe the changes seen in serum calcium, serum phosphate, alkaline phosphatase, and PTH in each of the following diseases. So first we have primary hyperparathyroidism. So what does that start with? Well, this starts with elevated PTH. Elevated PTH is going to raise serum calcium, which will trash the phosphates and will raise the alkaline phosphatase level. Next, what about Paget's disease of bone? So this has nothing to do with PTH, but you have increased bone turnover. So you're going to raise your alkaline phosphatase. Vitamin D toxicity. So this is going to result in increased absorption of calcium. So the serum calcium will be increased. Now, as a consequence, PTH is going to go down. And as a consequence of that, you're not going to be trashing that phosphate, and the phosphate will go up as well. The alkaline phosphatase will be unchanged or normal. Next, what roles do Leydig cells and Sertoli cells play in male spermatogenesis? So Leydig cells are stimulated by LH and they produce testosterone. Now Sertoli cells are stimulated by FSH and they provide support like nourishment to the developing spermatozoa. Next, what is the mechanism of action of sildenafil? So sildenafil is a phosphodiesterase inhibitor. So it inhibits cyclic GMP phosphodiesterase, which causes an increase in that cyclic GMP. And that leads to relaxation of smooth muscle, and specifically smooth muscle in the corpus cavernosum. Now all of this leads to increased blood flow and erection. All right, that's it for the review. Let's get to the video.
In this video, we're talking about breasts and breast pathology. Eyes up here. We reviewed basic breast anatomy and physiology in the video on the female reproductive cycle, and we discussed the roles of prolactin in stimulating milk production and oxytocin in stimulating milk ejection. But there is one important breast pathology related to breastfeeding, which is acute mastitis. Mastitis is basically an infection of the breast, usually due to Staph aureus. Breastfeeding leads to cracking of the nipples, which allows the bacteria to enter. And that leads to cellulitis, which can progress to an abscess. So clinically, you'll see redness, pain, and potentially some fever. And you can sometimes treat mastitis and cellulitis with antibiotics. But if you feel a fluctuant mass under the skin that makes you suspect an abscess, the next step would be to do an ultrasound of the breast to confirm the diagnosis of an abscess, and then needle aspiration to drain the abscess or surgical drainage if necessary. It's important to remember that we want to keep breastfeeding during mastitis. The bacteria in the milk aren't dangerous for the infant. And if a woman has opted not to breastfeed, she needs to keep pumping because that helps to clear that infected fluid out of the breast. Let's briefly discuss gynecomastia, which is the development of breast tissue in men. A lot of different things can cause gynecomastia, especially things that result in high estrogen levels. You can see gynecomastia in infancy and in the elderly, and especially in puberty, when up to 70% of adolescent boys can have some transient gynecomastia. Testicular tumors can raise estrogen levels, and so can cirrhosis. And you can see gynecomastia and Klinefelter syndrome, also from a bunch of different drugs. And this is probably the highest yield thing about gynecomastia for your test. So they might give you a patient with gynecomastia and ask, which of the following drugs is most likely the cause? There are several mnemonics for the drugs that cause gynecomastia. The one I like is STACT, even though it's not the most PC mnemonic around. The S is for spironolactone. T is for THC, so marijuana can cause gynecomastia. The A is alcohol, specifically chronic alcohol use. The C is the H2 blocker cimetidine. K is ketoconazole, and the E is for estrogens, which should be pretty obvious that if a man is taking estrogens, that could lead to some breast development. And the D is digoxin. Now, let's talk about some benign breast conditions before we get to breast cancer. In your study guide, there's a list of benign epithelial lesions, which we divided into proliferative changes and non-proliferative changes. We're going to talk about the non-proliferative changes first, which are sometimes called fibrocystic changes, or it used to be called fibrocystic disease, but now we just talk about it not being a disease, but just being a benign change in the breast tissue. It's really just an increase in benign fluid-filled cysts and fibrous tissue. So it's fibrocystic. But the key feature is that it's non-proliferative, despite what you may see in some review books. There is no proliferation of cells, so we classified this as non-proliferative. Non-proliferative changes are the most common cause of breast lumps in women ages 25 to about 50 when menopause happens. And the reason that they become less common after menopause is that these fibrocystic changes fluctuate with hormone levels. Clinically, these patients present just before their periods complaining of breast pain and multiple bilateral breast lesions. Again, these are hormone sensitive, and these changes fluctuate in size over the course of the menstrual cycle. They tend to be worst just before menstruation, and then it regresses somewhat after the period is completed. So if a young woman comes in complaining of a breast lump, and you examine her and suspect that this is non-proliferative fibrocystic change, you might just re-examine it about a week after her period is completed, when it's going to be the smallest. True breast tumors don't change with the menstrual cycle. They stay relatively stable in size. So in the study guide, you see that there are two basic histological findings in these non-proliferative fibrocystic changes: fibrosis and cysts. The fibrosis we're talking about, hyperplasia of the breast stroma, the connective tissue. These are not neoplastic tumors. They are just areas of dense hyperplastic breast stroma. And then the cysts are fluid-filled cavities that look bluish in color. So they are called blue dome cysts. Here we see a gross specimen of fibrocystic change, and you can see cystic cavities, including this, which is vaguely bluish, I guess, and the rest of the lump is just dense fibrous connective tissue. The other thing to mention is that these non-proliferative changes can sometimes be caused by caffeine or dietary fat. So if women are really symptomatic with cyclical pain from these changes, decreasing their caffeine intake can really help with their symptoms. Then the next group of bullets are the proliferative changes without atypia. So these have proliferation of cells, but there are no atypical cells. These aren't precancerous. The first one of these is sclerosing adenosis. Adenosis means increased glandular tissue or increased acini. The acini are so increased that they become compressed and distorted inside of the lobule, and this leads to intralobular fibrosis, which is what sclerosing refers to. The adenosis leads to sclerosis, and there can be some calcifications which can be suspicious for cancer on the mammogram. But again, this is completely benign. The next one is epithelial hyperplasia, where you have an increase in the epithelial cell layers in the terminal duct of the lobule. There's also a complex sclerosing lesion, which is sometimes called a radial scar. It's a scar with an irregular shape that can look like invasive cancer on mammogram. It looks like fat necrosis. Fat necrosis is where you have some injury to the breast and the fat tissue dies and becomes necrotic, and that leads to a painless lump. A radial scar looks similar on mammogram, but there's no prior history of breast surgery or breast trauma. And then the last type of benign proliferative change I want to mention is fibroadenoma. These used to be classified as non-proliferative, but that's no longer the case. A fibroadenoma is actually cellular tumor. This is one of 3 types of benign breast tumor that I want to talk about: fibroadenoma, intraductal papilloma, and a phylloides tumor. Fibroadenomas are the most common breast tumor in women under 25. It's a small, firm mass with regular edges, and it's not adherent to anything, so it's mobile. And it can increase in size with estrogen exposure, so it will get larger and maybe more tender with pregnancy and with menstruation. But it's not a precursor to breast cancer. Histologically, you see a proliferation of stroma, but this time it's cellular stroma that squeezes the purple glandular elements until they become compressed and elongated. The second type of benign breast tumor is intraductal papilloma, which is a very small tumor that's found inside of the lactiferous ducts, beneath the areola. It's intraductal inside the ducts, and it creates either a serous or bloody nipple discharge. It's the most common cause of a fluid discharge from the breast other than milk. So if they give you a patient with a straw-colored nipple discharge or a slightly bloody nipple discharge, think about an intraductal papilloma. And this one carries a very, very tiny increase in the cancer risk. And our third benign tumor is a phylloides tumor. Instead of being a small tumor, this is a large, bulky tumor with leaf-like projections on histology. That's the key term for your test, leaf-like. Phylon is the Greek word for leaf, and you might remember leaves have chlorophyll, phylloides tumor. I'm not sure who decided this looks leaf-like, but that's the classic description. What I see are well-defined projections of tissue with lots of inlets, almost like fjords. And at higher magnification, these projections are lined with purple epithelial cells. But if they use the phrase leaf-like, think phylloides tumor. Phylloides tumors are more common in women in their 50s, and generally these are benign, but occasionally they can become malignant. Now let's talk about malignant breast tumors, or breast cancer. Definitely important USMLE and COMLEX. Breast cancer is the most common cancer in women, and it's the second most common cause of cancer death after lung cancer. And is breast cancer more common in younger women or older women? Older women, post-menopause. That's why we start mammograms at age 40. The most common location of breast cancer is the upper outer quadrant of the breast, near the axilla. And the single most important prognostic factor is whether or not the lymph nodes are involved at the time of diagnosis. There are several important risk factors for breast cancer, but the main one is estrogen exposure. The more menstrual cycles a woman goes through, the higher her risk of breast cancer. So, an early menarche or late menopause are risk factors. Fewer pregnancies and less time breastfeeding are risk factors. Older age at the time of first live birth increases the risk of breast cancer, and obesity will increase the risk as well because the peripheral conversion of androgens to estrogen in adipose tissue. Family history of breast cancer is also important, and certainly a history of BRCA gene mutations or HNPCC. It's common to find an overexpression of estrogen and progesterone receptors in breast cancer tissue, as well as the HER2/neu receptor, which is the ERB2 gene. The presence of these receptors gives us targets for chemotherapy to attack those cancerous cells with drugs like tamoxifen, which binds to estrogen receptors, or trastuzumab, which binds to HER2/neu receptors. There are 2 basic types of breast cancer, ductal and lobular. Ductal breast cancer arises from the duct epithelium, and lobular breast cancer arises from the lobules, from the glands. Let's talk about some specific details about the different types of breast cancer. First, let's cover breast carcinoma in situ, which makes up about 15 to 30% of breast cancer. In situ means that the cancer cells are still situated where they arose. They haven't broken through the basement membrane and started invading locally yet. So again, if our 2 big breast cancer subtypes are ductal and lobular, we can talk about ductal carcinoma in situ and lobular carcinoma in situ. Let's talk about ductal carcinoma in situ. We abbreviate this as DCIS, and it's also called intraductal carcinoma. It's intraductal. It is contained within the duct and hasn't broken through yet. It arises from ductal hyperplasia, and then the cancer cells fill the lumen of the duct, but there's no penetration of the basement membrane. That's what keeps it from being invasive cancer. There are 5 different morphologic subtypes of DCIS. The first of these is cometacarcinoma, which is characterized by central necrosis. After that, you have solid, cribiform, papillary, and micropapillary. There's also something called Paget disease of the breast, which is technically not a subtype of ductal carcinoma in situ, but it's a way that DCIS can present. With Paget disease, you see eczema-like patches on the nipple and areola, which suggests an underlying carcinoma. Microscopically, you see cancer cells interspersed within the epidermis, and on higher magnification, the cancer cells are surrounded by a clear halo. But the real issue is that Paget disease is often associated with underlying DCIS. So if you see Paget disease, you need to evaluate further for underlying cancer. The other type of carcinoma in situ is lobular carcinoma in situ, or LCIS, which is characterized by signet ring cells. A signet ring cell is a cell that's filled with mucinous material, which pushes the nucleus to the periphery so that it looks like a signet ring, a ring that's thicker on one end, kind of like a class ring. We also see signet ring cells in Krukenberg tumors, which is a gastric adenocarcinoma that metastasizes to the ovary. LCIS is basically always ER and PR positive. There may be a rare exception now and then, but in general, these are always ER and PR positive. Remember that for your test. And again, hormone receptors are useful because they give us targets for treatment. LCIS is a risk factor for lobular carcinoma, but it's not clear that these LCIS tumors actually progress to invasive carcinoma. With DCIS, those cancers eventually do break through the basement membrane, and they do become invasive. So when you find DCIS, you want to remove that tumor because if you leave it alone long enough, it can transition into carcinoma. But with LCIS, it's not that necessarily the case. You don't have to take out those cells because even if you do, the chance of getting sporadic lobular carcinoma in other parts of the breast is still really high, even in the contralateral breast. That's why these patients consider mastectomy or tamoxifen to try to prevent invasive cancer in the future. Now, let's get into the invasive breast cancers. The first type is invasive ductal carcinoma. This is by far the most common type of invasive breast cancer. It makes up 75 to 80% of invasive breast cancers. It's the most common and unfortunately the most invasive. It arises from DCIS and it's a firm, rock-hard mass with sharp margins. So it can feel a lot like a fibroadenoma, which is why biopsies are so important. One difference between these two is that fibroadenomas are mobile and invasive cancers tend to be attached to other tissues, so they are fixed and immobile. On biopsy, the histology is very heterogeneous. But one very recognizable feature is this stellate or star-like border of the tumor. The next one on our list is invasive lobular carcinoma. This type of cancer can be multiple and bilateral. It's associated with inactivation of the E-cadherin genes, and generally it's ER and PR positive. And on histology, you'll see those signet ring cells again. Another classic histologic finding of invasive lobular carcinoma is that tumor cells tend to line up in little single file rows. Be sure you can recognize that. Ductal carcinoma and lobular carcinoma are the two most important types of invasive breast cancer to know for your test, but just for completeness, we've listed several other types. Medullary carcinoma is a fleshy cellular mass with lymphocytic infiltrates. Then there's tubular or cribiform carcinoma, mucinous carcinoma, papillary carcinoma, and metaplastic carcinoma. And then I want to briefly call your attention to inflammatory carcinoma. This isn't really a subtype of invasive carcinoma, but it's a way that invasive carcinoma might present. Inflammatory carcinoma occurs when you have cancer that invades the dermal lymphatics and it leads to visible inflammatory changes. Signs of inflammatory breast cancer may include peau d'orange, which is the orange peel texture to the skin, which comes about because of lymphatic obstruction, and to lymphedema, which causes the skin to thicken. You can see focal dimpling of the breasts because of cancer that involves the suspensory ligament of the breast. You can also have nipple retraction. Now, some women have nipple retraction at baseline, and that's okay. But if there's a change with new nipple retraction late in life, you have to worry about some ductal involvement, pulling the nipple in. Let's also talk briefly about a couple of classes of medications used to treat breast cancer. The first class is the SERMs, or selective estrogen receptor modulators like tamoxifen and raloxifene. These are drugs that bind to estrogen receptors, but they have either agonist or antagonist properties in different tissues, which is why they are called selective estrogen receptor modulators. And each one of the SERMs has its own unique profile of where it acts like an estrogen receptor agonist and where it acts like an estrogen antagonist. Tamoxifen is the classic one used for breast cancer. It's an estrogen antagonist in breast tissue. So if we have an estrogen receptor positive breast cancer, if we can use tamoxifen, it will block the stimulatory effects of estrogen on that cancer. We use tamoxifen to treat primary breast cancer. We also use it to prevent recurrence of estrogen receptor positive breast cancer, and we use it for primary prevention in some high-risk women. Remember, LCIS is one situation where you might use that, but the problem with tamoxifen is that it's an estrogen agonist in endometrial tissue, so we have to watch out for increased risk of endometrial cancer. Raloxifene is another SERM, and it has a unique profile. It's an estrogen agonist in bone, and it's primarily used for osteoporosis. It reduces bone resorption, so it helps with osteoporosis. And it's also an antagonist in the breast, so it can sometimes help with breast cancer as well. But it doesn't cause an increased risk of endometrial cancer like tamoxifen does because it's not an estrogen receptor agonist in the uterus. And then another category of medicines would be the aromatase inhibitors like anastrozole. Anastrozole inhibits the production of estrogen by inhibiting the enzyme aromatase, which is an important step in the conversion of androgens to estrogens. We use anastrozole in postmenopausal women with breast cancer. They have low levels of estrogen anyways, but anastrozole decreases the estrogen levels even further. The problem is that this low estrogen also affects the bones, so it increases the risk of osteoporosis and fractures. Now let's pause and work through the end of session quiz, and we'll go over the answers. Let's get going. First question, what are some of the causes of gynecomastia? Hyperestrogen states like puberty, cirrhosis, testicular tumors, Klinefelter syndrome, and drugs. Remember the mnemonic STACKED. Spironolactone, THC or marijuana, chronic alcohol use, cimetidine, ketoconazole, estrogens, and digoxin. Next, what organism is most commonly responsible for acute mastitis? This is usually caused by Staph aureus. Next, what is the classic presenting complaint in a patient with intraductal papilloma? Straw-colored or yellowish nipple discharge that may or may not also be bloody. Next, what breast pathology fits each of the following descriptions? The most common breast tumor in women under 25 is a fibroadenoma. The most common breast mass in a postmenopausal woman is invasive ductal carcinoma. The most common breast mass in premenopausal women, that's a non-proliferative change, fibrocystic change. The most common form of breast cancer, again, that's invasive ductal carcinoma. A small, mobile, firm mass with sharp edges in a 24-year-old woman. The only thing you really have to go on here is her age. Young woman, think fibroadenoma. Histological leaf-like projections, that's a phylloides tumor. Signet ring cells, that's LCIS, most commonly lobular carcinoma in situ, but those cells can also be seen in invasive lobular carcinoma. Loss of E-cadherin cell adhesion gene on chromosome 16. That's both LCIS and invasive lobular carcinoma. Always ER positive and PR positive, same thing. Both LCIS and invasive lobular carcinoma. Commonly presents with nipple discharge. That's the intraductal papilloma. Eczematous patches on nipple. That's Paget disease. Whenever you see problems with the nipple and the areola, think about Paget disease. Multiple bilateral fluid-filled lesions with diffuse breast pain. That's non-proliferative fibrocystic change. And the last one is a firm fibrous mass in a 55-year-old woman. This is most likely cancer. And the most common breast cancer is invasive ductal carcinoma. And our last question says, a 58-year-old postmenopausal woman is on tamoxifen. This medication increases her risk of developing what condition? Endometrial cancer. That wraps up the quiz, but we also have some rapid-fire facts to go over. The most common cancer in women in the U.S. is breast cancer. The most common benign breast tumor is a fibroadenoma. And the most common malignant breast tumor is infiltrating ductal carcinoma. A blue dome cyst in the breast should make you think of fibrocystic change. The treatment for ER-positive breast cancer should include tamoxifen. And finally, red, itchy, swollen rash on the areola and nipple. Again, anytime they start talking about the areola and nipple, think about Paget disease. That's it for this video. Okay, you guys, that's all for me. I've enjoyed going over this material with you. Best of luck on your test.